Hold 2 ഇട്ടാ മതിയായിരുന്നു. ഇത് റീനെയിം ചെയ്യാൻ പറ്റും. കാണിക്കണം. എന്റെ പേര് മാറ്റാൻ പറ്റും. എവിടെ ചേച്ചിന്റെ പേര് മാറ്റാൻ പറ്റും. മാം ഞാൻ ഹോൾഡ് 2
Hello. Hello. Hello.
Hello.
Hello. Hello. Hello. Hello.
Ashish sir,
Can you hear?
okay.
Dr. Atmaja, can you hear me?
Yes sir, yes sir.
Okay, we can start at 9 o'clock. Now 9 o'clock. Hello.
I think Anuna madam.
First participant should start at 9 a.m.
Hello.
Hello.
Sir, shall I start?
Yes, yes, we can start.
Good morning, one and all. Today I'll be presenting a case on unicystic ameloblastoma. A 17-year-old male reported with a chief complaint of swelling in the lower front tooth and the jaw region for the past 1 month with associated pain while swallowing. History revealed that the swelling initially was small, began as an asymptomatic enlargement of the lower jaw. It slowly progressed over the past several days to attain the present size. The patient gave a history of trauma in the lower front region of the jaw that was associated 2 years ago while he was playing cricket. There was rearrangement of the front teeth that was noted by the patient. In the past surgical history, patient underwent surgery for a left hand fracture 6 years ago while playing cricket. It was the patient's first dental visit. Personal history: patient had a mixed diet. He had a regular bowel and the bladder movement. Appetite was regular. Sleep was adequate. Or in the oral hygiene habit, patient brushes his teeth once daily in the morning with a toothpaste and a soft type of toothbrush. In the general examination, there was no abnormality that was detected. The vital signs were within the normal range. In the extraoral examination, however, there was a facial asymmetry that was observed on the right side. The submandibular lymph node was tender and palpable ipsilaterally. Here we can see on inspection, a diffuse smooth surface swelling was seen over the chin region in the lower third of the face on the right side. It was measuring about 30 by 20 mm. The swelling was observed in the right parasymphysis region, extending from the level of the angle of the mouth till the lower border of the mandible that was crossing the midline. The superior inferior extensions were from the lower border of the lower lip till the base of mandible, and in the anterior posterior from the midline to the commissure region. On palpation, the swelling was smooth, febrile, and non-tender. The skin was shiny, whitish red in color, and non-pinchable. In the intraoral examination, we can see there was a labally placed maxillary right canine. There was rearrangement of the lower right anterior teeth. Class 2 driven malocclusion was seen. The lower right lateral incisors showed displacement. Grade 1 mobility was seen with the lower right and the left anterior teeth, along with the lower right first premolar. These teeth were tender on percussion. The swelling was round, smooth, and oval in shape. It was poor, non-tender, and non-fluctuant. There were smooth margins that were noted. Obliteration was observed from the medial surface of the lower right premolar till the distal surface of the lower left lateral incisors. There were calculus deposits that were noted on the right lateral incisors and the canine. Based on these observations, a provisional diagnosis of infected radicular cyst was considered, and a differential diagnosis of benign odontogenic tumor was considered. The investigations that were carried were as follows. In the routine examination, we had done the pulp vitality test for the hard tissue examination, where the lower right anterior teeth with the first premolar were vital and the left mandibular anterior teeth were non-vital. On the cytological technique that was used was fine needle aspiration cytology, wherein the aspirate showed a straw color fluid. Based on these observations, it was sent for a protein estimation, where the protein estimation was about 2 grams. Based on the typical appearance of the swelling, other investigations that were carried were occlusal radiograph was taken to see the two-dimensional view. In the occlusal radiograph, there was a multilocular radiolucency that was observed in the lower anterior region. It extended from the medial surface of the lower left canine to the distal surface over the lower right first premolar. There was a thinning of the cortex in the buccal to lingual plane. The size of the lesion was approximately 30 by 20 mm. There was internal septa that were noted from the left premolar to the right to the lateral incisors that gave a soap bubble appearance. Displacement of the tooth in the lower right lateral incisor was also seen that gave a floating type of appearance. Here we can see it is a panoramic view that was generated, wherein there are septas that are seen with the large compartment. In the CBCT scan, in the axial view, we can appreciate that there are bony trabeculae and the expansion of the buccal to lingual plate is seen. In the three-dimensional view, we can appreciate that there are large compartments that are present, giving a soap bubble appearance. Based on this, a radiographic differential diagnosis of central giant cell granuloma and a variant of ameloblastoma was considered. This is the patient's hemogram that was taken. The other investigations that were done were plasma prothrombin type at the serology that was negative. The treatment plan that was carried, considering the clinical findings, chair-side investigations, and the radiographic features, enucleation was planned. After obtaining informed consent from the patient, the lobules were broken and the lesion was decompressed, along with the extraction of the lower right lateral incisors, and a surgical drain was placed. The specimen was further sent for histopath evaluation. On the histopath examination, a unicystic ameloblastoma with odontogenic epithelial island were present in the connective tissue. Here we can see the odontogenic island, the stratified squamous epithelium that is present in the luminal type. In the intraluminal type variant, which was also present with odontogenic islands that were seen in the connective tissue. Based on the histopath evaluation, a final diagnosis of unicystic ameloblastoma was considered. The postoperative OPG was taken to see the extent of the placement of the surgical drain. This is the comparative evaluation that was done, the pre and the post-operative OPG that was taken. The nature of the tumor was explained to the patient, and the patient is under regular follow-up. Conclusion: the present case has some interesting finding that distinguishes it from the other cases. This is a case of unicystic ameloblastoma with a rare variation that is in the anterior location, as most of the ameloblastoma is seen in the posterior area. The etiology associated with this case was trauma and pain while swallowing, as majority of 50 to 80% of the cases are associated with an impacted or unerupted tooth, and these are painless in origin. And the age of occurrence.
Your time is up.
Thank you.
Hello. Hello.
Yes, sir.
Yes. Good presentation. In your panoramic radiograph, you should mark the identification site.
Sir, it is marked. I think it wasn't visible on the screen.
Which are all the additional investigations, radiographic investigation you advise for this patient?
So we had taken an occlusal radiograph, and we had based on the occlusal radiograph, we had done the CBCT scans.
CBCT, advanced imaging technique. Okay, thank you.
So your provisional diagnosis was periapical cyst, right?
No, ma'am. The provisional diagnosis which I had given was an infected radicular cyst, as the patient has a history of trauma and it was painless in origin. The lesion was history of trauma. The pain was associated while swallowing, and the lesion had crossed midline.
Then why did you consider odontogenic tumor as your first differential diagnosis?
Ma'am, because we hadn't done the cytologic FNAC wasn't done and the aspirate wasn't seen. That is why a benign odontogenic tumor was considered as a differential diagnosis.
Okay.
Thank you. Now we have paper presentation 2.
Is my screen visible, ma'am?
Yes, yes.
Shall I start?
Yes.
Yes.
Okay. So I'd like to begin with a quote by Sir William Osler. Medicine is a science of uncertainty and an art of probability. With this, I begin to present my paper on the topic, omega-3, an astounding adjuvant in treating oral submucous fibrosis. Oral submucous fibrosis is a chronic, potentially malignant condition affecting the oral cavity, and omega-3 are polyunsaturated fatty acids that have been reported to exert important roles in the inflammatory process. The major omega-3 polyunsaturated fatty acids are the icosapentaenoic acid and the docosahexaenoic acid. Now, as a consequence of possessing the anti-inflammatory properties, omega-3 has been accepted as an addition therapy in the treatment of chronic inflammatory diseases such as rheumatoid arthritis, cardiovascular disease, diabetes, and even chronic kidney diseases. Therefore, the use of omega-3 polyunsaturated fatty acids as an adjuvant therapy during the treatment of oral diseases could help the clinicians like us in the control of inflammatory process and the patients in the post-treatment symptoms. Here, the objective was to evaluate the anti-inflammatory ability of the omega-3 as a supplementary therapy for OSMF. A randomized controlled trial was designed, and 48 clinically confirmed patients of OSMF, 24 in each group. Both the patients were given bi-weekly intralesional injections of dexamethasone 1.5 ml, hyaluronidase 1500 international units, mixed with lignocaine for 6 weeks. Additionally, Group A had received a placebo, that is lactose capsules, for 3 months, while Group B received 1 gram of omega-3 3 times daily continuously for 3 months. Patients were followed every month for 3 months and then after 6 months and 1 year. Subjects included had tobacco history, OSMF patients who were more than 18 years of age, physically healthy, and not on any systemic treatment or any treatment for the same. Patients suffering from any other systemic diseases, mucosal disease, or any other skin lesions, or any drug therapy, or with a known allergy or contraindication to the study medications are excluded from the study. Now, Group A was given bi-weekly intralesional injections along with 3 gram of lactulose, that is the placebo tablets, for 3 months, whereas Group B was given bi-weekly intralesional injections of dexamethasone and hyaluronidase mixed with lignocaine, along with 3 grams of omega-3 tablets per day continuously for 3 months. Now, patients were followed up every month for 3 months and then 6 months and then 1 year. Interincisal distance was recorded, tongue protrusion was measured, cheek flexibility was recorded, and only grade 2 and grade 3 patients were integrated in the study. Now, we had observed improvements were seen in the clinical parameters assessed in both the groups during the first 2 months. Improvement was observed in both the groups independently, but intergroup comparison did not show any significant difference. However, after 3 months, statistically significant improvement among all the 3 clinical parameters were observed, that were mostly the interincisal distance, tongue protrusion, and cheek flexibility when compared with Group A. In contrast, statistically significant improvement in burning sensation was observed after 1 month itself in Group B when compared with Group A. Now, in the present study, the use of areca nut in different forms like tobacco, pan masala is definitely the whole and sole reason of the disease, and according to study by Anigiri and Jadhav et al., which was done in 2015, no documentary evidence in literature is present till date for the role of omega-3 in OSMF patients, so a comparative analysis was not possible. However, comparative analysis of results of omega-3 with other treatment modalities was done, and it was seen a mean improvement of 6.3 millimeters in interincisal distance in this study group, which is more than the studies on intralesional injections alone done by Selvam et al. In 2013. Corticosteroids decrease the inflammation, decreasing the fibroblastic proliferation, collagen formation, thereby preventing fibrosis, according to Sai et al. Given in 1999. So the improvement noticed in this study were in all 4 parameters might be due to the synergistic effect of all these drugs at very high doses. Example, for 15 grams per day, omega-3 tends to increase bleeding time as given by Kohli et al. In 2014. But here the dosages were 3 grams per day. That was limited and thus no complication was noticed.
You have 1 more minute.
Thus, in conclusion, the results of this study suggested that intralesional injections alone or in conjugation with omega-3 both are effective in improving major symptoms in OSMF grade 2 and grade 3 patients. However, omega-3 in conjugation with intralesional injections has shown better clinical results than intralesional injections alone. Further studies can be planned to assess the individual effects of omega-3 and its role in improving the lipid profiles of OSMF patients, in preventing the conversion of pre-malignant lesions into malignancy, and in different supplementation doses to find out the exact dosage with minimum side effects. These are the references for my study. Thank you.
What are the possible side effects you expect with omega-3 fatty acids?
Yes, ma'am. Possible side effects of what?
Side effects of omega-3 fatty acid treatment.
Ma'am, as it said, the patient can develop any kind of allergic reaction to it. Also, if the dose is increased, it is said to increase the bleeding time in patients.
Okay.
Yes, ma'am.
Ashish sir. Ashish sir.
Okay, it's okay. Continue the next one. Okay.
Okay, thank
Thank
you,
you.
sir. Thank you, ma'am.
Thank you, judges. Next, we have paper 3 present.
If paper 3 is not there,
Is paper 3 presenter ready?
Yes, ma'am.
okay, then you start with the presentation.
Ma'am, please give me a few seconds.
ഞാൻ പറയുന്ന കേൾക്കാൻ പറ്റുന്നില്ല.
Ma'am, please give me 3 seconds. I'll start now, ma'am.
Okay, okay.
Good morning, sir and ma'am. Are you able to see my screen share?
Yes, you can continue.
Shall I start?
Yes, yes.
Respected chairpersons of the scientific session, I am here to present a research paper titled Patient Perception and Awareness on Radiation Safety in Dental Radiographs, a questionnaire survey. Human beings are constantly exposed to different kinds of ionizing radiation, both from natural and artificial sources. X-rays are ionizing radiations that are extensively used for diagnostic purposes. In dentistry too, radiography plays a vital role in diagnosis and treatment planning. Even though the radiation exposure of dental patients is small, it comes with a subtle risk. Patient information on radiation safety in dental radiography is very much limited. The aim of my study is to assess the patient perception and awareness on radiation safety in dental radiographs, and the objective was to compare the level of awareness with educational status. The materials used was a questionnaire with 16 questions. A total of 100 patients were randomly selected and questions were asked to them. The questionnaire contained questions about their demographic data and their perception and awareness towards dental radiography and radiation safety measures. This was the questionnaire used for the study. Personal interview was done with the questionnaire and 100% of response rate was obtained. Descriptive statistics and inferential statistics were performed to analyze the data. Moving on to results. These are the demographic details of the 100 respondents. Out of 100, 53% were above 35 years of age, 61% were females, 38% had bachelor's degree, and 47% were employed. 54% of the participants had taken radiograph only based on requirements. 43% believed that X-rays are not harmful, while 38% did not know the harmful effects of X-rays in dentistry. Out of them, 14% were with the bachelor's degree. And this shows that even educated people are not aware of harmful effects of X-rays. Majority of the participants had awareness regarding the importance of clinical and patient history. They knew the reason for taking dental radiograph, and they were aware of the informed consent. 95% of the participants said that the benefit was well explained to them before taking a radiograph. 54% of the participants reported that they were not informed by the dentist about the type of radiograph to be taken. 93% of the participants said that they were not informed about the radiation hazards before the procedure. Out of them, 34% were with the bachelor's degree, and they were not even aware of the radiation hazards associated with the radiographic examination. And the graph here shows that all education level are unaware about the radiation hazards. 74% of the participants said that they were not given any safety measures such as lead apron or thyroid collar during the radiographic examination. Out of them, 34% were with the bachelor's degree. And here also the graph again shows that all education level were unaware regarding the radiation safety measures used during the radiographic examination. 48% of the patients believe that radiographic examination is harmful in pregnant women. Out of them, 21% were with the bachelor's degree. Since the chi-square value obtained here is less than 0.05, there is a significant association between education level and awareness regarding the harmful effects of radiation in pregnant women. 54% of the participants had noticed the signboards displayed outside the X-ray room. Out of them, 27% were with the bachelor's degree, and they knew the relevance of signboards. Here also, chi-square value obtained is less than 0.05, and there is significant association between educational level and awareness regarding the presence of signboards outside the X-ray room. 68% of the respondents had noticed the red light indication on while the radiography was seen in progress. Moving to key highlights of the study. The patients were aware regarding the importance of clinical and patient history, reason and benefit of taking radiographs, importance of informed consent, harmful effects of radiation in pregnant women, presence of signboard displayed outside the X-ray room, and red light indication on while the radiography was seen in progress. And patients were unaware regarding the harmful effects of dental X-rays, type of radiograph prescribed by the dentist, radiation
You have
hazard,
1 more minute.
as well as the radiation safety measures. These are the recommendations I would like to suggest. The role of the dentist is pivotal in this aspect. Dentists must educate and inform the patients about radiation hazards and the measures adopted to reduce them. Inform the patient about the type of radiograph before the procedure. Provide the patients with radiation safety measures such as lead apron and thyroid collar. You can disseminate scientific information about radiation safety measures to the public through media to increase the public awareness. Display radiation safety measures near the X-ray room regional language to benefit those belonging to low education level, and proper location of signboards for easy identification is also essential. Hereby, I conclude with that there is a lack of awareness among the patients regarding the radiation hazards and the safety measures adopted in dental radiography. More emphasis must be laid on patient education and focus on risk versus benefit assessment while planning dental radiographs. These are the references. With this, I conclude. Thank you.
How did you select the questionnaire for this study?
Ma'am, I have a previous literature, and based on the previous literature, I selected the questions.
Okay, you have done any validation and all for this selecting the before giving the questionnaire to the patients?
No, ma'am. Based on the review literature only, I selected those questions.
Okay.
Hello, ma'am.
Hello, you can hear?
Yes, ma'am, I can hear you.
Can you selected the patients from radiology department itself, right?
Yes, ma'am. I selected the patients, those who came to radiology department.
Okay. Okay. Thank you.
Thank you, ma'am. Shall I exit?
Ashish sir, are you asking any questions?
No. You asked some range issues there. I can hear it. No problem. Okay.
Okay, thank you, sir. Next, we have paper presenter 4.
Thank you, sir and ma'am.
Is paper presenter 4 ready?
Ma'am, can you hear me?
Yes, yes.
Can hear you, but there's some echo there.
Okay, ma'am, it's okay now? Is it okay now?
Yes, yes.
So, myself, Anjana, my topic is radiation protection, general dental practice, recommendations and guidelines. Introduction, X-rays are the ionizing radiation used extensively in medical and dental practice. In dentistry, it is mainly used for diagnostic purposes and dental setup. Usually, the practice in dentist exposes, process, and interprets the and even though such exposure is less, it is critical to reduce the exposure of dental personnel and patients in order to prevent the harmful effects of radiation. So my aim and objective of the study is to assess the knowledge and practice on radiation safety in dental practice. So based on a questionnaire survey. Questionnaire with 14 questions was designed based on the review literature, and a total of 100 practitioners were randomly selected, and the questions were given to dental practitioners, and participation in the study was voluntary. And these are my questionnaire. The methodology, personal interview with the practitioners, response rate is 100%, and data was analyzed using the statistical package of SPS 22.0, and level of significance was set at p-value less than 0.05, and descriptive statistics was performed to assess the proportion of category of the respective group. So first question is 91% of dental clinics have the X-ray equipment, and 74% and 88% are aware of the ICMR guidelines and ALARA principle, and 54% do not calibrate their X-ray equipment. And 64% of dental clinics have lead barriers in their clinic, and 83% are aware of position distance rule, and 77% uses RVG as a digital sensor, as far as this digital sensor are mostly used in dental clinics. And 63% of dental clinics do not have any radiation safety display kept in their clinic. And 57% don't know about the thickness of the wall, which is required in the X-ray room based on ARB guidelines. And 82% do not use dosimeter to measure the radiation dose. 45% are aware of the average exposure, and it is 0.5 to 0.8 seconds. And 65% of dental clinics do not provide any lead aprons or thyroid collars for patients while being exposed to X-ray, which is mandatory. And 82% are aware of the aware that the pregnancy, the first trimester, is not safe for the radiation exposure. So key highlights of my study is dental practitioners are aware of NCRP and ICRP guidelines, ALARA principle, use of lead barriers, position distance rules, average exposure time, and pregnancy safe trimester. But they do not have any aware, or they overlook in the calibration, radiation hazard display, radiation protection shielding, and dosimeter. So my recommendations are awareness of recommended dose for the operator in general public as per the guidelines, and radiation monitoring devices recommended for practitioners. Lead aprons and thyroid collars should be regularly used, and never stabilize X-ray film during exposure. Calibration of X-ray equipment and regular monitoring of radiation dose, especially from handheld devices. So my conclusion is that the study concluded that majority of the dentists know the basic concept that is being asked in the questionnaire, but majority of the dental practitioners overlook the radiation protection measures in dental clinics. So knowledge on the type of radiological equipment during purchase and the calibration of the machine should be mandatory. Following the ERB guidelines while constructing the radiological unit and monitoring the individual exposure is important in radiation protection. Through exposure to radiation in dentistry, it's minimal. It is very important to follow the guidelines.
One more minute.
Minimize the radiation exposure. These are my references. Thank you.
Was there any question regarding the radiograph prescription practices? Did your study included some objective like that? what are the common indications when they are prescribing CBCT or other radiographs like that?
There was no such questions, ma'am.
I think when you talk about this protection, the first thing you should consider is that they should be aware regarding the radiographic diagnostic yield and all. You should have included a question like that, I feel so.
The question was only asked about whether they provide their radiation protection to the patients only. Yeah. Hello?
Okay.
Okay, we can continue the next one. Okay.
Thank you. Next we have paper presenter 5.
Thank you, ma'am.
Stop sharing your screen.
Ma'am, shall I start?
Yes.
Good morning, everyone. Today I'm going to present a research paper on the topic knowledge and awareness of CBCT.
Excuse me, your screen is not visible.
1 second, ma'am.
Okay. Now it's visible.
Okay. Okay, ma'am, shall I start?
Yes.
Good morning, everyone. Respected chairperson, today I'm going to present a research paper on the topic knowledge and awareness of CBCT among dental students and dental practitioners, a survey. CBCT is an excellent diagnostic 3D imaging modality that has recently been introduced for dentomaxillofacial imaging. CBCT unit costs less, requires less space, and it has got a rapid scan time and reduction in radiation doses compared with the conventional CT scanners. Indications of CBCT include nerve tracing in cases of third molar extraction, implant planning and placement, maxillofacial and sinus pathologies in TMJ disorders, and for locating additional roots and accessory canals in endodontics, and for orthodontic cases and orthodontic surgeries. The aim and objective is to evaluate the knowledge and awareness of CBCT among dental students and dental practitioners based on questionnaire survey to compare with age and educational status. Materials included a structured questionnaire with 18 questions and 4 groups were randomly selected, which consist of UGs, interns, PGs, and general practitioners. And this is my questionnaire. Methodology, all of them were interviewed personally. Descriptive statistics and inferential statistics were done. And moving on to the results, 99% were aware of CBCT being used for dentomaxillofacial region, and 53% have advised their patients for CBCT imaging, and among them 21% were dental practitioners, and this data shows very high statistical significance. 78% does not take CBCT for child patients, where radiation risk for children is 3 times higher than in adults. 98% think that CBCT should be provided in dental institutes. All PG and dental practitioners agreed to this. 72% would choose to use CBCT as an imaging modality in their clinical practice, and UGs and PGs are willing to use. 41% obtained their knowledge about CBCT through lectures, which were UGs and interns, and 37% were PGs. They obtained knowledge through curriculum-based, and 22% general practitioners obtained through CDs. 75% haven't attended any workshops or CD regarding CBCT, which reflects the need for CDs. And this data also shows high statistical significance. 50% were not aware of radiation dose, and 96% were not aware of equivalent background radiation, which indicates less awareness radiation doses from CBCT. 68% does not select CBCT based on field of view, which indicates lack of awareness, and PGs have more awareness about field of view. 99% feel that CD or workshop should be conducted to increase their knowledge, which reflects the positive attitude towards CBCT. 65% of the participants opted clinical period, and introduction of training in CBCT must also be given. 63% would choose CBCT for multiple uses, whereas general practitioners emphasized more on implant planning. So coming to the key highlights of my study,
Some of the positive aspects were all the participants were aware of CBCT, although their knowledge level is varying. There is positive attitude towards CBCT is reflected in this study, and they agreed the necessity of CBCT in dental institutes and selected clinical period for training in CBCT. And the negative aspects were most of the participants were ignorant of radiation dose, equivalent background radiation, and field of view. General practitioners aware of implant planning using CBCT, but they have minimal awareness on CBCT indications in other specialties. And the positive aspects include UGs and PGs willing to use CBCT in their future clinical practice, and they agreed the need of CDs or workshops to be conducted. General practitioners obtain knowledge mainly through CDs, whereas UGs and PGs through lectures or curriculum based. And the negative aspects include radiation risk for child is 3 times higher than that of adults, hence should be advised only if absolutely indicated. So coming to the recommendations, conduct CDs to update the knowledge and CBCT training, lectures in UG level and hands-on training in PG level should be provided, and provision of CBCT in all dental institutes. So hereby I conclude, general dental practitioners and specialists must gain knowledge on the applications of CBCT in diagnosis and treatment planning. Knowledge on radiation hazards and protection is very important while prescribing CBCT, and consider the benefits versus risk in pediatric patients where CBCT is taken only if absolutely necessary for the diagnosis. These are my references, and thank you. Thank you, ma'am.
Have you heard of a campaign, Image Gently?
Ma'am, just 1 second. Can you see me? You can't.
Yes, I can see you. Have you heard such a term?
What, ma'am? I didn't hear. Sorry.
Image Gently.
Image Gently. No,
It's
ma'am.
okay. Okay. Okay, thank you.
Thank you, ma'am.
Thank you. Next, we have paper presenter 6. Is paper presenter 6 ready? We will move on with paper presenter 7. Judges, please note paper presenter 7. Is paper presenter 7 ready? Is paper presenter 7 ready? We will move on with paper presenter 8. Is paper presenter 8 present?
Nine. Next presenter. Nine. 11. 9 ഉണ്ടോ?
Paper presenter 9. Is paper presenter 11 ready? Is paper presenter 11 ready?
Is anybody ready in this session with the presentation? Is anybody else ready?
Hello.
Hello.
Ma'am, paper presentation number 11. I'm ready.
11. Okay. Then continue. Judges, please note that this is paper presenter 11.
Yes, ma'am. Just one sec, ma'am. I'm sharing the screen.
Ma'am, excuse me. Hello, ma'am.
Tell me.
Ma'am, I am paper presentation number 8, ma'am. Ma'am,
Now we'll start with, yeah, I understood. Now we'll start with 11. Once 11 is over, you can start your presentation.
Okay, ma'am.
Okay. Can you see my presentation now? Hello.
Yes.
Hello.
Yes, we can see your screen.
Am I audible?
Yes.
Can I start?
Yes, please.
Good morning, everyone. Oral malignant melanoma, a rare case report. The term pigmentation of the oral mucosa is applied to a wide range of lesions or condition featuring a change in color of oral tissues. It can range from simple racial physiological pigmentation and can be due to systemic conditions. Thus, by correlation of detailed history, clinical appearance, and etiopathogenesis, is a correct diagnosis is attained. Malignant melanomas are pigmented lesions in the oral cavity, which are aggressive malignant neoplasm arising from melanocytes. They have poor prognosis as they are rare, which leads to their delayed diagnosis. Here, I am presenting one case of rare oral malignant melanoma of an 80-year-old female patient who presented to OPD with a chief complaint of black growth in the upper right edentulous jaw region since 1 to 2 days. Patient was a known case of denture wearer since 25 years, which noticed a black growth in the upper right edentulous region since 1 to 2 days, which was concealed by the denture. There's a history of associated pain, which is moderate in nature, non-radiating, and aggravates chewing. Patient relatives reported of a similar blackish growth on the forehead region 15 years back, which was diagnosed as cancer and surgically treated in a government hospital. There was no history of swelling, blood or pus discharge, weight loss, or appetite loss. Medical history: the patient was known case of COPD, acute pulmonary edema, was hypertensive and diabetic, and patient was also under ecospirin. There was no contributory findings with respect to general intraoral and extraoral examination. On intraoral examination, specific findings: there was well dispersed melanotic patch on the palate crossing midline adjacent to asymmetrical growth. Growth was on the anterior 2/3 of hard palate with ragged borders, grayish black in discoloration, measuring around 1 to 1.5 centimeter in size. Growth was with elevated surface. On the extension of the lesion, extending laterally to the right buccal vestibule, medially over the right alveolus to the right hard palate, inferiorly up to the middle part of right buccal mucosa, and superiorly in front of right buccal frenum. The growth was soft to firm in consistency with mild tenderness, and there is no evidence of blood or pus discharge. On intraoral examination, the supported tongue physiological pigmentation present since birth. To summarize, there's a 84-year-old female reported to dental OPD with black growth. Patient could not give details of onset and growth pattern of the lesion as she had noticed it only 1 day prior. Intraorally, there's a large diffused melanotic patch, melanotic macule noted on the right side of hard palate. On examination of macule, asymmetrical grayish black growth was noted with ragged borders and elevated surface. By clinical examination history and ABCD criteria, we have given a diagnosis of oral malignant melanoma. differential diagnosis were given as melanoacanthoma. The points not favoring is there's no growth present and there's no pain present. The second one is a melanotic macule. The size was not more than, and the points not favoring was in melanotic macule is that there is not size not more than 1 centimeter, and it's mostly seen in lip and lower gingiva. And further investigation.
Hello. Hello.
Hello. Hello.
Hello, can you hear me?
Yes, sir, I can hear you.
Completed.
Okay, sir. Before the commencement of a treatment, patient collapsed and passed away. Moving to discussion, melanoma is a malignant neoplasm of melanocytic origin. The UV radiation exposure from sunlight is the major etiology in melanoma. Diagnostic criteria for melanoma is ABCDE rule, in which there is asymmetry, borders with ragged edges, color, diameter, and raised elevation surface is observed. Nodular melanomas have their own mnemonic of EFG, in which the lesion is elevated with firmness of the lesion, and this lesion is always growing. Their growth pattern seen is such as radial growth phase and vertical growth phase. In radial growth phase, there is a malignant melanocyte spread horizontally through the basal cell layer of epithelium. In vertical, it invades the underlying connective tissue. There are 4 types of clinicopathologic types of melanoma, which is superficial spreading, which is most common, nodular melanoma, which rapidly invades the connective tissue. There's acral lentiginous melanoma, which is a common form of oral melanoma, and there's lentigo-maligna melanoma, which occurs in sun-exposed skin and mostly seen in older adults. The histopathology, there's a buckshot scatter phenomenon is seen in superficial spreading melanoma, characterized by presence of large epithelioid melanocytes.
Your time is up.
Pagetoid manner. Treatment is surgical excision, radiation therapy, immunotherapy. Thank you.
Hello.
Hello, yes, sir.
Can you hear me?
Yes, sir, I can hear you.
What is the prognosis of this case?
Sir, very poor prognosis, sir.
Pardon?
So the prognosis was very poor, and before the commencement of the treatment, the patient collapsed and passed away, sir. And
Can you're using any advanced radiological imaging techniques for the diagnosis of the lesion?
Sir, positive emitron tomography was advised for the patient, PET scan.
Okay. Dr. Atmaja?
Hello.
Yes, ma'am.
Immunohistochemistry was done.
No, ma'am, immunohistochemistry was not done.
Okay, what are the differential diagnoses you considered?
Ma'am, we considered melanoacanthoma because of the patch and melanotic macule.
Okay, thank you.
Thank you.
Thank you.
Next, is paper presenter 12 ready?
Madam, 6, 7, 8, 9 are absent.
Ma'am, 9 is present.
Okay, 6, 7, 8, and 10 are absent.
6 and 7 are not
8 is
contactable,
also
sir.
present.
6 and 7 are not contactable.
7 is also present, ma'am.
You were not initially contactable. Okay. Can we move on to the 12th one and then get back to you?
Hello.
Okay, then we will
Madam, can you
start.
repeat, 6 is absent?
6 and 7 were not conducted initially. Now 7 is present, I think. If 7 is present, 7 can start with the presentation.
Yes, ma'am.
So it's 7 presenting.
Can I start, ma'am?
Yes.
Good morning, all. Today, I am going to present a study topic based on the topic assessment of maxillary sinus volume from 3D linear measurements and volumetric measurements, a correlation using CBCT. Then the introduction. Knowledge of maxillary sinus volume is important in oral surgical procedures, and maxillary sinus is visualized in periapical and panoramic images and CBCT. And CBCT provides undistorted 3D images without superimposition. So I propose a pilot study based on the topic comparative study for assessing maxillary sinus volume, calculated from 3D linear measurements in CBCT2, calculated the sinus volume using on-demand 3D software in CBCT. The aim of the study is to correlate the maxillary sinus volume calculated from 3D linear measurements to software measurements in CBCT. And objectives of my study are maxillary sinus volume calculated from linear measurements of maxillary sinus, that is the length, width, and height in CBCT, and from on-demand 3D software. And third one is and compare and correlate volume assessed from linear measurements to on-demand 3D software. Then the materials and methods. Study design, this is a comparative study, a pilot study, and study subjects are archived CBCT images of both male and female patients, which are randomly selected. Then the inclusion criteria of the study is archived high-resolution CBCT images of both male and female patients, and CBCT with clear visualization of both maxillary sinuses. And exclusion criteria is the image of patient with history of trauma, fracture, congenital anomalies or surgery, or pathology, or mucosal thickening, or completely edentulous jaw. Then the procedure. Then the measurement taken as when maxillary sinus is considered as a pyramidal shape and square base oriented median. And the linear measurements are taken based on the Hamdi et al. 2040. Then the length, craniocaudal extension, and width, anteroposterior dimension, and height, mediolateral dimension in millimeters. And volume measurements from the linear measurement based on the formula. Volume is equal to base surface area into 1/3 height. And volume of maxillary sinus pyramid is equal to anteroposterior width into craniocaudal length into mediolateral height. Then volume from on-demand 3D software. Then the calculation method. Then the length is estimated as the interdental area between upper first and second premolar, second premolar and first molar, first and second molars, and second and third molars. Then width is measured as the in two level, first along the nasal pora and along the zygoma. Give rise to 4 measurements: APNF, APZG, MLNF, and AMLZG. APNF is anteroposterior nasal flora and anteroposterior zygoma, mediolateral nasal flora and mediolateral zygoma. Then the sinus volume measurement by the software using the 3D picker tool. These are my results. Then based on the results, comparison of volume from linear measurement to software, both right and left side, software volume is little bit greater than the geometric formula. Then the intercost correlation, there will be excellent agreement of highly statistically significant on both sides. Then excellent correlation volume from geometric 3D linear and software on both right and left sides. Then the discussion, volume of maxillary sinus according to Arji et al. 1994, normal volume is estimated at 4,567.22, 35,213.3 millimeter cube. According to Giacomi et al. 2018, software volume is greater than volume from 3D linear measurement, and average adult volume is 10.9 plus or minus 2.8 centimeter cube to 24.7 plus or minus 9 centimeter cube. In our study, volume of maxillary sinus is 5842.1 to 8645.2 millimeter cube. And software volume is greater than volume from 3D linear measurements. Then volume in right and left side, according to Hamdi et al., excellent correlation right and left side using Zipline software, and volume from 2 methods, according to Agnieszka et al., 2017, statistically significant correlation.
You have 1 more minute.
Mimic software. In our study, excellent correlation of right and left side from 2 methods, and statistically significant correlation seen in volume from 2 methods. Then I concluded the study highlighted volume measured from software is greater than volume from 3D linear measurement, and excellent correlation in volume in both right and left sides from 2 methods, and volume from linear measurements and software. So suggestions for future study: this automated tool may be used in clinical practice and needed to evaluate patient group with different ages and genders, and larger sample size is needed for volume measurement in Indian population. These are my references. Thank you.
So what is the clinical significance of measuring this sinus volume?
Various oro under surgical procedures, implant, such cases like oroantral fistula and malignancies of maxillary sinus. Such cases we can use this automated tool.
So your conclusion is that both the methods are accurate only. It means linear method as well as using that software. Either method you can use.
Yes, ma'am.
And any means you did some inter-rater analysis like that, means different observers analyzed the sinus volume, or only one observer did all the measurements?
Not clear, ma'am.
When you took the measurements, only one observer was taking the measurements, or different observers did the measurements and you
Different observers taken this measure.
Okay.
Thank you.
Hello. Okay. It's okay.
Thank you, sir.
Next one.
Paper presenter 8, can you please share the screen? Paper presenter 8, can you please share the screen?
Then we'll move on to paper presenter 9.
Is paper presenter 9 ready? Okay.
Yes, ma'am. Good morning, all. Today I'm here to present a pilot study on the topic comparative evaluation of salivary cortisol levels and stress in smokers and non-smokers. You all know cortisol is a hormone with several functions, especially on emotional states. It can be detected in plasma, saliva, and urine. Salivary cortisol is a reliable indicator of serum cortisol level. So, salivary cortisol estimation, which helps in early diagnosis of depression, anxiety, and stress. Here in old literature, smoking which cause moderately elevated salivary cortisol level, but in some recent studies shows that there is no interrelation between smoking and cortisol level. So I have planned to evaluate and compare salivary cortisol level in smokers and non-smokers. So aim of my study is to evaluate and compare salivary cortisol level and stress in smokers and non-smokers. So my objectives are, primary objectives is to evaluate salivary cortisol level in smokers and non-smokers and to assess the stress level in smokers and non-smokers using DAS-21 scale, and to compare and correlate salivary cortisol and stress in smokers with non-smokers. So the materials and methods, my study question is to do the smokers have an increased salivary cortisol level. The study subjects are case group consisted of 10 smokers of 20 to 50 years of age group, control group 10 age and sex matched non-smoker healthy volunteers. So the inclusion criteria based on the willingness to take part in the study, current smokers and healthy non-smokers based on Centers for Disease Control and Prevention criteria. Then exclusion criteria, smokers with diabetes mellitus and malignancy who have a drug history of corticosteroid, antidepressants, anxiolytics, and antipsychotics, and the condition that could affect hypothalamic pituitary adrenal axis. Then pan chewing habits. Then the procedure, the study subjects are randomly selected and the saliva collection taken during 9 a.m. to 12 p.m. to avoid circadian variation. Study subjects are abstained from brushing caffeinated drinks for 30 minutes prior to saliva collection. They are advised to rinse their mouth thoroughly before collection. Then 1 ml of unstimulated whole saliva collected in Eppendorf tubes by spitting method. Then the collected saliva transported in a cryo box of -4 degrees Celsius and stored in lab at -80 degrees Celsius till analysis. Then an analysis of emotional state after saliva collection is by a self-assessment questionnaire, that is DAS-21 scale. Final score is calculated by multiplying DAS-21 score by 2. Here we can see the recommended cutoff score of DAS-21 for depression, anxiety, and stress. Here, these are the procedure I had done for the comparison of salivary cortisol level and stress in smokers and non-smokers. Then the statistical analysis conducted using SPSS for Windows 17 software, normality test, Shapiro-Wilk test were done, and data are non-normally distributed. Continuous data was represented as mean and standard deviation. Manually used test was used for analysis. P-value less than 0.05 was considered as statistically significant. These are the detail of case and control group. Here we can see the stress, depression, and anxiety score of case and stress, depression, anxiety score of control. Here we can see the elevated salivary cortisol level in case group, that is smokers, that is 247.30, and in control group it is 93.80. Here the comparison of salivary cortisol level in smokers and non-smokers. Here highly significant salivary cortisol level is evident in smokers when compared to non-smokers. These are the scatter plot of comparison of salivary cortisol level in case and control.
You have 1 more minute.
Then this is the comparison of DAS score in case and control group. Then salivary cortisol level is elevated in smokers, which is evident in old studies like Talukdar et al., Cohen et al., and Rafeti et al., Bavankar et al., and Sang et al. In our study, it is similar, significantly higher in smoker when compared to non-smoker. Then the depression score is elevated in smokers when compared to non-smokers, which is evident in old studies like Fluharty et al. Study and Rubin et al. Study. Then anxiety level is also elevated in smokers when compared to non-smokers, which is also evident in Talukdar study. Our study also, there is highly significant depression and anxiety score in smokers than non-smokers. Stress level is also elevated in smokers, which is evident in all studies. Our study highly significant stress score in smokers than non-smokers. So here, moving to the last
Your
part,
time is up.
concluding. In our study, there is strong significant association between smoking and cortisol secretion. Thank you.
by using this DASS scale, you will be able to analyze both acute stress as well as chronic stress?
Ma'am, at present, it is a self-assessment questionnaire. It will evaluate chronic stress, mainly. Based on the questionnaire, we are evaluating, ma'am.
And saliva cortisol measures, acute or chronic one?
Chronic one, ma'am.
Okay, are you sure? Means this cortisol levels, means I have read something like this chronic stress, this HPA adaptation, HPA axis adaptation will occur. So this saliva cortisol is more accurate for analyzing acute stress level.
Ma'am, here we exclude the HPA axis syndrome diseased patients. So we assume that it may evaluate the stress during the smoking period and all.
Okay.
Hello. Okay.
Okay, thank you. Next we have paper presenter 10. Is paper presenter 10 ready?
Yes, ma'am.
Can you share the screen? Judges note, this is test number 10.
Good morning. Today I am going to present a case series on the topic chronic non-bacterial osteomyelitis of jaw, a diagnostic dilemma. Chronic non-bacterial osteomyelitis is an autoinflammatory bone disorder with a wide spectrum of clinical manifestation from unifocal to multifocal lesions. When it manifests with multifocal lesion, it is also referred to as chronic recurrent multifocal osteomyelitis. CNO or CRMO can affect all age groups, most commonly in pediatric and adolescent population. It is characterized by bone lesions with pain and swelling. It is chronic in nature and patients present with episodic flares and phases of remission. First case presented with a 16-year-old male presented with a complaint of swelling on lower jaw since 1 year. Upon clinical examination, a diffuse swelling noted on the symphysis region, which extends to the body, left body of mandible. Case 2, a 15-year-old male patient complains of pain and swelling on the left side of jaw since 11 months. On clinical examination, a diffuse swelling noted on the left ramus region of the mandible. Case 3, a 13-year-old male patient complains of swelling on left side of mandible since 4 weeks. And on clinical examination, a diffuse swelling noted on the left body region of the mandible. There was history of fever 1 week back. In all the 3 cases, the swelling was of hard consistency with a rise in temperature and with tenderness. On intraoral examination, there was no active dental foci of infection. There were no history of any trauma or any other systemic diseases. There was exacerbation as well as remission of this pain in all the patients intermittently. Provisional diagnosis was made as fibro-osseous lesion, possibly fibrous dysplasia. Investigations. Vitality tests of all adjacent teeth to the area of the lesion in all the cases showed normal responses except one RCT treated tooth. Blood investigations of all the 3 patients was within normal limits. Pan view in case 1 showed altered trabecular pattern with multiple lytic area in left parasymphysis and body region of mandible. There was loss of normal corticated border of left inferior border of mandible. In case 2, there was lytic lesion with irregular margins on left posterior ramus region of the mandible. And in case 3, there was a hypodense radiolucent lesion on the left body region of the mandible extending to ramus in relation to teeth 3, 6 and 3, 7. CBCT of case 1, short lytic lesion with alteration of normal mandibular pattern that extends to right parasymphysis region of the mandible, and there was also increased buccolingual width of the left mandibular body compared to right. In case 2, there was increased width of mandible and also irregular lytic lesion with periosteal reaction noted on left ramus region. In case 3, axial section showed hypodense lesion in the left ramus region of the mandible and also in relation to the roots of 3-6 and 3-7. Thinning and breach of buccal and lingual cortical plate also noted in relation to 3-6 and 3-7. Histopathology reports of all the 3 cases showed chronic inflammation with a lymphocytic infiltration, lymphocytic and inflammatory infiltrate with myelofibrosis and osteolysis, which are the features suggestive of chronic osteomyelitis. Culture and sensitivity reports of all the 3 cases was also negative. Discussion. CNO is a poorly characterized in oral and maxillofacial surgery because of the inconsistent terminology and lack of information about whether the patient is having any other bony foci or extraosseous lesion. Female patients are more commonly affected than males. The lesions may be acute or chronic, or it can be unifocal or multifocal. The most commonly affected bone with unifocal disease is mandible. The differential diagnosis include infectious osteomyelitis, malignancy, which include osteosarcoma and Ewing sarcoma, and
You have 1 more minute.
Histiocytosis. CRMO is uncommon in jaw, and in panoramic radiographs, it may be mistaken as fibrous dysplasia or chronic diffuse sclerosing osteomyelitis or periosteolytis ossificans. CT and CBCT scans are the best diagnostic imaging tests because these provides adequate bone visualization. There is no standard treatment for CNO. However, NSAIDs, TNF blockers, and bisphosphonates can be used for treatment. CNO in jaw must be diagnosed with differentiation of chronic bacterial osteomyelitis, and a bone biopsy is essential. The early diagnosis of CNO in jaw will prevent unnecessary and prolonged antibiotic usage and unnecessary surgical intervention. The updated researches of several pathophysiological alterations in CNO should be studied more for its exact causes and also for the creation of directed treatment options. Thank you.
What about the treatment and prognosis of these cases?
Treatment, it was for patients, there was surgically removal of tooth bud, and for case 2, and the lesion, osteolytic lesions was somewhat improved, but intermittent pain was still persisting, but the recurrence was decreased.
Okay.
Hello. Can you hear me? Hello.
Hello.
Can you hear me?
Hello.
Hello. Can you hear me?
Yeah.
Panoramic radiograph, you are saying lesions on the left side of the mandible.
Yes, sir.
But one of the cases, all the 3 cases, side identification mark. Then why can you
Sir, I didn't get.
Can you tell it as a right or left?
So can you repeat?
Side identification mark is not there for all the 3 panoramic radiographs.
Sides. Okay.
Side, I don't know. In CBCT also, in CT. How can you say it is right or left without identification for the external radiograph?
Yes.
How can you say it is right or left? Why can be identified? It's okay.
Sorry, sir.
It's okay.
Thank you. Next, we have paper presenter 8. Is paper presenter 8 ready? Is paper presenter 8 ready?
Yes, I'm ready.
Can you share the screen?
It's number 8.
Just please note that this is paper number 8.
Can I start?
Yes,
Can
yes.
I?
Yes.
Good morning. My topic for presentation is white sponge nevus area oral genodermatosis case series. First, introducing white sponge nevus is a rare hereditary dyskeratotic hyperplasia of mucous membranes. It is an uncommon disease that Heide first described in 1909, but Cannon coined the term in 1935. This entity is also known by other names like Cannon's disease, familial white-folded dysplasia, hereditary leukokeratosis, white gingival stomatitis, and exfoliative leukodema. It is an autosomal dominant disorder with variable penetrance. White sponge nevus has been listed as a rare disorder by National Institute of Health, which implicates a prevalence below 1 in 2 lakh. Aims and objectives of my study to identify various clinical presentation of white sponge nevus to differentiate white sponge nevus from other oral lesions. Case series. These all three cases are reported to our department. First 20-year-old female, I'm comparing your 17-year-old female and then 20-year-old female. First one complains of white discoloration in mouth noticed 6 months back. Then second one, white discoloration inside mouth, which is irritating and tendency to bite on it noticed 1 month back. And third, white film inside right and left cheek, which on biting peels away, leaving a red surface since 6 months. On examination, on observation, we noticed in first case, white continuous plaques on right and left buccal mucosa. And in second case, we noticed white thickened plaque on, which is like velvety on right and left buccal mucosa. And on third case, which is a curdy appearance on right and left buccal mucosa. And also on palpation, all cases are non-tender and non-scrapable on palpation, and also it is not disappearing on stretching. And it was first provisional diagnosis was like white sponge nevus, and differential diagnosis for candidiasis for first case, morcatio bacorum for second and third case. And histopathology report came as superficial parakeratosis, acanthosis, and spongiosis with perinuclear eosinophilic condensation of epithelial cells, which is feature of white sponge nevus. Discussion part. All three cases reported are in age range of 17 to 20 years. All three noticed abnormality within 6 months at a time of reporting to our department. This condition is attributed to a defect in normal keratinization 4 and 13. In periodic studies, the orders investigated a new keratin 4 gene mutation are detected in an amino acid insertion exon 1A. The lesion of symmetric keratinized thickened diffuse plaques, buccal mucosa is the most frequently affected, followed by labial and gingival mucosa. For extraoral sites like nasal, esophageal, laryngeal, and anogenital mucosa appear in less extent. And all patients are asymptomatic, not diminished when the tissue is stretched. Oral candidiasis, frictional keratosis, leukodema, leukoplakia, and lichen planus are differential diagnosis. Malignant transformation of white sponge nevus is exceptional, but Downham and Pleaser reported the occurrence of an oral squamous cell carcinoma within a white sponge nevus. Thomas et al. Reported that the long-term administration of prednisone induced the malignant transformation of white sponge nevus. Stefan et al. Reported 12 patients in a 4-generation family developed white sponge nevus-related oral cancer. Squamous cell carcinoma. The downregulation of keratin 4 and 13 were detected in a study of oral squamous cell carcinoma. Thus, there might be a relationship between missense mutation in keratin 4 and 13 genes and development of malignant oral lesions. There is no treatment required in case of asymptomatic oral white sponge nevus. Various molecules were tested to reduce the clinical presentation of white sponge nevus. This include beta-carotene, antibiotics, antihistamines, local application of retinoic acid, tetracycline, mouth rinser, surgical resection, and laser ablation, but without any success. Concluding my presentation, like even though white sponge nevus does not entail any symptoms and therefore no treatment required, there's a need for precise identification through prompt histopathologic examination to differentiate this condition from more serious, potentially premalignant lesions, as well as other genodermatosis, and also strict regular follow-up as necessary. These are my references. Thank you.
Any positive family history was there?
Madam? No, madam. There's no positive family history for all these patients.
Okay. Other than Mosigaccio, Baccarum, and this leukoplakia, what all lesions will you consider in your differential diagnosis?
We can consider as candidiasis, then leukodema, then leukoplakia, and lichen planus also can be different as a differential diagnosis coming in these cases.
Hello.
Sir?
Hello.
Sir?
Can you hear me?
Yes, sir. Yes, sir. I can hear.
Usually, all the forms of candidiasis are scrapable form. When you're considering the white sponge nevus, it is not a scrapable lesion, isn't it?
Yes, this white sponge
Which type of candidiasis you include in the DD?
It's hyperplastic candidiasis like lesions are sometimes non-scrapable.
Okay, thank you.
Thank you.
Thank you. Next, we have paper presented 12. Is paper presented 12 ready?
Good morning. Today, my topic of presentation is a rare encounter, ameloblastic fibroadenoma in a pediatric patient. As an introduction, ameloblastic fibroadenoma is a rare benign mixed orogenic tumor. It is also called as dentinoma or fibroameloblastic dentinoma, and it is composed of odontogenic epithelium, immature connective tissue, and characterized by formation of dysplastic dendrin. Here, an 8-year-old male patient presented to our department with a swelling on the left side of the face since 3 months, and it is not associated with any toothache or any other difficulties. Extraorally, a facial asymmetry noted with swelling extends anteroposteriorly from left corner of the mouth to left angle of mandible and supra-inferiorly from the level of alatragal line to lower bottom of the mandible. On palpation, there is no local rise in temperature, it was non-tender and uniformly hard in consistency and smooth surface. Intraorally, a diffuse swelling on the left side of the mandible in relation to 753637 region is noted. Obliteration of mucobuccal sulcus and extension of buccal and lingual cortex was evident. Clinically missing teeth is 75 and 36. There is helium biopsy site with sutures covered with food debris on the alveolar ridge with respect to 75 and 36. And our provisional diagnosis was benign odontogenic cyst, possibly dentigerous cyst in relation to 36. And differential diagnosis is benign odontogenic tumor, possibly ameloblastoma. Investigations, radiographic examination, panoramic radiograph shows a mixed radiolucent radiopaque lesion on the body, left body ramus region. Anteroposteriorly, it extends distal to 7.4 to
0.5 centimeter anterior to posterior border of ramus and supra-inferiorly from mid-ramus region to lower border of the mandible. Posterior-inferiorly displaced 3-6 with the specks of radiopax foci scattered within the lesion, and the margin is well defined and corticated except at the superior border. This imaging shows well-defined mixed radial and radiopaque lesion on the body ramus region with well-defined margins, corticated margins. Expansion of buccal and lingual cortex was evident with the breach at multiple levels. Posterior-inferiorly displaced 3-6 and 7-5 is displaced within the lesion. Internal architecture is coalesced hyperdense structures of varying sizes and densities, suggestive of calcification, and the inferior alveolar canal cannot be traced on the left side. Radiographic diagnosis is benign odontogenic tumor, ameoblastic fibroadenoma in relation to 3-6. And histopathology was ameoblastic fibroma with extensive dentinoid formation. And final diagnosis is ameoblastic fibroadenoma in relation to 3-6. Case discussion. WHO defined ameoblastic fibroadenoma as a very rare neoplasm composed of odontogenic epithelium, immature connective tissue, and formation of dysplastic tendon. It is mostly common on the maxilla, mandible, then maxilla, and it is encountered first 2 decades of the life with the male to female predilection of 2.4 to 3:1. It is an intermediate stage between ameoblastic fibroma and ameoblastic fibroadenoma. It has been suggested that ameoblastic fibroadenoma is not a true neoplasm but a hematoma. Revision of 1992 WHO histological typing suggests that ameoblastic fibroma is a neoplastic lesion and ameoblastic fibroadenoma is a hematomatous lesion, which is capable of developing into ameoblastic fibroadenoma and further to complex adenoma. Conclusion. Although the ameoblastic fibroadenoma is a benign, rare, and non-recurrent tumor, its delayed eruption, missing or impaction of permanent teeth in pediatric patients emphasizes importance of early radiographic examination of these conditions for early detection, diagnosis, and treatment. Preference and thank you.
What about the status of ameoblastic fibroadenoma in 2017 classification?
It is considered as hematomatous lesion rather than neoplastic one.
I didn't hear you. Can you tell once more?
It is considered as a hematomatous lesion rather than neoplastic one. It is a benign mixed odontogenic tumor.
So it is still there in the classification. 17 classification, this lesion is there.
Ameoblastic fibroadenoma is not considered as a separate entity.
Okay.
Judges, please note that except for paper 6, all the participants have presented the papers. I want to thank the judges. We had Dr. Ashish R. Sir is Associate Professor, Government Dental College, Trivandrum, and we had one more judge, that is Dr. Atmaja K. Nair. Madam is Associate Assistant Professor, GDC Kottayam. Thank you so much, Sir and Madam, for judging our session. Thank you all the participants for actively participating. Thank you. So with this, we close the session of session 1, PG1. Thank you.
Okay, thank you. Thank you.
Thank
you.
Thank you.
Thank you. Bye. Have a good day.
Hello. 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 Hello.
അല്ല ഇത് ഈ അരവിന്ദ് സാർ വീണ്ടും ഇരിക്കണ്ടല്ലോ ഈ ആളല്ലല്ലോ പ്രസന്റ് ആളല്ലല്ലോ അല്ല ജഡ്ജ് ആയിട്ട് ഇരിക്കുന്നത്
ഇവിടെ വിളിച്ചു തുടങ്ങണ്ടേ നമ്പർ ഇല്ലല്ലോ പ്ലീസ് hold on hold one. Yeah. സബിത ലിറ്ററേറ് കൊണ്ടിനകത്ത് മണ്ഡലില്ല സബിത കയറി സബിത കയറിയോ ഗായത്രി ഇന്ത്യ അതിനെ വിളിക്കും കുന്തലം കണ്ടലില്ല പ്രസന്റ് ചെയ്യാനില്ല ഇല്ല അതെ ഇവിടുത്തെ അല്ല ആ 20 24 26 ഉണ്ട് ഇനി പേരേ ഉള്ളൂ
23, 13 to 26 and foreign numbers. മാം ഇത് ഓർഡർ വേറെ കിടക്കണം ഇതേപോലെ വിളിച്ചാൽ മതി 13, 14 അങ്ങനെ വിളിക്കാണ് അല്ലെങ്കിൽ ഇത് കണ്ടിന്യൂസ് വിളിച്ചോണ്ട് 13, 14 പിന്നെ
5 ഇതിനകത്ത് വിളിച്ച് ചേഞ്ച് ഉണ്ടല്ലോ 13 കഴിഞ്ഞ് 14 താഴെയാണല്ലോ നടക്കുന്നത്
അവർക്ക് എന്തോ പരീക്ഷ എന്തോ ഉണ്ട് 14 താഴെ ചെയ്യണം
അപ്പൊ ഈ ഓർഡറിൽ
ഓർഡറിലങ്ങ് വിളിച്ചാൽ മതി
അവസാനം അവരെ പ്രസന്റ് ചെയ്യാനുണ്ടെങ്കിൽ നമ്മൾ അങ്ങ് വിളിച്ചാൽ മതി അവർക്ക് അങ്ങനെ ഫോൺ നമ്പറോട്
ഫോൺ നമ്പർ 13 എന്തുകൊണ്ട് സബിതയാ
പേപ്പർ മേഡത്തിന്റെ
14 ലിസമ്മയാണ്
പോസ്റ്റർ എന്തോ ഈ
വീഡിയോ സ്റ്റാർട്ട് ചെയ്യാം അല്ലേ? എൻട്രി ചെയ്യാവും ചമ്പൻ എൻട്രി ചെയ്തിട്ടുണ്ടെന്ന് പറഞ്ഞു. അയ്യോ
ഡെൽറ്റ ബേബി എന്നാണ് കൊടുക്കുന്നത്.
Good morning, everyone. Welcome to the scientific session of Triple Conclave 2023. I welcome all the judges and delegates to the session. Today's scientific session will be paper presentation by postgraduate session 2. I would like to welcome judges of the session, Dr. Sunila Thomas, Professor and HOD, PMS College, Trivandrum, and Dr. Jinsi Thomas, Reader, PMS, Trivandrum. I welcome you, doctors.
Good morning.
Judges, please note that first presenter is paper 13. Is paper 13 ready with the presentation? Okay. You can start now.
Okay. Good morning. Today I am presenting a case report on adenocystic carcinoma of the tongue, a rare and stealthy intrusion. 20.8%. It has a relentless outcome and usually a fatal outcome. An early diagnosis is important as these are slow-growing tumors with a diffuse invasion. Coming to clinical presentation, a 72-year-old male patient reported to our institution with a complaint of swelling on the left side of the tongue since 1 year, and the swelling was occurring spontaneously, and the size of the swellings gradually increases to the present size, and patient doesn't have any complaint of any pain, but patient had difficulty on the protruding the tongue. And on extraoral examination, a submanda lymph nodes which are palpable on the left side, which is non-tender and which is normal in soft in consistency, and which is freely mobile. And intraorally, on examination, swelling approximate size 2.5 into 2.5 centimeter square, which is present on the left side of anterior two-third of the tongue, which is crossing on the midline, which are present on the ventral dorsal and alto surface of the tongue. And and it involves the surface involve prominent blood capillaries present on the surface, and also on palpation it is both fixed and non-tender. Provisional diagnosis is a malignant minor salivary gland neoplasm. Differential diagnosis is granular cell myoblastoma, schwannoma, and investigations we have done are USD, CECT, and histopathology. The USD shows us a mixed echoic lesion, predominantly hypoechoic, and its margins are ill-defined except at the inferior aspect, which shows a deeper invasion, and also a lymph nodes which is present level 1B lymph node which is present on the left side with an intact hilum, and also it shows us increased vascularity on the color Doppler and increased flow on the power Doppler. This suggestive of a malignant neoplasm on the tongue, and irregularly enhancing soft tissue lesions involving the left side of the tongue, and which is approximately size about 3 into 2 into 2 centimeter square, and which is present on the left side anterior two-third of the tongue, and causes an involving the extrinsic muscles of the tongue, and also a lymph node of approximately smaller size 3 millimeter noted on the left side of this mandible. And all this, and with the involvement of the extrinsic muscles of the tongue, it also suggests of a malignant neoplasm. Then histopathology reveals us we get base load appearances of tubular patterns and cribriform appearances. Predominantly, we get tubular pattern. So the histopathology diagnosis is adenocystic carcinoma, predominantly of tubular pattern. And the final diagnosis is adenocystic carcinoma, predominantly tubular pattern. Discussion: adenocystic carcinoma developed on the ventral surface of the tongue is extremely rare, and the peak incidence occurs predominantly among females between 5th and 7th decade of life. In our case, it describes the age, which is agree with that of the observation regarding the age. The most striking features of adenocystic carcinoma is a locally aggressive, high recurrent level perineural invasion, slow growth, and distant metastasis lesion. The distant metastasis usually occurs to lung, then to brain, and then to the bone. Clinical cause of an adenocystic carcinoma of the tongue is painless, slow submucosal growth of the tumor, which hinders its early diagnosis. Histologically, adenocystic carcinoma is a basal epithelial tumor consisting of epithelial and myoepithelial cells. Presents 3 different varieties, that is cribriform, tubular, and solid. According to Person et al., the predominantly tubular pattern has the best prognosis, and predominantly solid pattern has the worst diagnosis. The presenting cases reported was of predominantly tubular pattern. Possible treatments of adenocystic carcinoma include surgical therapy, radiotherapy, and chemotherapy. And in our cases, we had done the surgical therapy and with an adjuvant radiotherapy. So conclusion: adenocystic carcinoma is a very infiltrative and poorly exophytic growth. That is, it inverts more, and in usual inspection, it looks like a small nodule, which is suggesting of a fibroma or benign lesion. That is, most often no mucosal ulceration is observed. Also, because of the rarity of the lesion, can often lead to misinterpretation or late diagnosis. So, an early diagnosis is important, as these are slow-growing tumors with a deeper inversion. So, adenocystic carcinoma is a rare and stealthy intruder. These are the references. Thank you.
Okay, thank you, Doctor, for the presentation. I have a few questions.
Yes,
what is the staging of malignancy here?
Grade 1.
Grade 1. Okay.
Yes,
in this case, the location was on the ventral surface of the tongue.
It's on the mainly on the ventral surface, then on the lateral surface, and on the dorsal surface also somewhat swelling is there.
Okay. Which is the most common site for adenoid cystic CA?
Sorry, ma'am. Which is the?
Which is the most common site for adenoid cystic carcinoma?
Sorry, ma'am.
Most common site for adenoid cystic
Hello?
carcinoma. Am I audible? Hello? Hello? Most common site.
Hello?
Can you, which is the most common site for adenoid cystic carcinoma?
For the minor salivary glands, it is palate.
Okay. So your case is rarity, where it is occurred on the undersurface of the tongue.
Yes, ma'am.
Okay. And then regarding the duration, you have said that it is 1 year duration.
Yes, ma'am.
So in your provisional diagnosis, what made you think that it could be a malignant lesion?
Because it extends into a wider areas, not only to the ventral surface, it extends to lateral surface and also to the dorsal surface. That's why we thought it has a large tumor, which may occur with a extension to the side areas.
Okay. Actually, it is long duration, but it's a locally aggressive tumor. Okay, so probably,
yes, yes.
Probably that could be the reason for your provisional diagnosis. Okay.
Yes, ma'am.
Okay, fine. Thank you.
Thanks.
Thank you. Next, we have paper presentation 23.
Can I start?
You can.
Can you share the screen?
You can share your screen.
Am I audible?
Yes.
Sleep is a golden chain that binds body and health together. Good morning, one and all. I'm here to present the paper topic, Gas Culprit OSA. What is sleep? Sleep is a condition of body and mind that occurs every night for several hours in which eyes are closed, the postural muscles are relaxed, and the activity of the brain is altered. Typical sleep architecture consists of 4 cycles. The stages of sleep are classified into non-rapid eye movement sleep and rapid eye movement sleep. Non-rapid eye movement sleep consists of stage 1, 2, and 3. Out of this, the stage 2, that is the most prevalent phase, and stage 3 phase is very essential as it supports and strengthens the immune system. The benefits of a good night's sleep is that it regulates our internal body clock, supports growth and repair, supports emotion processing, it aids in memory building and learning, crucial for waste disposal from the brain, and it maintains hormonal balance, metabolism, and immunity. And what if the sleep is disturbed? It causes systemic manifestations such as anxiety, depression, high blood pressure, stroke, brain fog, arrhythmia, obesity, impotence, low blood oxygen levels, congestive heart failure, and type 2 diabetes. What is general sleep medicine? The discipline concerned with the study of oral and maxillofacial causes and consequences of sleep-related problems and their management with oral appliance therapy and upper airway surgery. The dental sleep disorders are classified into sleep-related breathing disorders, which includes snoring and obstructive sleep apnea, the orofacial pain, which includes toothache, TMJ pain, headache, the oral moistening disorders such as dry mouth and hypersalivation, gastroesophageal reflux disease, mandibular movement disorders such as mandibular dystonia, maxillofacial dyskinesia, and the most common is the bruxism. A dentist sees to the oral manifestation of sleep disorders such as attrition, loss of periodontal attachment, tooth mobility, fracture of tooth, xerostomia, hypersensitivity, changes in facial profile, high palatal wall, and narrow mandibular arch. The dentist also sees whether the throat is inflamed or swelling, and also sees to the size of uvula, tonsil, tongue. A good laugh and a long sleep are the best cures in the doctor's book. A dentist is often the earliest diagnostician, and he carries out it through a setup process, that is screen, educate, test, understand, and present the history to the patient. Once the sleep disorder is discovered, the quality of sleep and the sleep habits are better assessed through polysomnography, portable home sleep study, radiographs, and CBC. Polysomnography is the go-to method, and the portable home sleep study is well tolerated by the patient. Radiographs and CBCT, they assess the extent of airway obstruction. The role of maxillofacial radiologist in dental sleep medicine is demonstrating the airway space through CBCT images. The treatment for sleep disorders includes CPAP, that is continuous positive airway pressure, which is used to treat moderate to severe cases, oral appliance therapy, which is used to treat mild to moderate cases, and further obstructive disorders are treated through surgical interventions. Why oral appliance therapy? Because it is easy to use, portable, effective, adjustable, comfortable, custom-made, palm-sized, less cumbersome than a CPAP, suitable for those who cannot accept CPAP. The effectiveness of intraoral appliance in management of OSA has shown that 51% preferred oral appliance therapy and 23% liked CPAP. The future of dental sleep medicine, recognition and management of sleep-related disorders by the dentist, more attention
You
for
have one more minute.
dental sleep medicine and dental curricula worldwide. Scientific research in dental sleep medicine is rising in more studies related to long-term clinical outcome. Grow your dental practice by helping patients achieve quality sleep. These are my references. Your future depends on your dreams, so go to sleep. Thank you.
Okay. What is the role of an oral medicine professional in obstructive sleep apnea in one word?
Diagnosing the sleep disorders through the oral manifestations.
Okay. What are the long-term implications of OSA? You have given a very good compilation of data, very good review. Can you just speak on what are the long-term implications of OSA? If you don't treat such a patient, if you don't diagnose such a patient, what are the long-term implications?
Obstructive sleep apnea, if not diagnosed and treated properly, it is actually a grim reaper. It can lead to even death of a patient if not treated.
Okay. Any long-term ill effects?
Ma'am, it can cause xerostomia. And also it can lead to the xerostomia. It causes decrease of salivary secretion, which can lead to other dental problems like dental caries.
Okay, fine. Okay. Thank you.
Thank you.
Thank you. Next, we have paper presentation 16. Is paper presenter 16 ready?
Background
You can start your presentation.
Am I audible to you?
Yes.
Good morning. My topic is on low-level laser therapy versus pharmacotherapy in improving myofascial pain. It's a pilot study. We all know temporomandibular disorders are a group of pathology which involves the TMJ, masticatory system, and also the associated structures. And this myofascial pain syndrome is a chronic pain condition which affects the musculoskeletal system. Myofascial pain has got a characteristic feature, which is the trigger point, which is a very circumscribed region in which it's just relatively having a few motor activity. Trigger points are nothing but areas which are having high muscular contractions. While palpating on those areas, the patient may have pain. And this myofascial pain was first described by Travel and Windsor in 1952. And the common etiological factors are psychological, occlusal imbalance, and parafunctional habits. So in order to treat a myofascial pain, we have to give more concentration on the psychological aspect also. Mainly, we are doing conventional treatment for this condition. So now we can go for low-level laser therapy, which has both the analgesic, anti-inflammatory, and biostimulatory effect. It is a non-invasive therapeutic modality for myofascial pain. Laser is nothing but it's a light amplification by stimulated emission of radiation. It is first applied in dentistry by Niemann. We have got two lasers, the hard lasers and soft lasers. Hard lasers which can be used for both hard tissues and soft tissues. And soft lasers we are commonly used for this myofascial pain and all, which is highly compactable and which have less cost and has got a property of biostimulation. And this low-level laser therapy, as I told, it is analgesic, healing, and anti-inflammatory effects on the irradiated tissues. And my aim is to evaluate and compare the efficiency of low-level laser therapy in reducing pain intensity and improving the mouth opening in patients who have this myofascial pain. And my objectives are to evaluate and compare the low-level laser therapy on reducing pain, which is compared to the diclofenac sodium, and also comparing the efficiency of low-level laser therapy in the mouth opening. It's a pilot study. And the individuals with myofascial pain came to the Department of Oral Medicine and Radiology has taken at the study population. And the inclusion criteria were the subjects suffering from myofascial pain who have not received any kind of analgesic or antidepressant medications. And in the exclusion criteria, subjects who received analgesics or antidepressants and the patient who have received treatment for temporomandibular joint disorders and associated with rheumatoid arthritis. And coming to the procedure, and the study included 10 individuals which reported to the Department of Oral Medicine and Radiology, and these patients are divided into two groups. The study includes 10 individuals, and these patients were divided into two groups, and one group contained 5 individuals, and the other group is also containing 5 individuals. One group is given low-level laser therapy for 4 weeks within 1 week interval, and the other group have given diclofenac sodium 50 mg twice daily for 4 weeks. For laser, we have used cerulized blue diode laser 660 nanometer in continuous mode, up to 10 to 12 joule peak, 1 minute exposure on each trigger point or the muscles which are palpable. Patient is having pain at the time of examination at a 8 mm sport size of treatment, size as a treatment. And the pain intensity was measured by using visual analog scale, and the maximum painless mouth opening also measured, and the functional index before and after every session of this laser and diclofenac sodium. And these are the materials I have used. And coming to the statistical analysis, I have analyzed it using SPSS 26.
You have 1 more minute.
and the results came as in the case of mouth opening, only laser has given significant result. In case of pain, both group have got significant result, but within comparing within the intervals, laser has got significant result. So we can use laser as a promising therapeutic regimen for myofascial pain with less or no side effects. These are my references. Thank you.
Thank you. Your sample size was 30 or 10?
Sorry, it was a mistake. It's 10.
Okay. So you had 10 with low-level laser therapy, 5 with low-level laser therapy, and 5 with the
5 with diclofenac.
Okay. You said that you have given the laser application to the trigger points.
Yes, ma'am.
How did you identify the trigger points?
By examining the patient, where the patient is having pain on that area, we have given lasers.
Okay. What is the duration of one session of laser application?
On the trigger points, up to 1 minute on each trigger points, we have given like that, ma'am.
Okay. So it was done on one a particular day. Then you evaluated the pain using VA score.
Yes, ma'am. Once in a week we have done for 4 weeks. For 4 weeks, once in a week we will do.
Okay, once in a week. Okay, so you recall both the group of patients on a weekly interval?
Yes, ma'am. Yes, ma'am.
Okay. So regarding low-level laser therapy, your results are much more superior. That's what I understand. Okay.
Yes, ma'am. Regarding the pain, both the group have given a significant result, but comparing between the intervals, this laser group is more better. Regarding this mouth opening, laser group only has given a significant result.
Okay. So the reduction in pain was much more effective in case of low-level laser therapy. That's what your study is on. Okay.
Yes.
Okay. Okay. Good presentation.
Thank you, ma'am.
And one more thing, have you taken any precautionary measures while doing laser therapy? Any, or it was done routinely in the clinics? Is there any need for any precautionary measures?
Not like that, ma'am. We are not doing lasers on patients who's having any kind of systemic disorders, which is very severely ill-affected patients. No other precautions we are not taking.
Thank you. Next, we have paper presentation 17.
Next number is 17 or what?
Yes, ma'am. Paper presentation 17.
Am I audible, ma'am?
Yes, you are audible.
Shall I start now?
You can proceed.
Good morning, everyone. Today I will be presenting a case report on a rare lesion of inflammatory myofibroblastic tumor. Let's begin with the patient details. A 27-year-old male patient reported at OPD with a month-old history of pain in right maxillary posterior teeth region.
He reported intermittent episodes of dull aching pain and pus discharge from 1/7 region since 1 year, with a 1 month of mobile right maxillary posterior tooth. 1 week back, pain wasn't subsided and was referred to higher center for further evaluation. The patient had a history of uneventful COVID-19 infection 1.5 years back. His family, dental, social, and personal history were non-contributory. Extraoral examination was unremarkable with no facial swellings or asymmetry of cervical lymphadenopathy. On intraoral examination, mouth opening was limited, measuring approximately 18 mm, extraction socket of 1/7 with no associated separation, a diffuse erythematous mild swelling noted involving the distobuccal aspect of 1/6 and extending into the gingival sulcus, which was tender on palpation, soft and non-indurated. Tooth was tender on percussion with grade 1 mobility. There was limitation in examining the maxillary posterior region due to trismus. Coming to the investigation, panoramic radiograph was taken, which showed no bone distal to 1/6 region and loss of right maxillary tuberosity. Discontinuity of floor of right maxillary sinus noted. To find the exact pattern of bone loss, CBCT was taken. Normal hypodense appearance of right maxillary antrum was lost with a filling lesion, and sagittal section showed the loss of antral floor, and coronal section showed the discontinuity in the posterolateral wall of maxillary sinus on right side. According to CT neck with contrast reports, there was an ill-defined heterogeneously enhancing soft tissue density mass epicentered in right maxillary sinus. Initial clinical diagnosis were differential diagnosis were maxillary sinus malignancy of minor gland origin and mucormycosis. After basic hematological evaluation, incision biopsy was done from right gingivobuccal sulcus and maxillary sinus, and biopsy revealed a granulomatous lesion composed of spindle cells arranged in fascicles and variably dense inflammatory cells with a prevalent plasma cell infiltrate. Immunohistochemical analysis was done, which revealed immunoreactivity towards smooth muscle actin and vimentin. Fibroblastic staining fibroblastic and myofibroblastic spindle cells, CD138 kappa and lambda positivity staining plasma cell population, and the final diagnosis was inflammatory myofibroblastic tumor, plasma cell granuloma. Various treatment options include the following. Usually the surgical excision is the mainstay of therapy for IMTs. However, corticosteroids have good response in many reported cases. In our case, the patient was started on a tapered course of oral prednisolone, 20 milligrams per day, initially for 1 month. On next review, he was advised to take mycophenolate sodium, which is an immunosuppressant, twice daily along with the tapered dose of prednisolone. 3 months later, he reported an improvement in mouth opening with no recent history of pain, and CT imaging showed a 50% decrease in the size of the lesion. Now let's look into the discussion part. IMT is a rare tumor lesion consisting of variable number of inflammatory cells and myofibroblastic spindle cells. Exact etiology and pathogenesis remains unknown, and various hypotheses suggest that the lesion may be infectious, autoimmune, syndromic, or traumatic in origin rather than neoplastic, and hence the name pseudotumor. First observed in lung by Brunn in 1939, and oral IMT was first reported in 1981. A total of 51 cases of oral IMT were reported in English literature till date. In Russia's presentation of this tumor is extremely rare, with a total of 19 cases with, reported in head and neck region. And treatment of IMT of head and neck region varies with pathological subtypes, location of tumor, degree of invasion, and possibility of complete resection. Conclusion: IMT in the oral cavity may be confused with other malignant neoplasm on clinical, radiographic, and histological appearance. Although the incidence of IMT in the maxillofacial region is rare, accurate diagnosis is valuable in distinguishing these lesions from their more serious competing differential diagnosis, as well as providing appropriate management. This presentation aimed to present the case of IMT in the oral cavity and provide an updated literature review of current cases of IMT in the oral cavity. Also, I would like to stress upon the scope of conservative approach to IMTs rather than resection, which is found to be effective in many previously reported cases, and oral IMTs should be included in the case differential diagnosis of localized gingival enlargement mimicking oral hyperplastic or reactive lesions. These are my references. Thank you.
Okay, we have presented an extremely rare case of inflammatory myofibroblastoma of the maxilla, which would have been easily mistaken as a maxillary sinus malignancy, because it is clearly evident that there is disruption of the floor of the maxillary sinus. This could have been easily mistaken for a sinus malignancy. Okay. Now, one thing which was noted in the panoramic radiograph was missing 17 and 18. Was there any history related to that? Why was this teeth extracted?
Patient had a history of pain since 1 year, ma'am, and he went to consult a private clinic, and he was advised to extract that 17, which was mobile. 1 week back, when the patient visited our college, he had a history of extraction of 17 1 week back, which was mobile. And on examination also, 16 was also had mild mobility, grade 1 mobility, and tender on percussion.
So is it related to the disease process or not? The
Yes,
pain in relation to the posterior teeth.
Yes, ma'am, it has relation. Actually, the bone has resolved, 1718 region. The bone is completely lost up to maxillary tuberosity region.
Okay. Your case was treated with the surgical therapy and corticosteroid.
No, ma'am, no surgical therapy was done. He was under corticosteroid therapy. For the first month, he was under oral prednisolone, 20 milligrams per day initially. And then he was advised to take immunosuppressants along with prednisolone for next 1 month. So after after the review after 3 months, he showed improvement in mouth opening, and also he had no recent history of pain. And also follow-up CT showed a 50% reduction in the size of the mass.
Okay. Did you take a follow-up radiograph?
Follow-up CT
was taken.
Yes.
So was there bone formation, or you have the picture with you? You have not included in your presentation.
I have got that report only, ma'am. I have included that report in my slide.
It is if you could have included the post-treatment and the follow-up radiographs also. Even if CT was not available, you could have included at least an OPG for a completion. Okay. Okay. Anyway, nice presentation. Thank you.
Thank you.
Thank you. Next, we have paper presentation 18. Is paper presenter 18 ready? Can you please share the screen?
Yes. Hello, ma'am. Am I audible? Hello.
Yes, you are audible.
Yes.
Can I start, ma'am?
You can start with your presentation.
Hello.
Please make it into slideshow. Your presentation in slideshow.
Is it okay now?
You can start.
Very good morning to all of you. So today, I'm going to talk about Langerhans cell histiocytosis, a case report with unusual gingival enlargement. We all know Langerhans cell histiocytosis is a disorder of the reticular endothelial system, which is characterized by an abnormal proliferation of histiocytes and eosinophilic leukocytes. The nomenclature histiocytosis X was coined by Lichtenstein in 1953, and the term refers to the proliferation of histiocytes and other inflammatory cells, whereas the letter X was added to denote the unknown etiology of the disease. Going to the case, a 23-year-old female patient, a homemaker, had come to the Department of OMR with a chief complaint of receding gums in the upper and lower back tooth region since 2 months. As you can see in the figure, She revealed a history of pain on upper and lower back region of gum while eating food, and the pain was deep, dull, aching, and localized on receding gum region after warm saline water application. Patient also noticed deposits 6 months back. History of bleeding was also reported while brushing. Exudation and bad breath was also present. Now, on revealing the medical history, patient had reported that there was 10 to 15 kg of weight loss, which was observed within a year. There was no significant family history, and personal history revealed infrequent brushing habit. On intraoral examination, as you can see in the pic, I hope it is visible.
Now it's visible.
Hello. Is it visible, ma'am? Because I can't.
You can go to the previous slide and then come again so that it will be visible. Now it's not visible. Yes.
I don't know why what's happening. It's again. Okay. A generalized gingival hyperplasia on the palatal aspect was seen extending from 1.6 to 2.6. The color of the gingiva was somewhat erythematous with punched out border, was soft and edematous, bleeding was present, and there was generalized pocket present. And as usual, the treatment done was on the first visit, second visit, full mouth oral prophylaxis, and we advise the patient to use warm saline and reviewed after a week. Then we also advise the patient to use ultra soft toothbrush, and capsule amoxicillin was given 500 mg for 5 days with Metrogyl, Meftalfort, since she had pain. And we also advised to use Rexidin mouthwash. So after this, the patient was having much relief, and then the COVID lockdown started. So next, after a year, the patient came back to us. That was the third visit. And here, during the third visit, we had extracted, some extraction procedure was there for the patient. So that we had completed. And again, because of the gingivitis, because of the aggressive periodontitis nature, we again started, we had put
You
her
have 1 more minute.
We had put her on medication again. And again, on the fourth visit, that is after 1 week, it was again aggravated. Now, this made us to go further with the investigation of OPG. Which showed aggressive periodontitis, because generalized bone loss was also observed. And because of this, we thought of doing a we thought of taking a physician's opinion, where this was the result. So this led us to go for biopsy. We did the incisional biopsy and came to a conclusion that it was Langerhans.
Your time is up.
Yes. Hello.
Hello.
Hello. Yes, ma'am.
Your presentation is over?
Yes, ma'am.
Okay. Langerhans histiocytosis lesion, which can be easily mistaken for a periodontal disease. Okay, so that was the case which you have presented. Case with an aggressive periodontitis, probably because of the non-healing lesion, you have gone for further investigation. Okay, so one of the very prominent feature in the panoramic view which you have shown is the second panoramic view that was taken a year later. That was showing a destructive lesion. And
Yes.
one thing which was remarkable, that was near the area of the mental foramen, you can see a well-defined radiolucency also. Probably, was it noted or what?
Yes, ma'am, it was noted.
Okay, so what?
There was generalized irregular diffuse radiolucency. That was like due to horizontal and vertical bone loss, especially in the posterior region of the jaws, both the jaws. And the periodontal ligament space was also widened, and there's discontinuity at the periapical region of most of the teeth in the posterior region. This is what actually led us to further investigate, ma'am, with the incisional biopsy in the posterior region.
How was this case treated once a diagnosis was made?
Yes, ma'am. Intensive chemotherapy was advised with low radiation therapy and steroids. If the patient is still, the treatment is still ongoing. Just 3 days back, the patient had come here. So follow-up is still going on, ma'am.
Okay, okay. So this is one case which we all should keep in mind, that periodontitis, especially the aggressive periodontitis, non-resolving cases, you have to go about with further investigations. Okay.
Yes.
Thank you.
Thank you.
Thank you. Next, we have paper presentation 19.
Hello, ma'am. Am I audible?
Yes, you're audible. Can you share the PPT?
Good afternoon, judges and dear delegates. So here I'll be presenting an uncommon soft tissue tumor of the cheek, benign peripheral nerve sheath tumor, a case report. So coming to the introduction, peripheral nerve sheath tumors are a diverse group of tumors that can arise from various types of cells within the peripheral nervous system. So the incidence of which is about 1 to 5% of all the oral tumors, and the incidence of the oral peripheral nerve tumors is about 0.05%, that is 5 cases per 10,000 individuals. Here I'll be presenting a case where a 17-year-old male patient reported to our dental clinic with the chief complaint of swelling in the left side of the face since 1 year. And there was a history of small swelling, which was insidious in onset and gradually progressing in size. The patient had USG done. There was no history of trauma or decayed tooth. There was no history of pain or paresthesia reported. There was no relevant medical or dental history. Coming to the general physical examination, vital signs were under physiological limit. Patient was moderately built and nourished and well oriented to time, place, and person. Coming to extraoral examination, the swelling was a solitary, well circumscribed swelling in the left lower third of the face, approximately 2 into 2.5 centimeters in diameter. On palpation, the swelling was firm in consistency, non-tender, not fixed to the deep structures, and the skin overlying the swelling was pinchable. It was non-mobile and non-fluctuant. Intraorally, it showed as a dome-shaped swelling in the left mucosa, about 2 to 2.5 centimeters, and there was no evidence of any erythema or ulcerations. And on palpation, it was non-tender, firm in consistency, non-fluctuant, non-mobile, and there was no evidence of pus discharge or bleeding. To summarize, a 17-year-old male patient with no other medical comorbidities came with a chief complaint of swelling in the left cheek region since 1 year, which was sudden in onset and gradually progressing with no other symptoms. On examination, a solitary, well-circumscribed swelling was noted on the lower left side of the face approximately 2 into 2.5 centimeters, which was firm and fluctuant in consistency. So the clinical diagnosis of benign soft tissue tumor was given with the differential diagnosis of other soft tissue swellings such as hemangioma, salivary gland tumors, tumors of connective tissue, adipose tissue, neural tissue origin, and vascular tumors. The USG report showed that hypoechoic tissue lesion approximately 2.5 into 2 into 1 centimeter was noted, giving an impression of fibroma granuloma. Investigation orthopantomograph was done, which showed no evidence of any soft tissue invasions or any bony involvement. CECT scan showed a well-defined enhancing lesion measuring 1.9 into 2.5 into 2.9 centimeters, and it was infiltrating into the left buccinator muscle. Further, the histopathology was done, which showed well circumscribed, composed of bland spindle cells, and extravasation of the RBCs were also noted. So benign, the diagnosis of benign spindle cell neoplasm was given. Next, further, the immunohistochemistry was done, showing benign peripheral nerve sheath tumor with the secondary degenerative changes, where the Ki-67 proliferative index was less than 3% in hotspots. So the final diagnosis of benign peripheral nerve sheath tumor corresponding to the left cheek region was given. The treatment was patient underwent a wide local excision, and follow-up was done for 1 year, which showed no recurrence. So coming to the discussion, the peripheral nerve sheath tumors can be divided into benign and malignant. Under benign, it is schwannoma, neurofibroma, perineuroma, and malignant peripheral nerve sheath tumor. So under this schwannoma, neurofibroma, and malignant peripheral nerve sheath tumors are the most commonly occurring. So the histochemistry, immunohistochemistry diagnosis is the important part in this study because the IHS can differentiate between types, and here predominantly the Ki-67 marker was more evident. And hence the benign ones showed good prognosis, and the malignant ones had a higher recurrence rate with the increased survival rate. Thank you.
Okay. A good case. In your clinical diagnosis, you have given one of the diagnoses as hemangioma.
Yes, ma'am.
And also as vascular tumor.
Yes, ma'am.
One of the differential diagnosis.
Yes, ma'am.
In any way, did you, in your clinical examination, did you find that there was pulsatility?
No, ma'am, there was no pulsatility as such.
Any color change?
No, ma'am. It was a normal skin overlying, and inside the buccal mucosa also, it was the normal mucosa only.
Okay, so what made you diagnose as hemangioma?
More basically, we thought of a submucosal hemangioma, which
the differential diagnosis, I think that is not required. Okay, hemangioma or vascular tumor, because all the clinical signs were negative. Okay.
Yes, ma'am.
Your provisional diagnosis is okay. But I'm speaking of the differential diagnosis. Okay.
Yes.
So no need to add so much of differential diagnosis, only 1 or 2 or 3 diagnoses, which is most closely related to your findings. Okay,
Yes.
so that would be better. Okay.
Yes.
What is the prevalence your case is schwannoma? Finally, your diagnosis is schwannoma. What?
No, ma'am. It was given as a benign peripheral nerve sheath tumor.
Sub-classifications
So the
were not
further
given.
classification was not given since the further immunohistochemistry was required and the patient couldn't afford for it.
Okay, fine. Okay. Okay, thank you.
Thank you, ma'am.
Thank you. Next, we have paper presentation 20.
You can put in slideshow.
Start with your presentation.
Good afternoon, all. Today, I am presenting a paper based on my pilot study entitled as Correlation of Linear Measurements of Mandibular Condyle and Roof of Glenoid and Gender using cone beam computed tomography. The mandibular condyle and glenoid fossa are the important in craniofacial development and the influences its morphology. The CBCT is an diagnostic helps in the 3D analysis with relatively less radiation exposure. The pilot study was designed to correlate the linear measurements of condyle and glenoid fossa gender using CBCT. The aim of my study was to correlate the measurements of the condyle and glenoid fossa among different age groups using CBCT. My objective was to assess the using CBCT the length, width, height of the mandibular condyle and the thickness of the groove of the glenoid fossa. And I compared and correlate among different age groups. And the secondary objective was to compare among the different genders and sides, that is right and left. Materials and methodology. I have taken the archive CBCT images from our institute of both males and females, an age group of 15 to 30. I divided the groups population into three based on the age groups, that is 15 to 30, 31 to 45 and greater than 45. And intrusion criteria include the images of males and females greater than or equal to 15 years and which are having a clear area of TMJ visualization. And we excluded the trauma, fracture, pathology, surgery, and congenital anomaly in the TMJ areas. The procedure was, we have taken the archive images from our institute, which is taken in CBCT Denray SS CBCT machine and using the software on-demand 3D software. We measure the linear measurements of the condyle and roof of glenoid fossa as described by Alkosh et al. And we measure the length, width, height of the condyle in millimeters and roof of the thickness of the roof of the glenoid fossa in thinnest portion, which is the thinnest portion in millimeters. So first we measure the condylar length. Is we can see the points like AO, ACO to PCO. The distance is measured and considered as the condylar length. And we consider the condylar width as MCO to LCO. Then from the figure, we can see that sagittal in the sagittal plane, we measure the condylar height in the perpendicular distance from SCO to the line drawn inferior sigmoid tangent to the posterior surface of the ramus. And it is considered as the condylar height. And the thickness of the roof of the glenoid fossa is also taken in the sagittal plane, and the distance is between the OC and IC. And results, we have taken the
You have
data
1 more
and
minute.
tabulated, and statistically it is analyzed. And overall intra or oral group comparison, right side, we have a significant value that length and width and height was more in young age, and the thickness of the glenoid fossa is more in elder groups. And in the left side, we have a significant condylar height, which is more in younger group, and the thickness of the is directly proportional to age. And the gender, we have both are men's are having a right and left, both are having a greater value. And during the condylar measurements, we have got the younger group. Alkoshi et al. Is having a result that mean values are more in males. And Chaurasia is in 2017 having the height less than 20 years. Our study, we have got a greater value in younger group. And thickness also more in men's. And conclusion, for suggestion of future, we can consider as a radiological marker for the thickness of the roof of the glenoid fossa, and CBCT is a valuable diagnostic aid for the linear analysis of TMG. Thank you. These are my references.
Okay, thank you, Doctor, for the presentation. So your results, what I have understood is the height of the condyle is greater in younger individuals and also in men. Okay. And about the thickness also, it is more in the younger individuals and in men. Is it that? Thickness of the roof of the glenoid fossa.
It's increasing as the age increases, it increases.
As
In,
age increases?
in the age group, we have a third group greater than 45 years. That group is having greater the thickness
of glenoid fossa.
Yeah.
Okay, so what I have understood is with the increasing age, there will be decrease in the condylar dimensions, and with increasing age, there is increase in thickness of the roof of glenoid fossa.
Yes, ma'am.
Okay, so the so this can be used as a radiological marker in studying
marker for the arthritis patients.
Okay. Has there been any similar studies conducted earlier?
Lesser studies are conducted over this, so I have chosen this topic.
Okay. Okay, thank you.
Thank you.
Thank you, ma'am.
Next we have paper presentation 21.
Am I audible, ma'am?
Yes.
Hello.
You can start your presentation.
Good morning, everyone. My topic for today is sarcomatoid carcinoma, a fatal condition. The patient detail is 65-year-old male, came to the dental OPD complaining of a balloon-like growth in the mouth since 2 days. And patient had reported with a white lesion on the tongue in 2019, and incisional biopsy was done, and the lesion regress is reported by the patient. The current growth was initially small in size and gradually increased to the present size with restricted tongue movements. Gives a history of pain and breathing difficulty and restricted mouth opening with a negative history of fever, sudden weight loss. Relevant medical history of known case of hypertension and under medication. Past dental history shows biopsy was done on hyperorthokeratosis with oral submucous fibrosis like changes early. Personal history, a person is tobacco chewing gutka since 10 years and drinking alcohol since 20 years, and patient reports that he quits the habit 2 months back. On general examination, the patient had tachycardia. On extraoral examination, the patient's mouth opening was restricted 20 mm. And on intraoral examination, generalized gross attrition was noted, and thorough examination was not possible as the growth was restricting the view. And oral hygiene status was really poor with tobacco stains present. On soft tissue examination, ulceral infiltrative growth measuring 6 to 5 centimeter in size noted, involving left retromolar trigant, extending to the left buccal mucosa and involving tongue. The growth is covered with slough and dispersed white patches and appears blackish brown in color. Oropharynx couldn't be visualized, and the position of the tongue was pushed down due to enlarged mass. Non-tendon palpation, soft to firm in consistency, and is a solid mass. On clinical diagnosis based on the reports, it was malignancy with
Paper 21. Are you done with your presentation? You're not audible. Sulla ma'am.
Yes.
And 21 ma'am. Is it over or?
21 is not over. Something happened with the slides.
Yeah.
It is not moving. I think we'll give her one more chance.
Yes, ma'am. We can go to the next presenter, right, ma'am? Shall we go to the next one and later we'll give her a chance?
Yeah, sure.
Is it fine? Okay, thank you, ma'am. Paper presenter 22. Are you ready with the presentation? 22, are you ready with your presentation?
Yes, ma'am, I'm ready.
Okay, then proceed.
Good morning, everyone. Good afternoon, everyone. Today's my presentation topic is dentigerous cyst in pediatric patient, a case report. So introduction, dentigerous cysts are one of the most common developmental type of odontogenic cyst occurring in the oral cavity. It is attached to the cervical region of an unerupted tooth and enclosing the crown. Their exact etiology is unknown and may be referred to as follicular cyst. These cysts develop from remnants of reduced enamel epithelium around the crown of an unerupted or impacted tooth attached at the level of CJ. They are second most common, and they are 20% of the epithelial lined cyst of the jaw. Then highest incidences occur during the second and third decade with a slight male predilection. Teeth most commonly affected are mandibular, third molar, maxillary canine, and mandibular premolar. So often manifested as incidental finding on dental radiograph or a symptomatic swelling clinically. Then here I present a case report of 13-year-old reported to the Department of Oral Medicine and Radiology with the chief complaint of painless swelling in lower left side of the jaw since 2 months. The swelling had apparently enlarged over the preceding months, leading to facial asymmetry. On general examination, patient was apparently healthy. Medical history was non-significant. Clinical history revealed that the swelling started as a small painless nodule, which increased to the present size over a period of 2 months. On extraoral examination, facial asymmetry was noted on left lower side of the face with no sinus opening or active pus discharge. Intraoral revealed a hard swelling in 3475 region, and there was obliteration of the buccal vestibule. Then, based on the clinical findings, differential diagnosis included periapical cyst and unicystic ameloblastoma, as there was no carious lesion since seen clinically. Therefore, periapical cyst was ruled out. OPG was advised. OPG showed a unilocular expansile radiolucent lesion seen in the mandibular left posterior region of the jaw of size approximately 3 into 3 centimeter, involving left body of mandible in the region of 3536 and 37. Erupting 3536 are displaced, and 36 lies in the close proximity to the inferior border of mandible horizontally. Root with 36 is dilacerated and is in the inferior border of mandible. Root resorption with 75 is evident, and developing tooth bud of 3-8 all third molars is evident. Condyle and coronoid process appears to be normal. So radiographic diagnosis of dentigerous cyst with 3-5 was made. Then CT scans was advised for the patient. CT scan reports revealed that non-enhancing expansile cystic lesion noted in the body of mandible on left side with impacted molar tooth which is suggestive of a dentigerous cyst. So differential diagnosis, the most favorable radiographic differential diagnosis for this case included dentigerous cyst, amyloblastic fibroma, unicystic ameloblastoma, KOT, and AOT. Treatment, marsupialization was considered as the treatment of choice for minimize damage and favor an uneventful eruption of the affected tooth. So prior to the surgery, routine blood and urine examinations were carried out and the results were within normal limits. After obtaining an informed consent, surgical intervention was performed under general anesthesia. Treatment procedure comprised of extraction of 7-5. The flap was reflected and the content of the cyst were evacuated, and the cystic cavity was thoroughly irrigated to remove any residual fragments and debris. The cavity was then packed with the iodoform glycerin gauze. The dressing was placed in such a manner so as to stabilize the displaced premolar in their minimally developed socket and to guide their eruption. Then the patient was the histopathological samples was sent, and the patient was advised to maintain good oral hygiene, and chlorhexidine mouthwashes was prescribed. Then, according to the histopath report, it revealed that the cyst was lined by odontogenic epithelium lining and fibrous connective tissue wall. Odontogenic epithelium lining is a non-keratinized stratified squamous type of 5 to 6 cell layer, and epithelium lining shows cuboidal basal cell layer with prominent basal cell layer with flat epithelial cell interface. Few mucous cells are also noted. So, according to the histopath, overall diagnosis was suggestive of dentigerous cyst. So follow-up was done after 6 months. Yes, ma'am, I'm already done. Follow-up showed uneventful eruptive movements of the permanent mandibular left second premolar. And the conclusion, as they are dentigerous cysts are very uncommon in pediatric patient and in mixed dentition, and undiagnosed and untreated dentigerous cyst can lead to potential complication. A better prognosis can be expected in children as they have great potential to regenerate bony structure than adults. Therefore, a thorough and timely evaluation of the patient history coupled with clinical and radiographic examination would help in early diagnosis and treatment. Thank you.
Okay. Doctor, you have presented a case of dentigerous cyst in a pediatric patient. It is 13-year-old.
Yes, ma'am.
Is it a rare entity in a 13-year-old?
Yes, ma'am. It is rare because dentigerous cysts are most commonly associated with impacted third molars and then impacted maxillary canines. So it is rarely associated with the second premolars permanent.
Okay. So I would like to make one clarification on this regard, even though the histopathology was suggestive of dentigerous cyst. When you examine the panoramic view, actually the lesion has started from the lateral aspect. And you can see the intact follicular space in relation to the premolar. In this picture, you can see the follicular space is intact in relation to the second premolar. Probably the lesion would have been a lateral dentigerous cyst.
Lateral dentigerous cyst, yes, ma'am. Yes,
Then one more thing, the lesion, you have given one provisional as periapical cyst. Periapical cyst arising from which tooth? You have given it as a differential diagnosis, I think. Periapical cyst was also given as one of the differential diagnosis.
Yes, ma'am, periapical cyst, but it was not considered because there was no carious lesion or carious tooth associated with the cyst.
No, periapical cyst from which tooth?
Periapical cyst with the second, with the 7-4. 7-5, sorry, 7-5. 7-5.
So you should specify the tooth also when you give a diagnosis or differential diagnosis. Okay.
Yes, ma'am.
And another thing is you have given a DD of AOT also. AOT, the common site is maxilla or mandible?
Maxilla.
Maxilla. Okay, anterior maxilla is a common site for AOT. Okay. Now in the post-op picture, and one more thing, when you present cases like this, when you're giving CT picture, you give the picture which is most relevant. Don't give the picture of the whole CT, all the views. You pick out only the relevant pictures and project. Okay.
Yes, ma'am. Okay.
And regarding the post-treatment panoramic radiograph you have given, there was a lateral radiolucency, lateral to 6.
Yes, ma'am, that lateral radiolucency is still present. So we are hoping that if in case there is no eruption potential with the 6, so we'll let the second molar to erupt, and then we'll extract that second molar, and then 6 will get normally erupted in the place.
Okay.
So depending upon the eruption potential, we'll decide the further treatment.
So the patient is still under follow-up.
Yes.
So that is what I wanted to say. You have to regularly follow up this case because there is a radiolucency lateral to 6. You need not.
Yeah. Yes, ma'am. He is under the follow-up, monthly follow-up.
Because if it doesn't erupt, you have to think of extraction of 7 and allowing the eruption of 6 or vice versa. Okay, so the patient should be followed up.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you. Next, we have paper presentation 21. Judges, please note, it's paper presentation 21.
We are repeating the presentation because she couldn't complete the presentation. So judges, please note that it's paper 21.
Good morning, everyone. I'm presenting sarcoma root carcinoma, a fatal condition. The patient, 65-year-old male, came to the OPD complaining of a balloon-like growth in the mouth since 2 days. Patient had reported with a white lesion on the tongue in 2019. An incisional biopsy was done and that lesion regressed as reported by the patient. The current growth was initially small in size and gradually increased to the present size with restricted tongue movements. Gave a positive history of pain, breathing difficulty, and restricted mouth opening, and a negative history of burning sensation, fever, and sudden weight loss. Non-case of hypertension and under medication since 20 years. And the past dental history biopsy was done in 2019. And patient showed hyperorthokeratosis with background of oral submucous fibrosis like changes early. And personal history, tobacco chewing or gutka since 10 years and drinking alcohol since 20 years. And patient reports that he quit the habits 2 months back. On general examination, the patient had tachycardia. Extraoral examination, the patient's mouth opening was restricted 20 mm. Intraoral examination, generalized gross attrition was noted and thorough examination was not possible as the growth was restricting the view. And oral hygiene status was really poor with tobacco stains present. On soft tissue examination, ulcerative infiltrative growth measuring 6 into 5 centimeter in size noted, involving the left retromolar trigon, extending to the left buccal mucosa and involving tongue. The growth is covered with slough and dispersed white patches and appears blackish brown in color, and oropharynx couldn't be visualized. Position of the tongue was pushed down due to the enlarged mass and not tender on palpation, soft to firm in consistency, and is a solid mass. On clinical diagnosis, we found out that the malignancy with respect to left retromolar trigon extending to the left buccal mucosa, and the differential diagnosis of malignant transformation of oral submucous fibrosis. On investigation, panoramic radiograph shows tooth floating in space appearance and suspected pathologic fracture. Paranasal sinus view showed complete opacification of the left maxillary sinus and maxillary sinus walls and flows not appreciated. On complete blood count, hemoglobin, hematocrit, RBC count, platelet count, sodium were really low, and patient was referred to Department of Oral and Maxillofacial Surgery for emergency tracheostomy and biopsy. On incisional biopsy, came to the final diagnosis of sarcomatoid carcinoma with superimposed candidiasis with respect to left retromolar trigon and right lateral border of the tongue. Treatment plan habit cessation was reinforced in palliative care. Follow-up, early January in emergency trial with undetectable sarcoma with presence of maggots in the nasal cavity and foul-smelling discharge, and maggots were extracted and primary dressing was done and referred for palliative radiotherapy. Late January, post-RT ECOG1 condition and length bilateral air entry and referred for palliative chemotherapy. Mid-February, patient complaints of cough and palliative split RT first course was done, and however, patient started on palliative chemotherapy, paclitaxel plus carboplatin. The 20th February, patient had febrile neutropenia with septic shock, bilateral pneumonia, and patient was declared dead at 12 p.m. Discussion: sarcomatoid carcinoma, also known as carcinosarcoma, spindle cell carcinoma, pseudosarcoma, or pleomorphic carcinoma, is a rare malignant biphasic tumor containing both epithelial and mesenchymal components. It's a relatively uncommon form of cancer and is an aggressive form of cancer. Sarcomatoid carcinoma spreads fast and has poor prognosis. The management of SC has been a matter of debate owing to the rarity of the disease and the lack of treatment guidelines. Clinical features may arise anywhere from upper aerodigestive tract with a predilection for larynx and oral cavity. In common signs in mouth is alveolar mucosa, tongue, buccal mucosa, and lower lip. There's a male predilection, and mean age of diagnosis is 57, which is 29 to 93 years of age, and mostly appears as a pedunculated polypoid mass, which is ulcerated, can also appear in other forms, and pain and paresthesia were important clinical features. Treatment and prognosis: the treatment of choice is radical surgery with neck dissection when clinically positive nodes are present, and radiotherapy and chemotherapy might be ineffective. Adjuvant RT may be of benefit when surgical margins are positive. There's a 5-year survival rate for 30% of oral lesions, with most death occurring within 1 year of diagnosis. Negative prognostic factors includes endophytic growth and an origin from a previously irradiated carcinoma. Conclusion: a complex histogenesis makes the diagnosis of SC extremely difficult and often misleading and controversial. A clear understanding of clinico-pathologic characteristics and immunohistochemistry is indispensable for diagnosis and management of SC. Treatment should aim at controlling local and distant recurrence. Monophasic SC, which is devoid of classic carcinomatous component, is in some cases indistinguishable from a sarcoma. This leads us to wonder whether every case diagnosed as SC is actually a carcinoma or a true sarcoma. These are the references. Thank you.
So, in your case, you have given a history of incisional biopsy done for this patient earlier. Before,
yes,
that was from another site on the tongue.
Yes.
What was the diagnosis of the previous incision biopsy report?
Ma'am, in clinically it was diagnosed as Verrucous leukoplakia, but on biopsy it was found there was hyperorthokeratosis with oral submucous fibrosis early stage.
Okay. That biopsy was done in your center, or the patient came with a biopsy report?
In my center only, but someone else had seen the case before.
Okay, so that was a duration of 1 year from the initial biopsy till the occurrence of the second lesion.
Yeah, yes, ma'am. 1 year, but he came after 2 years.
The patient was not on regular follow-up.
He was, but he didn't tell anyone that he was having problem until and unless the breathing difficulty came. He couldn't breathe, so then he reported and he came.
Okay, so you would like to say that the lesion was there previously also in the retromolar trigon?
No, ma'am, it was not there.
Okay. Was there any paresthesia reported by the patient?
No, ma'am, nothing as paresthesia was not reported.
So only difficulty was breathing.
And pain was there.
Okay. What is the staging of malignancy?
Ma'am, mostly TNM staging is there. Tumor not metastasis staging.
In this case, what was the stage when he has presented to you?
Since it's a sarcomatoid carcinoma, which is both sarcoma and carcinoma.
Background എങ്ങനെ മാറ്റം പറഞ്ഞു എനിക്ക് ഇത് എല്ലാവരും ബാക്കിൽ സാധനം എന്റെ ഇനിയിപ്പോ ഇല്ലാണ്ട്
Ma'am, since sarcoma and carcinoma components were both there,
Excuse me, can others keep your mics on mute? Excuse me, can others keep your mic on mute? Excuse me. Can others keep their mics on mute?
Ma'am, stage.
Virtual background conclave. Background
Dr. Vidya. Dr. Vidya. Dr. Vidya.
Set 2. അതുകൊണ്ടല്ല അങ്ങനെ പറഞ്ഞാലേ
Dr. Vidya.
Okay,
Dr. Vidya.
Ma'am, stage 4 was stage 4 if it was like to be class staging, because it was like metastasis later to the lungs and all, and he passed. It was declared dead because he had bilateral pneumonia also, so there was distant metastasis to the lungs as well.
പക്ഷെ 130 ഉണ്ടാവണമെന്നില്ലല്ലോ ഇന്ന് അടുക്കപ്പോഴേ
Thank you, ma'am.
അതിപ്പോ ഇങ്ങനെ അറിയാം ഇതൊക്കെ ഇങ്ങനെ മനസ്സിലാക്കി ടീം
Dr. Vidya.
നേരിട്ടാണ് പോയി പ്രസന്റ്
Dr. Vidya, please keep your mic on mute.
how to change Zoom background.
Dr. Vidya, please keep your mic on mute.
കോൺസെൻട്രേഷൻ കൊണ്ട് പഠിച്ചാൽ
Paper 14, please wait. Paper 14, please wait.
Radiologics അഞ്ചാറ്.
We have to solve this issue otherwise it's very difficult for you to present.
Yes, ma'am, I'll wait.
Okay, thank you.
ചിരിപ്പിക്കല്ലേ കുറച്ച് പോകുന്നുണ്ട് ഞാൻ പിന്നെ പറഞ്ഞത് നീ മേലെ സെമിനാറെ ക്യാൻസൽ പിന്നെ എടുത്തിട്ടില്ല സ്ലൈഡ് പറഞ്ഞ ഇതല്ലേ പറയാൻ
Okay, now you can present paper 14. You can present.
Ma'am, am I audible?
Yes, you may please make in slideshow.
Yes, ma'am. Just 1 minute. I'm not able to. Ma'am, am I audible?
Yes, proceed.
Yes, ma'am. Good afternoon, respected judges and participants. Today, my topic is chronic recurrent multifocal osteomyelitis, a medical conundrum. This is a very fascinating medical condition, and it is being diagnosed more and more frequently in the dental OPD due to increase in awareness of this disease. So chronic recurrent multifocal osteomyelitis, also called abbreviation is CRMO, is an aseptic inflammatory disorder of unknown cause characterized by multifocal bone lesions with pain and swelling recurring over months to years. So chronic recurrent multifocal osteomyelitis is also known as chronic non-bacterial osteomyelitis or CNO. So let us now go into what this is. So it is an autoinflammatory bone disease of unknown origin. It mostly affects children and adolescents. The first case was described in 1972 by Gideon et al. So what makes it so different and so challenging to a dentist or to a doctor is that all the inflammatory sites which are biopsied and tested, they're all sterile. There is no bacterial origin of infection. Coming to the etiology, so CRMO most commonly affects the metaphysis of long bones, especially tibia, femur, and clavicle. The spine, pelvis, ribs, sternum, and the mandible are also affected. So from a dental aspect, for us, the mandible is very important, but the incidence of CRMO in the jaw bones is very uncommon and very rare. Only 1.5 to 3% of these cases are affecting the mandible. So this commonly occurs in childhood, and there is a female predilection of 2:1. Coming to the clinical features of bacterial osteomyelitis and the clinical features of chronic recurrent multifocal osteomyelitis. So even though it is called osteomyelitis, it differs a lot from bacterial osteomyelitis. Let's have a look. So in acute osteomyelitis, you'll have deep, intense jaw pain, high or intermittent fever, paresthesia, anesthesia of the lower lip, and a clearly identifiable cause, which is usually a deep cavity which has not been treated. Whereas in CRMO, there is a deep gnawing bone pain, there's fever, there's a swelling of the face, bony expansion, but there is no carious tooth, there is no pus, there is no sinus opening. So similarly, ma'am, there is a chronic bacterial osteomyelitis that will have fistulas, induration of soft tissue, there will be suppuration and a thickened or wooden character to the affected area. This is not seen in CRMO, and there is a mild and self-limiting variant or a chronic and recurrent variant. Coming to the clinical features of CRMO, this is affecting the whole body. There is bone and joint pain, fatigue, malaise, localized inflammation and swelling in whichever bone is affected, there the swelling will be noted. Now, there are two phenotypes of this CRMO. There is bone limited and complex. So the complex CRMO is usually associated with other systemic features like SAPHO. SAPHO is synovitis, acne, pustulosis, hyperostitis, and osteitis syndrome, where there will be skin lesions also seen like psoriasis. Patients can also present with inflammatory bowel disease, sacroiliitis, which is an inflammation of the sacral bone. And then coming to the radiologic features with the dental aspect. So the preliminary evaluation can be done by panoramic radiography. However, it's not as accurate as a higher imaging modality would be, like a CT or a CBCT. So in the CT, we'll find that there is a solid type of periosteal reaction, external bone resorption, and bone enlargement. So the radiographic features, they will show osteolytic lesions with a surrounding sclerosis and an altered trabecular bony pattern. CT is very helpful in distinguishing CRMO from fibrous dysplasia because in CRMO, there will be a smooth and lamellated appearance of new periosteal.
You have 1 more minute.
Coming to the diagnostic part, it's a diagnosis of exclusion. So history taking is very necessary. all the lab investigations need to be carried out. Usually in CRMO, there will be elevated ESR and C-reactive protein. Imaging techniques like X-rays, CBCT, CT are also very useful, and bone biopsies are the last resort. The treatment plan is NSAIDs, bisphosphonates, and if the disease does not subside, then disease-modifying anti-rheumatic drugs, and finally, corticosteroids. Caution is needed because the restraint from antibiotic therapy as well as repeated biopsy procedures is needed. My conclusion that this is a very challenging disease, and it will only be able to be diagnosed accurately if there is proper history taking. If we consider the age of the patients, the pattern of the disease, we should strive to be more aware about this, and we should consider that the side effects for the patient and monitor and guide the patient accurately. Thank you.
Okay, now there you have presented a case of osteomyelitis. So even though we say that osteomyelitis is related to bacterial infection, this what you have presented, CRMO, is a non-bacterial infection, which we should all keep in mind while diagnosing such cases. When you see cases which is non-resolving to other treatment, this should also be kept in the differential diagnosis. Okay.
Yes, ma'am.
So it was a good review. So what is, and you have given some diagnostic aspects like exclusion, then lab diagnosis. So what are the features, or what are the presenting symptoms by which you can think this as one of the differential diagnosis when such a patient comes to you?
Ma'am, actually CRMO, if I'm talking about the clinical features, ma'am, so the patient will come with a swelling, he'll have a fever, which is very similar to a normal osteomyelitis, but there's no carious tooth, there's no suppuration, no pus discharge. And ma'am, also even if we see in the blood reports, as I said, it's a diagnosis of exclusion because ma'am, even the blood reports, they don't show, they're not very specific. They're just mildly elevated ESR and CRP values. Everything else is normal. So what we should do is we should rule out things like fibrous dysplasia by using radiographs. Then we can rule out other conditions like OKC by different. Basically, we'll see the radiologic findings and we will differentiate between that because the CRMO has a characteristic type of radiologic appearance, ma'am.
So is a radiographic appearance, by radiographic appearance, will you be able to identify chronic osteomyelitis or differentiate from chronic osteomyelitis from a CRMO?
Yes, ma'am. Usually a moth-eaten appearance is seen, or and ma'am, in this there is not much of that appearance. It's just they are mainly like blank, empty spaces, or with a smooth lamellar border is noted, ma'am. Ma'am, and also for very accurate diagnosis, then a bone biopsy is suggested. In the bone biopsy, you'll find that there is a culture of the biopsy site, ma'am. So there you will notice that it is sterile and there is no evidence of any proper inflammatory cells.
Okay. Okay, thank you.
Thank you, ma'am.
Thank you. Next, we have paper presentation 26.
Am I audible, ma'am?
Yes, you are audible.
Start. Should I start?
Yes.
A very good afternoon to one and all. My topic is on the scope and the review of the fractal analysis in the dentistry. Firstly, the introduction part. Ma'am, 1 second. It's hanging. My slide is just hiding. Yeah. Firstly, the introduction part. The fractal is derived from the Latin word fractus, that means fractured or the broken. Fractal analysis is the mathematical method by which the irregular and the complex body structures may be evaluated. The quantitative outcome of this method is defined as the fractal dimension. Now, how is fractal analysis used in the dentistry? It is useful to quantify the trabecular changes after the jaw bone regeneration and the implant positioning, and in the evaluation of the morphological pattern of the jaw bones and its possible change over the time. For the detection and quantifying changes in the bone mineral content and architecture of the jaw bone in the osteoporosis, and in measuring the roughness of the implant surfaces. Now, fractals is of two types, true fractals and the false fractals. The true fractals go beyond the physical form as they can be temporal or spatial on the infinite scales and a repeated pattern. Digital images are false fractals in the strict sense, but these are the approximation of these true fractals. Now, various softwares used in the fractal analysis are the ImageJ, Fractalize, Vidon, Fraclac, Hosdim, and Fractal Analysis System for the Windows, and these are the references from where I took. Now, ImageJ for the fractal analysis. The most commonly used freely available software for the fractal analysis is the ImageJ. Based on the medical images by the White and Rudolph, they use the ImageJ software that measures the morphological features of the trabecular bone. And these are the references I took. Now, the methods for calculating the fractal dimension are the box counting method, differential box counting method, Pentland approach, reticular cell counting approach, Keller's approach, and Peleg approach. And these are the references from where I took the method for the calculating the fractal dimension. Now, the most common method for calculating the fractal dimension is the box counting method. Among the existing methods for calculating the fractal dimension, the box counting approach explained by White and Rudolph is mostly used for the binary images such as the periapical radiographs. In this method, FD is basically a measure of number of boxes needed to cover the trabecular pattern. Higher FD shows that the trabecular pattern is more complex. Now, steps in the fractal analysis are as follows. As the A part, you can see at that I've highlighted the region of interest, the selection in the periapical radiograph image immediately after the extraction. B part, you can see the highlighted selected region of interest, and C part after the application of the Gaussian blur filter. It's formed. Now, as on the D part, you can see the digital subtraction of the blurred region of interest from the initial image, and E, you can see the after addition of the 128 pixels to the existing image, and F, you can see the conversion of image to a binary image. Now, G part, you can see the erosion and dilatation of the image, and H part, you can see the inversion of the resulted image, and I, you can see the skeletonization of the image, and finally J, on J, the superimposition onto the initial selected region of interest to confirm the trabecular structures. Now, the fractal analysis in the radiographic images are used in the mandibular cortical index, that is MCI, mandibular cortical width, that is MCW, and these are developed to assess and quantify the quality of the mandibular bone mass and to observe the signs of resorption on the panoramic radiographs for the identification of the osteopenia, for the bone support of for the implants, and the magnetic resonance images. Now, the mandibular cortical index, as you can see here, the C1, you can see the normal cortex is there, and on the C2, you can see the moderately worn cortex, endosteal margin, lacunar resorption resulting in semilunar defects or the formation of the endosteal cortical residues. C3, you can see the eroded or the porous cortex that form the dense layer of the cortex, endosteal and clearly porous cortical remnants. Now the various studies in the fractal analysis in the imaging modalities were there. 78 articles were found in which the fractal analysis was used. Now the types of radiographs on which the studies were
You have 1 more minute.
Yes, ma'am.
You have 1 more minute.
Type of radiograph were used were the panoramic radiographs, periapical radiographs, Batwing radiographs, cephalometric radiograph, CBCT, micro-CT, and xylography, and the ultrasound. And the number of studies were 34 in the panoramic radiograph, 21 in the periapical radiographs, 4 in the Batwing radiographs, 1 in the cephalometric, 15 in CBCT, 3 in micro-CT, and 2 in the xylography and the ultrasound. Now, the advantages of the fractal analysis are the quantification of various parameters in the radiograph, application of the artificial intelligence, useful tool in the research. And various drawbacks are the not easy to understand, and it is a complex method, and it is not used in the bone mineral density. To conclude, the use of the FA in the dentistry has increased substantially in the last years, as the quantification of the trabecular bone is required in several dental specialties, and the use of the common dental images such as the panoramic and the periapical radiographs is preferred. Practitioners have at their disposal a free and easy handling system that allows them to analyze the image texture of their patient exam. Thank you.
Okay, doctor, you have given a briefing regarding what is fractal analysis in dentistry, right?
Yes, ma'am.
Is there any, you have shown digital images of IUPA
Yes, ma'am.
and panoramic radiograph also.
Yes, ma'am.
So is there any specific software by which you can do the analysis?
Ma'am, DEXA method is the method that we can calculate the bone mineral density, but the softwares are so many software, different software can also be used for the calculation of the tubercular bone pattern in the radiographs.
No, my question is, what are the softwares available for you to do the analysis? Can this software be installed in routine digital panoramic radiographs, radiography system?
Ma'am, they can be installed. Ma'am,
What are the available softwares?
Ma'am, I don't have any idea about the available softwares for that.
Okay. So one of the drawbacks which you have said is bone mineral density cannot be
Measured.
visualized, or bone mineral density cannot be calculated.
Yes,
Okay,
ma'am.
even though you can say that the thickness of the inferior cortex, the bone mineral density cannot be made. That is one disadvantage you have pointed out, right? Okay. How will you standardize this?
For standardized for bone
How
mineral
will you
density.
not for bone mineral density, for using this analysis, how will you standardize?
Ma'am, there are studies going on related for this because this is a newly developed software, so it's standardization is not done yet for the bone mineral, but the DEXA is used for the bone mineral density normally,
Yeah.
which is the gold standard.
Okay. Okay, fine. Thank you.
Thank you.
Please note that there is one more presenter in this session. She could not join our previous one, so she's presenting, that is paper 6. Paper 6 will be presenting now, but her name is not there in the score sheet. Kindly.
Yes, am I audible now?
Presentation also, ma'am. Paper 6.
Am I audible?
Paper 6.
What is the number of
Paper 6, ma'am.
6?
Yeah, 6.
Okay.
Am I audible?
Yes.
Is the screen visible now? Hello? Hello?
Your screen is not visible. The previous person has to stop screen sharing.
No, ma'am.
Can you make it slideshow? The screen is not moving. No, I think the previous slide is, previous presenter slide is there on screen.
Previous presenter has to stop screen sharing. Yeah, now we can see.
Thank you. My topic is about a study which we did in Conclave, analysis of clinical symptoms in patients with oral submucous fibrosis. As we all know, oral submucous fibrosis is a chronic progressive collagen metabolic disorder, commonly due to auricular chewing, and it is due to the imbalance of the fibroblast proliferation and excess collagen deposition. So, what we wanted to study was to see the clinical symptoms reported in OSM, which is more prevalent, disease prevalent, so that we get a better idea of the association of clinical symptom with OSM reading. And the materials is 1 year data of our college was collected around 155 cases, and non-chief specific chief complaints were eliminated. The grading was done using WHO accepted care and non-urea classification, and the specific complaints which we were splitting was burning sensation, pain in cheeks, reduced mouth opening, and ulcers in the mouth. So based on our data, we came across a very interesting finding that graphical representation revealed that 23.87% of patients would be have specific chief complaint. The rest had only non-specific chief complaint. That means the patients could have reported for another dental caries or pain management or replacement of missing teeth, and then they get referred to oral medicine because they have fibrotic band. So irrespective of whether they have fibrotic band or not, whether there is a restriction of mouth opening, the patients were able to come to the oral medicine department only when they have specific chief complaint. And among them, what we found was, the most common chief complaint which they gave was burning sensation and reduced mouth opening. The ulcers in the mouth and the pain in cheeks were reported only in 18.9% patients and 10.8% patients. And when we see the above data, the non-specific chief complaint reported with missing teeth, mobility, stains on teeth, and toothache. That means OSMO had also been an incidental finding, and the patients report the chief complaints only at the later stages in grade 2, grade 3, grade 4. Grade 5 was not included in the study because there is an also proliferative growth which will be referred to oncology. So whenever the take-home message for our discussion is, this is the first study to analyze the prevalence of symptomatic chief complaints, and it would also be an incidental finding in screening camps. And they had male prevalence. That doesn't mean all male, it is more common in this. They might have been reports where female patients would not have reported, they would not have been aware, because only male patients report only after specific chief complaints, that would later stages only. And lack of awareness in early clinical stages is also being reported. So take-home messages, in respect of the chief complaint, we as oral medicine practitioners is also necessary to look beyond the chief complaint, because we might be missing the early OSMO stages, which can be reversible with pharmacotherapy alone. Because when it comes to grade 2, grade 3, and grade 4, though there is standard corticosteroid therapy, intralesional, and hair physiotherapy, it is not gold standard standardized treatment, and there are a lot of research going on into that area. So it is important that we have to look beyond the chief complaint of patients in recurrent and probable tumors, because there would be early signs of OSMO which needs attention. Thank you. Hello.
Is your presentation over?
Yes, ma'am.
Okay. I have one query regarding the presentation. That is, you said about non-specific symptoms in OSF.
Yes.
So is it, you have said about toothache, mobility, or few non-specific symptoms were included. So I didn't get that point. That is it important in diagnosing a case of OSF?
Yes, because whenever a patient comes to the hospital or a private institution, we are driven towards a treatment based on the chief complaint. So not all cases, when compared to lichen planus, the patient will come with a burning sensation, and in patients with another pemphigus, they'll come with an ulcer and burning sensation. But when it comes to OSMO, most patients, predominant patients in grade 1 stages, had come for missing teeth replacement, mobility, for cleaning, or my toothache in wisdom teeth region. And then on careful examination by oral physician, oral medicine specialist, then they would have seen what the early stages of OSMO, they would be high fibrotic bands, and then they inform the patient, and then they get motivated for treatment. So what happens is, we always think OSMO patients will get reported with specific chief complaints, symptoms related to OSMO. It need not be so. It is one of an active research area that there are a lot of studies being coming in PubMed journals about non-specific chief complaints in OSMO. So this gave an idea to delve into all the patients who was reported to our clinic. It is a retrospective data analysis. So where we came across like a predominant patients who reported to the institution were in grade 1. And they were not aware of their existing OSMF, or they are not aware of any symptoms, because till now in grade 1 there is no active symptoms which they get reported. So what we conclude is whenever we come across a patient, when we take history, whether they have a tobacco chewing history, it is also important to look for early signs of OSMF.
And you said that this is the first study of its kind in India.
Yes, ma'am, in India. Yes, ma'am.
So, have you searched the literature?
Yes, ma'am. And regarding non-specific chief complaints, we have published one from our college, and we saw journals from Sri Lanka and in other developing countries like China, Thailand, because it is only predominant in developing countries. So we came across only those studies. So we thought, why don't we try in India also? And my thesis was regarding to OSM. So I had more experience in screening all those cases in clinics. So I thought, why don't we look into it, and we found the data like this.
This is an ongoing study or what?
No, this study is published, and my research project is based on electromyography analysis in OSMF. This I did as a short study.
Okay, fine. How many patients you had in the study?
155, ma'am.
Okay. And among 155, how many presented with non-specific symptoms and were diagnosed as OSF?
Among them, the non-specific complaints, it came around, one minute, I'll show the data. Around 76% had non-specific complaints. That is, they had come for other treatments, not for OSM treatment. Only 24%, it is 23.87, 24% had some chief complaints related to OSM.
Okay, so we will put this in another way. Patient coming to a dental institution with other non-specific complaint. So we can stress the importance of clinical examination, thorough clinical examination to diagnose a case of OSF.
Yes.
So that should also be included, rather than just saying that patients with non-specific complaints diagnosed as OSF. You should highlight the importance of your clinical examination by which you have come to the diagnosis.
Yes.
Okay. Okay, thank you.
Yes.
Thank you, Sunila ma'am and Jinsi
Yes.
ma'am, for making this session very attractive and very interesting. And also, thank you so much for judging all the papers. Thank you so much, ma'am.
Okay, thank you.
Thank you. With this, we come to the end of the session.
So can we leave the presentation?
Jinsi ma'am, we are sending your certificate also. Just a minute.
Thank you. Thank you.
मेरे को बैकग्राउंड ये शेयर करना है, म्यूट कर देती हूँ।
Hello.
Launch open Zoom.
Good afternoon, all. May I please confirm the presence of the participants PG paper 16 and PG paper 18?
Can't control everything, right?
Sorry? Managing. May I please confirm the presence of the participants, which is PG paper 16 and PG paper 18? Good afternoon, all. Let's begin the session. Pushperi College of Dental Science is delighted to host the Kerala State 5th Annual Triple O Conclave. Let's start the scientific presentation under Department of Oral and Maxillofacial Pathology. Starting with the postgraduate phase presentation, and going on the session to the open, we invite our judges for session. It's my privilege to invite Dr. Kara Arvind and Dr. Arvind. Dr. Kara Arvind, who is an assistant professor of Department of Oral and Maxillofacial Pathology, Amrita Institute of Dental Sciences, Edapalli, and Dr. Arun Mohan, who is an assistant professor of Royal Dental College, Palakkad. We welcome you, judges. Now, let's proceed to the instructions. Presentation. I will have 5 minutes. We will use 30 seconds to do. If your time exceeds more than 30 seconds, next candidate will be called and will be given a chance. You will also be given a warning at the 4th minute. So feel apply a final warning. I hope the instructions are clear.
Ma'am, excuse me, you're not very audible.
You're not audible? So, like, both of us?
No, the second person. Your name is. I think that you will have to adjust the mic a bit, I think.
Audible.
We can hear one of you. Yeah, one of you is audible.
Sir, is it clear? Like,
Yeah, now it's okay.
yeah, now it's okay. So shall I repeat the instructions once more?
Yes, please.
Okay. So the instructions are that for the paper presentation, you have 5 minutes. You'll be given 30 seconds for screen sharing before presentation. And if your time exceeds more than 30 seconds, next candidate will be called on, and you will be given a chance only at the end of the presentation. You will also be given a warning at the 4th minute, preceded by a final warning at the 5th minute. I hope the instructions are clear.
Now, let's start the session. I would like to call PG paper 1. You will be given 30 seconds for preparation. Your time starts now.
Good afternoon, everyone. Today I'm presenting a systematic review on the topic of platelet-rich plasma protein as a therapeutic regimen for oral lichen planus, an evidence-based review. Oral lichen planus is a chronic mucocutaneous disease of autoimmune origin affecting the mucous membrane skin, mucous membrane skin, esophagus, genitals, nails, etc. The prevalence is around 0.5 to 2.2%, with more commonly affecting the females of middle age. In the oral cavity, the most common site is the buccal mucosa, and the lesion appears as a multifocal bilateral symmetrical lesion with intermittent periods of recurrence and recovery. The different variants of the oral lichen planus are reticular type, papillary, plaque, bullous, atrophic, and erosive. Then, along with the traditional treatment, newer treatment modalities for treating a plasma concentrate of individual own blood containing platelets predominantly. The activated platelets in the PRP releases different types of growth factors, which result in the cell migration, which helps in cell migration, proliferation, differentiation, angiogenesis, debris removal, and regeneration of tissues. The studies regarding PRP on lichen effect of PRP on lichen planus are scant. This review was undertaken to answer the research question: does PRP have any therapeutic effect on OLP? Methodology include the review followed the PRISMA protocol checklist and listed for systematic review and meta-analysis. eligibility criteria includes the article must be in English language, showing the reporting the effect of platelet-rich plasma on OLP. No time frame was set. Study design of any type with patients intervened for OLP with PRP, irrespective of age and gender, were chosen. Trials with different doses of PRP intervention, comparative trials between PRP and other drugs, PRP was a placebo or no treatment were included. Patient in the case report included were confirmed by histopathology. Information sources include PubMed, Medline, Scopus, and Web of Science. This is a flowchart for inclusion of articles. Result, this systematic review included 2 clinical trials and 2 case reports, in all of which 0.5 ml of PRP were administered to the patients, and which resulted in a significant decrease in the VAS score and significant decrease in the erythema and lesions. These are the 4 discussion. OLP seems like an incurable condition with a major focus of treatment concentrated on control and reduction of inflammation. Multiple interventional modalities have been employed, such as steroid, both topical system and systemic retinoids, phototherapy lasers, but in most of the cases, OLP cases appear to be resistant. PRP does not induce any immune response or allergy, and literature does not report any serious adverse effects. All studies had cases with erosive OLP. Erosive OLP seems obstinate to presently accessible therapies, and hence need for newer therapeutic agents arises. Steroids are regarded as the first line of choice treatment for OLP, but prolonged uses can result in side effects such as candidiasis, mucosal atrophy, etc. The use of natural agents such as aloe vera, curcumin are not able to tackle the issue of resistance. PRP intervention with its low cost and effectiveness seems to be a viable alternative in treating OLP in future. The procedure for production of PRP includes the withdrawing the venous sample from the patient, centrifugating it, and resulting in the different layer formation with the pipetting of platelet-rich plasma and administering it into the patients. PRP contains activated platelets, which releases a lot of type of growth factors, which in turn causes helps in angiogenesis, mitogenesis, cell growth, proliferation, etc. Pain reduced significantly among all cases treated with PRP. Overall, PRP is a treatment of choice in cases with which are non-responsive to conventional therapy without any emergence of adverse effects. But the evidence is not sufficiently robust to establish the effectiveness, as there are not many studies done in this regard. We strongly recommend a greater number of prospective studies conducted in large sample with long-term follow-up and to arrive to a definite conclusion.
So your time is up. Thank you, sir. Now it's time for the discussion. Over to you, Dr. Tara Aravind.
So PRP, on what all cases do you use PRP?
In common, other than OLP or
OLP, not like in planus.
in
which
most
all cases?
like reticular, plaque, and papillary type are easy to tackle, but most commonly it is used for erosive type of lichen planus.
Erosive type of lichen planus.
And in all these studies included in the systematic review, all cases were done on the erosive lichen patients only.
In erosive lichen planus.
Actually, ma'am, erosive erosive type of OLP is most difficult to tackle. That's why this type of new regimen was.
So, is there any article to support that there is complete healing after the PRP administration?
Ma'am, not complete healing, but definitely reduction in the appearance of lesion, appearance of the erythema around the lesion, and very much significant reduction in the pain was seen in many of the cases, including these all 4 studies included in this systematic review.
Okay, that's all from my side.
To you, Dr. Arun Mohan.
When you say use of PRP, how do you use that for treatment purpose? Like, what is the mode of administration?
It is firstly it is mixed with the anesthetic and administered locally into the lesion.
Intralesionally, will inject in.
Yes, yes, sir.
So, did you compare it with other modalities like rinses and or supposedly there are PRP rinses? So, do we have a comparison for that? Which one is more effective, topical or intralesional injection?
Basically, the topical treatment modalities are for the initial cases only, and erosive lichen planus does not show much effect on using the topical ones, steroids ones, but on inducing this PRP regimen, erosive lichen planus showed a much promising result.
Okay then.
Thank you.
Thank you, judges.
Next, I call one. You'll be given 30 seconds for speech.
Hello, am I audible?
Yes, you're audible.
Your time starts now.
Good afternoon, all the respected dignitaries. I'm presenting an original research performed in the Department of Oral and Maxillofacial Pathology. Vitamin B2 and OSCC, a diagnostic gravestone. These are the contents under which the study was performed and conducted. So to start with the introduction, oral squamous cell carcinoma is the most common subtype of the head and neck cancer with a 5-year survival rate of only 50%. It is 6th most common malignancy worldwide, causing major public health problem in the Indian subcontinent. Tobacco is the main etiological factor for the oral carcinoma. But what about other than tobacco? There are many other etiological factors. So let's try to focus and explore about the least determinants like diet and nutrition. They are the modifiable determinants of cancer risk with several bioactive components including vitamins like B2, B6, B9 and B12 which are included in the 1-carbon metabolism pathway. Okay, so these are responsible for protein synthesis, cell maintenance and proliferation. The deficiency states of which can affect the immune system and intact affect the methylation of and synthesis of DNA causing carcinogenesis. So a key factor of lack of improvement in the prognosis is the very fact that a significant proportion of OSCC are not diagnosed or treated until they reach an advanced stage. So there is a need for improvement in the early diagnosis of the oral carcinomas because in the initial stages, treatment is more effective and morbidity and mortality are minimal. So this study is an attempt to study the association of vitamin B2, that is riboflavin, with oral squamous cell carcinoma. The aim of the study is that to study the riboflavin levels in OSCC. The objectives of the study are to estimate serum vitamin B2 levels in oral squamous cell carcinoma patients and healthy counterparts, and to compare and correlate between the groups, and to assess the clinical utility of riboflavin as a potential tumor marker for OSCC. The methodology under which the inclusion criteria has histopathologically diagnosed patients of OSCC, and for control, we have taken apparently healthy individuals. For the exclusion criteria, cases and controls with known systemic diseases were excluded. The methodology which we adopted were 3 ml of peripheral blood was collected from the patients in the morning hours to avoid any dietary and hormonal disturbances. It was then rested for 30 minutes, after which it was centrifuged for 2500 RPM for 10 minutes, and then the serum and plasma was separated, after which vitamin B2 analysis was done via HPLC assay. The results we got from the study were the mean and standard deviation distribution in the oral squamous cell carcinoma patients were low, that is 3.22 and 2.16, which is diagrammatically represented in this graph, where we can see that the red line is the individual serum levels, vitamin B2 levels in the normal cases, as compared to the oral squamous cell carcinoma cases, the individual riboflavin levels were decreased. So it gave a significant p-value that's saying that detects that the vitamin B2 levels in oral squamous cell carcinoma patients were much lower than the healthy counterparts. So now to discuss, our study was in positive correlation with the study performed by Zhao et al., Shukla et al., Yoon et al. On breast cancer, oral cancer, and colorectal cancer respectively, which also showed low levels of riboflavin. Literature also supports that altered riboflavin metabolism is seen in gastric and lung cancer. Now to conclude the topic, decreased serum levels of riboflavin were observed in OSCC compared to healthy individuals, and the results support the hypothesis that the vitamin B2 riboflavin could be used as a tumor marker or diagnostic gravestone in OSCC cases. These are the references for the study. Last but not the least, wishing everyone a happy International Women's Day. Thank you so much.
Thank you, ma'am. Now it's time for the discussion. Over to you, Dr. Tara.
So what is the function of vitamin B2?
Vitamin B2 is a nutrient, which is a micronutrient of the body, which is important for one carbon metabolism path. So one carbon metabolism is a series of interlinking metabolic pathways, which donates one carbon unit, that is methyl units, for the synthesis of DNA, polyamines, and phospholipids. So vitamin B2, that is riboflavin, is an important and major cofactor in this pathway. So if vitamin B2 gets less, that is deficient, intact the OCM, that is one carbon metabolism, also gets hampered, and because of which we can face many problems such as araboflavinosis.
Okay, what about other vitamin Bs? B6, B9 and all. Why it is only B2? Yeah.
No, ma'am. Along with other vitamins, that is B6, pyridoxal P phosphate, B9 folic and B12 folic acid, and along with all these vitamins, even homocysteine is responsible for deficiency in one carbon metabolism pathways. So B2 is just one of the factor in which we are studying OSCC.
Okay, how many cases you have taken for the study?
Ma'am, I've started with a pilot study. I've taken 10 oral squamous cell carcinoma cases and age and gender matched healthy counterpart. Yes.
Age and matched healthy counterpart. Okay. So out of the 10 patients, how many showed vitamin B2 deficiency?
Ma'am, in all the cases except one, they showed decreased serum vitamin B2 levels.
Yeah. Except one cause B2. Okay.
Yes. So 9 of them showed decreased vitamin B2 level, and only one showed more than 1 nanomole per ml. That is normal.
What about the other? You have checked only the B2, right?
Yes. Ma'am, I've also done a study on B6, but that's ongoing.
Okay. Yeah, that's all.
Again, just why vitamin B2 itself? Any particular reason for selecting that over the other vitamin B complex components?
Yes, sir. We are trying to focus on every vitamin that is responsible for one carbon metabolism. We have started with vitamin B2. B6 is ongoing, and we are going to study all the vitamins. Then following, we will compare and correlate all the results and its association with oral squamous cell carcinoma.
Okay, any idea about how it affects the oral squamous cell carcinoma, like how the deficiency could affect the pathogenesis of oral squamous cell carcinoma?
So vitamin B2, when if we see on a general if vitamin B2 is deficient in our body, it causes sores in the mouth and the source are for longer period of time, and the source we can see on the lower part of the pharynx. So maybe that relation could be there.
Like a weak physical defense. Is that
Yes, sir.
hypothesis?
It's lowered immune response.
Okay. Any other action in any other pathways, apoptosis or oxidative stress? Have we gone through literature? Is there any other correlation with any other factors usually associated with etiology of squamous cell carcinoma?
So in the literature by Fu et al. In 2021, the author has stated that due to as B2 is a major cofactor in 1-carbon metabolism pathways, and itself the pathway is responsible for DNA methylation and for formation of polyamines phospholipids. So we can say that DNA methylation and cellular aging could be a fact that vitamin B2 or other vitamins along with vitamin B2 is responsible for causing OSCC or the decreased serum levels in OSCC.
Okay. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, judges. Now I would like to call upon PG paper 3. You will be given 30 seconds for screen sharing.
Good afternoon, all. Am I audible?
Yes, sir. You'll be given 30 seconds for the preparation.
Good afternoon, all. Today I am going to present a case report on rapidly growing tumor of jawbone. A patient named Priyanka, 26-year-old female patient, reported to with the chief complaint of small swelling on the right side of the jaw before 2 months and was rapidly enlarged to present size. On local examination, unilateral facial asymmetry noted on the left side of the face. Bony expansion shifted the right commission of the lip upwards and superiorly extended to the angle of the mouth, anteriorly extended to 4-2.
Excuse me, can I interrupt you? I cannot. Can you please put in the presentation mode? The presentation is actually stuck for me.
Okay.
Yeah.
What about Dr. Arun? Dr. Arun, can, yeah, fine. Yeah, continue.
Patient having chief complaint of patient noticed a small swelling on right side of the jawbone before 2 months and was rapidly enlarged to the present size. On local examination, and unilateral facial asymmetry noted on the right lower third of the face, and the bony expansion shift to the right commission of lip upward, and superiorly it extended to the angle of the mouth, anteriorly extended to 4-2, and inferiorly extended beyond the inferior border of the mandible, and posteriorly extended to 4-6, and it was non-tender, non-fluctuant, and hard. On intraoral examination, on inspection, a diffuse swelling of approximately 8 into 6 centimeter centimeter in size, and was paint pink in color, extending posteriorly from distal aspect of 4-6 to anteriorly distal aspect of 4-2. Obliteration of labial and lingual vestibule noted. On palpation, non-tender diffuse bony heart swelling, bicortical expansion and loosening of adjacent tooth noted. The patient was advised for biopsy. At that time, patient was not willing to do biopsy. After 8 months, he came with an unilateral facial asymmetry. After 8 months, she came back to the clinic having unilateral facial asymmetry noted on the right lower third of the face, and bony expansion shift to the right commission of lip upward, and superiorly extended to the anatragus, anteriorly crosses the midline and extend the left commission of the lip, inferiorly extended to the beyond the inferior border of the mandible, and posteriorly extended up to the angle of the mouth. At that time, the CT images were showing the multiple radiolucency of varying sizes arising from the body of the mandible can be noted. From this CT, there is anti-resorption of Lower anterior tooth also evident. 3D reconstructed image showing the very expansile bony lesion extending from 4.2 to 4.8. Sorry, 3.2 to 4.8. And investigation and incisional biopsy of the lesion was taken, and we received a single bit of formalin fixed mixed tissue specimen measuring of about 5 into 5 cm. On histopathological evaluation showing the malignant odontogenic epithelium proliferating as multiple islands, based on incisional biopsy, the diagnosis was given as malignant odontogenic tumor. At 3D, before treatment, mock surgical stent was prepared, same as that of the lesion. From this 3D print mandible, we can able to see the buccal and lingual cortical plate expansion. And we received an exceptional biopsy specimen after the surgical procedure, and it was largest formalin mixed tissue specimen measuring of about 9. No, ma'am.
We have 1 more minute left.
Measuring of about 9 into 5 centimeter. On histopathology, a lower magnification showing the neoplastic proliferation of odontogenic epithelium as follicle, islands, and strands. On a higher magnification showing the clear cells and the peripheral palisaded nucleus. We did special stents including musicarbon and PS to find out the clear cell contents. Musicarbon was negative, hence the rule of the salivary gland neoplasm, and PS was positive. We did a panel of immunohistochemical markers, and the tissue section was positive for pancytokeratin, indicating that it was epithelial origin, and we did a specific marker CK19, and hence showed that it was arising from odontogenic epithelium. And the final diagnosis based on excisional biopsy given was clear cell odontogenic carcinoma. And it is coming to discussion, it was first described by Hansen et al. In 1985.
Your time is up. Thank you, sir. Now it's time for the discussion. Over to you, Dr. Kara Arvind.
So, by looking at the incisional biopsy, how did you come to a diagnosis of malignant odontogenic tumor?
Ma'am, based on incisional biopsy, we found out that the epithelium was proliferating as islands, follicle, and there is infiltration in connective tissue also noted. And hence we given diagnosis malignant odontogenic.
That is what, if you see the proliferation of epithelial cells, can you just put it under malignancy? Why can't it be benign?
Ma'am, clinically it was more aggressive.
So aggressive means you will put it under malignancy. Just because clinically it is aggressive, histopathologically, without seeing the malignant features, you will give a diagnosis of malignant odontogenic tumor. Ameloblastoma, it's a benign tumor, it is aggressive, right? There are so many benign tumors that are aggressive. So how did you say that by seeing the incisional biopsy, how did you say that it is a malignant odontogenic tumor? That is my question. What are the features that tell you that, okay, this is a malignancy, not a benign tumor? What is it? Okay. Then coming to the excisional biopsy, how did you come to the, what are the points that is pointing towards the diagnosis of clear cell odontogenic carcinoma? Are you able to hear him? Dr. Arun?
No, no, no.
No, I think he's stuck. Or he's there? Elizabeth, is he here?
Yes, ma'am. No,
Is he
he
here?
left. He's not
He
there,
left.
ma'am. Yeah. I
Okay,
think
so shall we
probably he has some issues with the network.
Yeah. Okay.
Okay. Ma'am, we'll just give him a call. Ma'am, we proceed to the next PG paper. Thank you, ma'am.
May I call upon PG paper 14 for the presentation? You'll be given 30 seconds for the screen recognition.
Shall I start?
Yes, ma'am. Your time starts.
Good afternoon, all. Today I'm here to present my research topic on evaluation of immune cells in oral squamous cell carcinoma and oral epithelial dysplasia, an immunohistochemical study. Oral and oropharyngeal cancer is considered as the 6th most common cancer. Of that, the squamous cell carcinoma accounts for 90 to 95% of all oral malignancy. Usually, squamous cell carcinoma is preceded by oral potentially malignant disorder, which are clinically termed as leukoplakia and histologically characterized as epithelial dysplasia. The progression of dysplasia to carcinoma is a stepwise event with accumulation of genetic changes leading to increasing severity of dysplasia and eventually to carcinoma. So in my study, I included the immune cells because the immune cells have some role in the tumor microenvironment. They can either suppress the tumor formation or promote tumorigenesis. I selected CD8 and CD57 as the biomarker because CD8 positive cytotoxic T cells, they are the critical subpopulation of T cells and they are the important mediators of adaptive immunity. And CD57 is a 110 kilodalton glycoprotein that is typically expressed by the natural killer cells, which can attack the cancer cell and inhibit tumor development. The aim of my study is to evaluate the IHC expression of CD8 and CD57 immune cells in squamous cell carcinoma, epithelial dysplasia, and comparing with the normal mucosa. And the objective is to evaluate the expression of CD8 and CD57 in squamous cell carcinoma, epithelial dysplasia, and normal mucosa, and also to compare their evaluation, the evaluation of these cells in the 3 groups. And my samples includes the 22 samples of oral squamous cell carcinoma, which constitute well differentiated about 9, moderately differentiated about 11 samples, and poorly differentiated only 2. And epithelial dysplasia also 22 samples are there, with mild dysplasia 9, moderate dysplasia 11, and severe is 2. And normal mucosa also 22 samples were there. And most of the cases showed an high prevalence for the tongue, and most of my patients are male patients. And the specimen were undergone sectioning, and I used the primary antibodies CD8 and CD57, which was undergone for the IHC staining. And I kept tonsil as my positive control tissue. And the evaluation is the cells exhibiting brown staining in the cytoplasm or plasma membrane are defined as positive regardless of the staining intensity. And for squamous cell carcinoma, the lesional area were divided into 3 anatomic compartments, that is the epithelium, connective tissue stroma, and the advancing tumor margin. And for epithelial dysplasia and normal mucosa, 2 anatomic components were evaluated, that is the epithelium and the connective tissue stroma. And the mean number of CD8 positive T lymphocytes and the CD57 positive NK cells were counted per microscopic field for each cases. After obtaining the sum value of each field, the mean positive cells for each cases were calculated by using mean labeling index. And the statistics were, quantitative variables were expressed as the mean plus or minus standard deviation, and one-way ANOVA test with post hoc test were used as for the statistical analysis. And the results showed there is an increased expression of CD8 positive T lymphocyte cells in oral squamous cell carcinoma when comparing to epithelial dysplasia and normal mucosa, which we got a statistically significant value that is less than 0.001. And when comparing the expression of CD8 positive cells with normal mucosa and OED, we got a statistically significant result. And when comparing the normal mucosa with squamous cell carcinoma, also we get an increased expression in squamous cell carcinoma than the normal mucosa, which is also shows significantly statistically significant value. And in the case of CD57 positive NK cells also, it shows an increased expression in case of squamous cell carcinoma comparing to epithelial dysplasia and normal mucosa. That also we got a statistically significant result, p-value less than 0.001. And comparing the normal expression of CD57 positive cells in normal mucosa with epithelial dysplasia, we got a statistically significant expression. And also when comparing the normal mucosa with squamous cell carcinoma, we got a statistically significant result. Here, the picture showing the increased expression of CD8 positive cells and CD57 cells in squamous cell carcinoma than OED and normal mucosa. So coming to discussion, the immune cells in the tumor microenvironment have important role as they have a very important role in cell-mediated immunity. And CD57 is most prominently expressed in highly matured NK cells. During the early stage of tumor development, CD8 positive T cells and NK cells can recognize and eliminate the more immunogenic cancer cells. And our results showed an increased expression of CD8 and CD57 both in oral squamous cell carcinoma. And we got a statistically significant result when comparing the groups with high expression in oral squamous cell carcinoma. And also finding it is as the grade of OSCC and dysplasia increases, the expression of CD8 and 57 tends to decrease. So to conclude, the CD8 and 57 can be used.
Now it's time for the discussion. Over to you, Dr. Bhatt.
So how do you help that in the planning of the treatment modalities?
The study showed that the increased expression of CD8 and 57 has more tendency for prognosis. The patient showed a good prognosis.
What the expression? High expression shows what?
A good prognosis. But as the grade of the squamous cell carcinoma and dysplasia increases, usually the expression decreases. The expression of CD8 and 57 tends to decrease as the grading increases. Usually the well-differentiated and moderately differentiated, it shows high expression of these immune cells. So by that we can have a good prognosis in case the patient have a good prognosis. And if we diagnose it in the early conditions, it will help in the treatment, help with the treatment modalities.
See, if it is well differentiated and moderately differentiated, by seeing the histopathology only we can know out, no? So why do you need CD8 and CD57? Otherwise also we know, if it is well differentiated, naturally the prognosis would be better than the poorly differentiated.
Yes, ma'am.
If there is any additional thing that CD8 and 57 are offering you for, additional prognostic, it's already understood, no?
Yes,
as the grade advances, the prognosis will be bad. The histopathologically, by routine simple histopathological stains that we can make out. Good indicators to know the aggressive nature of the lesion. That is why histopathologically we are grading into mild, moderate, severe dysplasia. We don't need an additional CD8 and CD57. To identify the patients with good or poor survival rate, same. That's what I think. The grades, the grading of dysplasia, the grading of squamous cell carcinoma, all these are, related with all these prognosis treatment modalities. Why do we need, simply why do we want to make the patient, go for immunohistochemistry if the diagnosis is clear cut? That is my question.
Because they have an anti-tumor response, these immune cells.
Immune cells, what does it continue?
And they have an anti-tumor response.
Anti-tumor response means what?
We have both immune cells like myeloid derived, they have a tumor immunosuppressive effect. But these CD8 and CD57, they have more of tumor suppression.
Okay. Yeah.
Thank you, ma'am. Over to you, Dr.
No, I had similar doubts only. Why to do this in squamous cell carcinoma especially? Did you compare it among the different grades of dysplasia? Mild,
Yes, but
moderate, severe?
we have only 2 samples with the severe dysplasia. So we
Okay.
didn't get a statistically significant result for that.
Okay, again, the question is why? Why to do that? You have 4 points here, which I assume is what you intend to use it for. So how can we know the aggressive nature? Is it like lower expression is more aggressive? Is that the conclusion?
If the immune cells have a higher expression, then the patient have more prognosis. The aggressive
higher.
nature of the lesion is low.
That, but it's again correlating with well-differentiated squamous cell carcinoma, which obviously has a better prognosis, right?
Yes.
Is there any exceptions for that? No, it's always well-differentiated, which has a better immune cell profile. Okay. Did you intend to take your study forward in any direction? To expand your study?
Yes, sir.
By doing what?
It's only a pilot study with 22 samples.
Okay, to increase the sample size, but would you like to look for any other parameters? Some other area of the tumor, invasion front or something?
Yeah, invasion front or we didn't check for the prognosis in the study. The patient is not followed up.
Okay, you just said they have had a better prognosis. Okay then.
Yes.
Thank you, judges.
Now I'll call for PG paper 15. You will be given 30 seconds for your screen sharing. Your time starts now.
Ma'am, am I audible?
Yes, you're audible.
Good afternoon, everyone. My topic of case presentation is today recurrent soft tissue lesion of buccal mucosa, quagmire in their diagnosis, a case report. After taking the patient consent for presentation, I am presenting this. So a 59 years old female patient came to our OPD with chief complaint of swelling in the right buccal mucosa. The swelling was present for 12 months. The patient had surgery for same kind of swelling twice before, but at the different site. No similar lesions were found in any other parts of the body at the point of examination. There was no weight loss, no change in appetite, no headache, or any other findings involving the central nervous system. On external examination, we found soft, round, fluctuant mass measuring 2 cm into 3 cm on the right buccal mucosa with well-defined margin. And on intraoral examination, we found the patient was completely edentulous, with no obliteration of occlusion or vestibular area. So the provisional diagnosis given was salivary gland tumor. We received the biopsy specimen, and on grossing, we found out a large tissue.
Excuse me, could you change the slides? Are you changing the slides?
Yes, I'm changing the slides.
We cannot see that slide. It's just stuck with the title slide. Put in the presentation mode.
Light show.
Ma'am,
Yeah.
Okay. Yeah.
So the provisional diagnosis given was a salivary gland tumor. We received the biopsy specimen, which showed a large tissue bit measuring 3 into 3.5 cm into 3.2
centimeter to 2.1 centimeter, brownish white in color, firm in consistency, irregular in shape. The specimen was inked and cut into 2 halves. Multiple small bits were further cut from 2 halves and sent for processing. Histological features showed hyalinized rope-like thick collagen fibers and mature adipocytes with bland spindle cells, and hypochromatic multinucleated giant cells in the rosette-like pattern, which is also known as the floret cells. Here I have encircled the floret cells in this slide. After viewing all the histological features, the following can be the DDs of this lesion. And the final diagnosis was given as the pleomorphic lipoma. So pleomorphic lipoma is a rare benign pseudomatous soft tissue neoplasm, and has slight male predilection of 4:1. It is found in the age group between 50s to 60s. It can either present itself as slow growing mass or rapid growing, which was previously at a stable state for a long time. Histologically, it contains varying amounts of mature fats, areas of spindle and pleomorphic cells, floret giant cells, and thick rope-like collagen in the myxoid stroma. As we saw in the DDs, lots of other lesions, specifically lipomatous lesions, can be confused with pleomorphic lipoma. So here are the features that stated and differentiates these entities from pleomorphic lipoma. The archival data shows only 4 cases till now, which are the following. To conclude, pleomorphic lipoma is a rare lesion and is seldom reported. The other lipomatous lesion should be distinguished from this lesion based on the non-lipomatous component to narrow down the surgical procedures to be performed. Knowledge of such a rare entity and a resembling lesion should be acknowledged to prevent any case of misdiagnosis or overdiagnosis and save the patient from surgical interventions. So these are my references.
We have 1 more minute left.
Thank you.
Now are we done with the discussion? Now we move on to the discussion.
So where was the lesion?
Ma'am, it was in the cheek.
Cheek.
Right. Yes.
Yeah. So what are the differential diagnoses that you have made clinically?
Yes, ma'am. Can you repeat?
Clinical differential diagnosis.
Ma'am, the clinical differential diagnosis was the salivary gland tumors like salivary gland neoplasms and pleomorphic adenoma.
Why only salivary gland?
Due to the site.
Due to the site, cheek.
Ma'am, due to the site, we came to the diagnosis, like we give the differential, like we said that it's a salivary gland tumor. As
site is on the cheek, right? Buccal mucosa.
Yes, ma'am.
Oh, so only salivary gland lesions will be there on the buccal mucosa.
No, ma'am. Liposarcomas are also there.
Liposarcomas. Okay. Histopathologically, what are the differential diagnoses?
Ma'am, histologically, we give the DDs as myxoid malignant fibrous histiocytoma, then sclerosing liposarcoma, then myxoid liposarcomas.
How did you come to a final diagnosis of pleomorphic liposarcoma?
Ma'am, we gave it the pleomorphic lipoma.
Pleomorphic lipoma, yeah.
Ma'am, after like after correlating with all the histopathological features with the other DDs, like other DDs histological features, we came to the conclusion.
Yeah, what are the other histological DDs? Can you just tell me?
Ma'am, like for myxoid malignant fibrous histiocytoma, there are presence of soliform pattern of cells with high rate of pleomorphism. Then in sclerosing liposarcoma, there are occasional lipoblasts and rarely floret cells are there within the matrix. In myxoid liposarcoma, we can see the sheet-like areas of proliferating lipoblasts. So in this, whereas in our case, like pleomorphic lipoma, we can see the floret cells.
Why did you say it is malignant? One of the diagnoses malignant fibrous histiocytoma, right? What was it?
Malignant fibrous myxoid valvular histiocytoma.
What is it?
Myxoid malignant fibrous histiocytoma. It is also known as myxofibrosarcoma.
Really? Okay. Yeah. Then how did you come to a differential diagnosis of malignant fibrous histiocytoma? It should be something, no, to have that differential diagnosis after seeing the histopathology. Why did you consider that malignant fibrous histiocytoma as a differential diagnosis?
Because it mimics lipoma due to the presence of adipose cells.
Okay. Yeah.
Thank you, ma'am. Over to you, Dr. Arun, ma'am.
No, just why did you describe it as a quagmire?
Sir, because many of the other lipomas have the same appearance histologically.
Compared to pleomorphic.
Yes, sir.
Mean to say, compared to other variants of lipoma, they have a similar appearance, pleomorphic lipoma, histologically or clinically?
Histologically, sir.
Okay. So did you do any special stains for confirming the diagnosis or do any other investigations? Or was it just based on histopathological examination?
So only based on histopathologically we did.
It doesn't sound that confusing, isn't it? You could reach a diagnosis, right, based on histopathology.
Yes, sir.
Okay then.
Thank you, sir.
Thank you, judges.
Now, let's move on to PG paper 16.
May I confirm the presence of candidate PG paper 16? May I confirm the presence of PG paper 16?
Okay, now let's move on to PG paper 17. This PG paper 16. Okay, you'll be given chance at the end of the conversation. But let's move on to PG paper 17. It is please not PG paper 17.
Yeah.
You'll be given 30 seconds for the screen share.
Yeah. Am I audible?
Yes, you're audible.
Yeah. So good afternoon, everyone. So today's presentation topic is malignant tumors of infancy, a diagnostic challenge. So the malignancy, as we can see, is a challenge for pathologists also to diagnose if a patient is an adult, and it becomes formidable in cases of children because malignant lesions are seen rarely in children, and they also present with the non-specific symptoms. So malignant lesions that can be present in children can be lymphomas, sarcomas, and like rhabdomyosarcoma and Ewing sarcoma. So the undifferentiated nature and the primitive characteristics makes it difficult to diagnose these lesions through
slides. Can you change the slides, please?
So I'm changing the slides. Yes, sir. Is it possible, sir?
Not yet. Can I select the second slide and see? Okay. Okay. Yeah, okay.
Yes. So the undifferentiated and the primitive character of these lesions make it difficult for diagnosing through the routine histological examinations. Hence, the advanced diagnostic aids come into play when diagnosing these diseases. So the most in recent days, the most common and reliable diagnostic aids that has emerged is the immunohistochemistry. And why is it important? Because it helps in localizing a specific antigen, and it is based on antigen and antibody reaction, and also helps us determining the tissue of origin. The advantages of using IHC is it can help in it can be used in fresh and frozen tissues, fresh tissue sections and frozen tissue samples. It is well established and it is readily available and is cost effective. So the objective of our presentation was to highlight the difficulties that were encountered during diagnosing the malignant tumors of infancy, and to emphasize the role of immunohistochemistry. So here is the case. A 3-year-old female patient was referred to the dental OPD for a second opinion from a private healthcare sector. A true cut biopsy was performed and a provisional diagnosis of odontogenic myxoma was made. And then the patient presented with sudden increase in size, and it was associated with pain and fever. So the extraoral findings were the soft tissue swelling was found to be firm and non-indurated. Size was 5 to 6 centimeter, and it extended superior-inferiorly from infraorbital region to the inferior border of the mandible. And anteroposteriorly, it extended from alar cartilage to the tragus of the ear. And intraorally, the swelling was found to be diffused and obliterating the vestibules. A provisional diagnosis of odontogenic myxoma was made, and investigations were done using radiographic examinations, that was OPG and CBCT, and a diffuse radioopacity involving maxillary sinus was found. And an incisional biopsy was done. Histopathological examinations were done using hematoxylin and using stainings. As we can see, under the low power, the sections showed spindle-shaped round cells. The same sections under high power showed round cells that had more bizarre nucleus. Under periodic acid shift stain, the cells showed muscle tissues that were rich in glycogen. So the differential diagnosis was following differential diagnosis were made: Ewing sarcoma, fibrosarcoma, non-Hodgkin's lymphoma, embryonal rhabdomyosarcoma, and malignant schwannoma. So an IHC was performed to arrive at a definitive diagnosis. So these were our markers: Ki67, which showed positivity for the tumor cells; CK19, that showed negative for tumor cells; S100 was negative for tumor cells; Vimentin was found immunopositive for the tumor cells, and Desmin was found to show positivity for positivity for the tumor cells. So final diagnosis was arrived with the help of hematoxylin and eosin, periodic acid shift, and Desmins. A final diagnosis of embryonal rhabdomyosarcoma was made. Coming to the discussion, embryonal rhabdomyosarcoma is malignant neoplasm and it has a poor prognosis. We can improve the prognosis with the help of an early diagnosis. IHC plays a crucial role, and the following markers were used. We managed the case with 2 cycles of chemotherapy, though there are other modalities like surgery, chemotherapy, and radiotherapy. To summarize it, it is most what was challenging for us that it was most commonly seen in males. It was misdiagnosed as odontogenic myxoma. A true cut biopsy was performed, and a required advanced diagnostic aids. Not all not all lesions are odontogenic in nature. Misdiagnosing is common in these cases, and an early and accurate diagnosis is required to arrive at a definite diagnosis. And IHC plays an important role in important diagnostic tools. These are our references, and thank you.
Now it's time for the discussion. Over to you, Dr. Tara.
What are the histopathological types of rhabdomyosarcoma?
Ma'am, these are alveolar form. Am I audible, ma'am?
Yeah. Come on, go ahead.
Yes, ma'am. These can be, ma'am, botryoid type, alveolar type, and pleuromorphic type of rhabdomyosarcoma are seen, ma'am. Histopathological differences.
Is there any special stain that can be used for this, for the identification of the rhabdomyosarcoma?
Ma'am, PAS staining that was done, ma'am, in a study that we did.
Yeah. Any other stain?
Ma'am, I'll find out.
Yeah. Over to Dr.
So your diagnosis was based on the IHC?
Yes, sir.
Okay, so why embryonal specifically?
So embryonal specifically because it is these malignancies are rarely seen in children, and so they have poor prognosis. But with early diagnosis, we can improve the prognosis of the patient. That's why that's why it is important to do it in cases of embryonal types.
Okay.
Thank you.
Thank you, judges. Now, I would like to call upon PG paper 80. You will be given 30 seconds for the screen sharing.
Good afternoon, everyone. Am I audible?
Yes, you're audible.
You'll be given 30 seconds for the screen share.
Is this visible to everyone?
Yes, it's visible. The time starts now.
Good afternoon, everyone. My
Why
topic
don't
is.
you maximize? Yeah, yeah.
Okay, ma'am. Good afternoon, everyone. My topic is about to assess the inter-observer variability in mitotic figure counting in various grades of oral squamous cell carcinoma. So squamous cell carcinoma is a malignant epithelial neoplasm exhibiting squamous differentiation as characterized by formation of keratin and presence of intercellular bridges. It represents 90% of oral cavity cancers, and it is the sixth most common cancer in the world. 45% of Indian cancers represent OSCC. It is associated with significant morbidity, mortality, and an aggregate 5-year survival rate of less than 50%. Now, etiological factors being smoke, most common smoke and smokeless tobacco in the form of cigarette, cigar, BD, and bitter then alcohol, then some viruses like oncogenic viruses, most common being HPV 16, 18, and Epstein-Barr virus, poor nutrition like iron deficiency and vitamins, then dental factors like sharp tooth and faulty appliances, then potentially malignant disorders like erythroplakia, leukoplakia, and immunosuppression like AIDS and organ transplant. And there are some genetic alterations of the genes like RAS, MYC, EGFR, and others. So defects of mitosis result in various nuclear abnormalities, namely micronuclei, binucleation, broken egg appearance, pycnotic nuclei, and increased numbers of mitotic figures. The rationale for mitotic figure counting is that it's frequently used for classification and grading of tumors, prediction of prognosis of tumors, and even advocated as a decision point for treatment. Reproducibility of the mitotic counting is paramount for the assessment of malignancy on a histological scale. So with this background, we decided to assess the inter-observer variability in mitotic figure counting in various grades of oral squamous cell carcinoma. So the study design was that 48 cases of oral squamous cell carcinoma, which were histopathologically diagnosed by using HND, and they were divided into 16 cases each of well-differentiated, moderately differentiated, and poorly differentiated squamous cell carcinoma. Then mitotic figure was counted by 2 independent observers, which were mutually blind observers, and 10 high-power fields were taken into consideration. And then data was analyzed, and variability was seen between the 2 observers. So these are the samples of the mitotic figures in 4 cases of oral squamous cell carcinoma. Now it was seen that most number of variations was found to be in poorly differentiated squamous cell carcinoma, with difference of 5 mitosis was seen also in 1 case, and it was least seen in the well-differentiated squamous cell carcinoma. There was seen difference of 2 mitosis only. So it was only up to the 2 mitosis, but in case of poorly differentiated, it was seen up to 5 mitosis also. So this is a graphical representation of the mitosis in the well-differentiated, poorly differentiated, and moderately differentiated squamous cell carcinoma. If this is a statistical analysis of the inter-observer variability, we can see it. There is mean is almost the same in case of WDSCC between 2 observers, and the mean is very much far away in case of poorly differentiated squamous cell carcinoma. Observer 1 being 20.43 and observer 2 being 18.75. So there's a greater variability in case of mitotic figure counting in case of poorly differentiated squamous cell carcinoma. So coming to the discussion, there is an increasing awareness that proliferation is one of the most important features characterizing the malignant phenotype. In general, high proliferation rate is found in malignant tumors and only rarely in benign tumors. In malignant tumors, high proliferation rates are associated with a poorer prognosis. The mitotic count is the most commonly used method of assessing the proliferative activity of a tumor. Although a number of approaches exist like immunohistochemistry, but mitotic count has the advantage that it can be performed in a routine hematology and eosin stained slides. For this reason, the mitotic index is frequently used for classification, grading, and predicting prognosis.
1 minute left.
Predicting prognosis of tumor, and sometimes even advocated as a decision point for treatment. reproducibility of a mitotic count is paramount for the assessment of a malignancy on a histological scale. In our study, least difference was seen in case of WDSCC up to the maximum of 3 mitosis, whereas in case of moderately differentiated showed modest differences in observations with a maximum of 4 mitosis. And poorly differentiated squamous cell carcinoma case had the highest inter-observer variability with a maximum difference of 5 mitosis. Similar findings were observed by Yadav, Silverberg, and Clayton et al. So coming to the conclusion, proliferation plays an important role in clinical behavior of oral squamous cell carcinoma. Increased proliferation correlates strongly with the poor prognosis. Out of the different methods to assess proliferation, mitosis counting has been shown most convincingly to provide independent prognostic value and is the most well-established component of the histological grading system of oral squamous cell carcinoma. So these are my references. Thank you.
Your time is up. Thank you, sir. Now it's time for the discussion. Over to you, Dr. Tara Arun.
So, according to your study, inter-observer variability was more in the case of poor, right?
Yes, ma'am.
Yes.
Yes,
So this is actually, even the mitotic figures also will be more in the case of poorly differentiated, no? Compared
Yes,
to
ma'am.
well differentiated. So naturally it will be more, no?
Yes, ma'am.
So why you are, I don't know why you are doing the study? What is the purpose in doing the study?
Ma'am, it was not that poorly differentiated has a higher number of mitotic figures. It was the variability that we saw. The variability in assessing the mitotic figures. For example, observer 1 had seen 10 mitotic figures, and observer 2 had seen 12 mitotic figures in same 10 hyper fields. So the variability was seen to be more in case of poorly differentiated, and it was seen less in case of well-differentiated squamous cell carcinoma.
Yeah, definitely. Even the mitotic figures also will be less in well-differentiated carcinoma compared to poorly differentiated carcinoma. So naturally, that is already understood.
Ma'am, it was not total number of mitosis. It was a difference of mitosis that was seen. For example, in well-differentiated squamous cell carcinoma, if one observer seen 5 and another observer seen 5, so the variability was 0. 5 minus 5 is equal to 0. So the variability will be 0 in case of well-differentiated. But in case
So why do you think the variability is more?
Variability, because well-differentiated squamous cell carcinoma has a good differentiation. The mitotic figures can be seen very well. And in case of poorly differentiated squamous cell carcinoma, when it goes towards the anaplasia, so it can be very much difficult to see the mitosis. Some may have seen that one observer may not have estimated that it is a mitotic figure, and another observer has taken that figure into mitotic figure. So based on this, they may have missed the mitotic figure, and one may have taken that the mitotic figure. But in case of well-differentiated, there is good differentiation. Mitotic figure is well much evident in case of well-differentiated squamous cell carcinoma.
Okay, so it is not because of the atypical okay, yeah,
Yes,
that's it, yeah.
Over to you, Dr. Arun Mohan.
So what is the significance of the study?
Yes, sir. Significance of the study is that mitotic figure plays a paramount importance in case of assessment of malignancy, because it is used in various it is used in grading, like in NROS grading system, which we commonly use. NROS grading system, grade 1 is based on the number of mitosis. For example, 0 to 1 grade 1, 2 to 4 grade 2, 3 to 5 grade 3, and more than 5 grade 4. So if we miss the mitosis, we can miss the grade. We can place the grade into lower or higher.
Yeah,
so
like how can we bypass this problem? So what is the solution we can do for this? Obviously, we shouldn't miss it. Variability shouldn't be there. So how can we bypass this?
So mitotic figure is it denotes the prognosis. There are other things we can do for the prognosis, like immunohistochemistry, like TNM staging, like others we can bypass this. But still, mitotic figure plays still.
No, mitotic figures, rather than depending upon histopathology, because we already saw there's a lot of variability.
Yes,
so what can we do? Any other special stains or immunohistochemical stains we can use instead of?
Yes. There are a number of special stains to see the mitotic figures, like toluidine blue, crystal violet, JAMSA, or Calgian, or nuclear phosphate red stain that can better visualize the mitotic figures.
How can we calculate mitotic index?
Yes, mitotic index, sir, is a for example, if you take the high power field, number of high power filters, we can divide the total number of mitotic figures divided by number of high power filters. That gives us a mitotic index of that section.
Any immunohistochemical stains we use?
No, sir. Special stain we use for mitotic figures, and immunohistochemical stain for the DNA we can use for because it is basically
For proliferation rate for mitosis.
Proliferation, yes, sir. Like PCNA, Ki67, these are some immunohistochemical stains that can stain the DNA, and that we can assess the mitosis.
Okay. Okay.
Thank you, judges.
Now, I would like to call upon paper 19 for participation.
Yes.
You'll be having 30 seconds for this screen share.
Okay, am I visible and audible?
Yes, you're visible and audible.
Shall I start?
Yes, you can start.
So, good afternoon, everybody. Today, I will be presenting a case titled Extranodal Rosai-Dorfman Disease Affecting the Mandible. So, a 45-year-old female patient reported to us with a complaint of growth on the right lower back tooth region. And on history taking, she revealed that she had undergone extraction in the same area 3 years back. And upon further asking, she revealed that the similar kind of growth had happened twice before, for which it was excised and was reported as non-specific inflammatory lesion. The present growth was not associated with any pain, discharge, or bleeding, and on palpation, it was soft and non-tender. It measured about 2 into 0.5 centimeters. So at this point of time, the clinical DDs that we thought of were pyogenic granuloma, peripheral giant cell granuloma, or a simple fibroma. On radiography, we saw that there were multiple radiolucent lesions on the right side of the mandible, which had kind of a moth-eaten appearance. And on gross, we received 3 sections, which were irregular, rough, and whitish brown in color. Upon histopathological examination, we see that there were a lot of histiocytes that were present in the connective tissue. Along with that, we saw many inflammatory cells like plasma cells and lymphocytes. So looking at this histological pictures, we went ahead and did a IHC marker for CD1A. However, that was negative. And on closer observing the slides, we seem to see that these macrophages seem to be engulfing other cells like plasma cells and neutrophils, a phenomenon known as emperipolysis. So looking at this, we got a clue and went ahead and did a immunohistochemical stain for S100, which showed positivity of the macrophages. The macrophages took up the S100 stain, whereas the cells engulfed did not exhibit the S100 stain. So our findings in the present case was that it was a CD1A negative and S100 positive lesion. So the differential diagnosis that we could think of were Langerhans cell histiocytosis. However, in Langerhans cell histiocytosis, both CD1A and S100 should be positive, along with certain other eosinophils and group nucleus should be seen, which we did not see in our case. And in Erdheim sister disease and juvenile xanthogranuloma, CD1A and S100 are both negative, but these also show the phenomenon known as emperipolysis. So this was also ruled out. In central xanthoma, we not only see S100 that is negative, other than that, we see a lot of plasma cells. And since there was presence of emperipolysis and as sheets of plasma cells were not seen, we even ruled out myeloma. And then we therefore came to a conclusion that it was a Rosai-Dorfman disease and extranodal presentation. So what exactly is Rosai-Dorfman disease? So Juan Rosai and Ronald Dorfman in the year 1969 described this in a paper titled as sinus histiocytosis with massive lymphadenopathy. It has now been renamed as Rosai-Dorfman disease. It primarily affects the lymph nodes of young males of African descent, and the other constitutional symptoms could be fever and weight loss. The etiology is unknown. However, certain viral etiologies and mutations in the KRAS have been implicated. The extranodal presentation of RDD is extremely uncommon, and if it presents, it affects the head and neck region, the nasal cavity, paranasal sinuses, followed by jawbone. In the nathic area, it usually gives pain, swelling, and mobility of teeth. And there have been only few case reports that have reported the extranodal RDD in the jawbones, approximately 7 or 8 in the maxilla and 9 in the mandible. Thank you. I'm open for questions.
Now it's time for the discussion. Over to you, Dr. Karan.
So, which are the neoplasms that is associated with Roside?
So with Roside-Hoffman disease, we can see Langerhans cell histiocytosis, and there we can, another DD that we can think of is Erdheim cyst disease, and even juvenile xanthogranuloma also has a similar presentation to Roside-Hoffman disease.
Okay, so immunohistochemistry is the one that distinguishes one from the other.
Yes, because emperipolysis can be seen in other cases also. It is not pathognomic of the disease.
Pathognomic of that particular disease. Yeah, good.
Yeah, so which are the common sites, like extranodal sites? Which are the common extranodal sites?
So commonly, extranodal sites will be in the head and neck region and the paranasal sinuses and even the nasal cavity. Then it is seen in the nathic region.
Is it common to have extranodal presentation without any lymph node involvement?
It is very uncommon. It is very uncommon. Usually, Roside-Hoffman disease will 43% will have an extranodal involvement, but pure extranodal RDD without nodal involvement is very uncommon.
And this patient, unless I missed it, does not have any lymph node involvement.
There
was a solitary lesion.
It was a solitary lesion. There's no lymph node associated.
Okay.
Thank you.
Thank you, judges.
Now I would like to call upon PG paper 20. You will be given 30 seconds for the screen sharing.
Am I audible? Am I audible and visible? Shall I start?
Yes, your time starts now.
Very good afternoon to everyone. Today I'm going to present a quick review on saliva-based biosensors for early detection of oral squamous cell carcinoma. Oral cancer are the sixth most common cancer with high mortality rate. The mortality rates can be decreased if we detect the oral cancer at the earlier stage. So earlier diagnosis plays an important role in the mortality rates of cancers. So till now, the clinical examination and histopathological analysis are the gold standard for the diagnostic method. But the major disadvantages are that it is an invasive procedure and it will take the longer time to diagnosis. So the point of care diagnosis is play an important role in early diagnosis. So biomarkers which are present in the blood and saliva, which also have the good sensitivity and specificity rate that can diagnose this oral squamous cell carcinoma at early stage. So saliva-based diagnosis is also called a liquid biopsy. It has an immense potential as it is economical and non-invasive and easy to collect, and it contains the various biomarkers which can be detected by biosensors. So what is biosensors? It is an analytical device with your bioreceptors. Here the bioreceptors are enzymes, any antibodies, which recognizes the target. Here the target in our study is the biomarkers. So these bioreceptors which are present in this, when the target comes in contact with the bioreceptors, it will produce the biochemical response. This biochemical response is transferred, converted into the measurable signal with the help of the transducer. So transducer is the key component of the biosensor. There are already commercially available biosensors for glucose monitoring and pregnancy test and cholesterol monitoring also. So what is the working principle of biosensor is, if we put the analyte, that is any biofluids, the blood, saliva, or urine that contains the target, if it comes in contact with the bioreceptors, that is the sensitive coating layer which is present on the biosensor, it will produce the biochemical reactions. This reaction will change into that of the electrical signal with the help of the transducer. So that the key component of biosensor is the transducer. So what are the elements if we see in detail means, first is analyte, that is the substance of interest. Here it is the biomarker. Next is the biorecognition element. The most common bioreceptors we use are enzymes, antibodies, microorganisms, and tissue slices. When this bioreceptors and analytes comes in contact, it will produce the biological response. So this biological response is converted into the electrical signal with the help of the transducer. So the final result will be displayed in the electronic system by the means of quantitative or semi-quantitative analytical information. Like we can find the concentration and the presence or absence of analyte also. So what are biomarkers? Biomarkers are any biological molecule present in the blood or saliva that are the measurable indicators with the chemical nature of DNA, RNA, and protein that will provide the useful information about the state of health and disease of the body. Why the salivary biomarkers means it is usually easier to obtain and it is less technique sensitive when compared to blood biomarkers. So studies shows that for OSCP, the study shows that there are already more than 100 potential biomarkers are available. So the major disadvantage of salivary biomarkers is that the reliability and then validation of salivary biomarkers useful for the biosensors. So most approved studies, reliable biomarkers for OSCC screenings are microRNA fragments and pro-inflammatory and pro-angiogenic cytokines like interleukin-6, interleukin-8, and tumor necrosis factor alpha. They have the sensitivity and specificity of 91% from distinguishing OSCC from controls. Another one is salivary transferrin, which also have the sensitivity and specificity of 95%. Next is CYFRA, which is the cytokeratin. So biosensor, how they detected means for the first time, cytokeratin fragment biomarker, they have determined the unprocessed human salivary sample. So final result also they obtained. So this is a picture showing the microfluid chip containing electrode. When the saliva is placed, it will produce the biochemical reaction. And then we can find the result using the graph. In the recent times, we can use that biosensor, we can attach to the smartphones also, we can find the result in that. This is the actual display meter. We can find it in the analyzer. So to conclude, the traditional method for finding biomarkers are the PCR and the ELISA, but their major disadvantages are time consuming and it is expensive. But biosensors are rapid, inexpensive, and easy way to detect, and it has the same specificity and sensitivity as traditional methods. So with the rapid advancement of biosensor-based test technologies, yearly cancer screening may enter a new age and significantly improving the therapy outcomes and patient survival. Thank you.
Ma'am.
These are my
Now
references.
it's time for the discussion. Over to you, Dr. Sara Arvind.
So, which is the common biomarker that is used?
That is a cytokeratin fragment, cytokeratin 19, the fragment of cytokeratin fragment 21. That is most commonly approved and reliable salivary biomarker. So the first biosensor they designed, they're using the deduction of cytokeratin fragment 21.
Okay. Okay, that's all.
Over to you, Dr. Arun Mohan.
Now, like, is this one particular instrument in which we have to change the sensors or something? Because you mentioned different types of compounds like microRNAs and cytokeratin fragments and all. These are different.
No, actually, for one biomarker, particular electrode will be shared. Like for cytokeratin fragment 21, that electrode should be of the cytokeratin fragment antibody will be present. So that biochemical response will occur. So for each biomarker, there are different biosensors. So first they designed the biomarker for cytokeratin fragment 21. So it is first they were designed in 2019 only. It is an emerging technology. So still research is going on, like multiplexing of biomarkers we can do like that.
So we still need all the electrodes corresponding to each biomolecule.
Yes, sir. Yes, sir.
So the advantage of this process is because unlike the other molecular mechanisms, what is the main advantage of this is that the procedure time will be less.
Procedure time is also less. It is very comparatively cheaper when compared to PCR and ELISA also.
Okay.
It has the same sensitivity and specificity, sir.
Okay, thank you.
Thank you, sir. So as we are coming to the end of the session, I would like to confirm.
Ma'am, I lost the discussion
13.
mark. PG13 lost the discussion.
Judges, please note, PG13 would like to continue with this discussion. Over to you, Dr. Tara. Paper 13, please note, you can continue the discussion.
Can you go down to the last? Can you quickly scroll down the slides? I think the question, ma'am, we was discussing was regarding why, which all were the histopathological differential diagnosis, which all were there? Histopathological differential diagnosis before IHC was done.
So ameloblastoma, ameloblastoma is one of the
No malignancy was suspected. Did we suspect any malignancy in the histopathological differential diagnosis, or which all were the differential diagnosis?
So
I don't completely remember. I think you did IHC, right?
Yes, sir.
Which all markers did you use?
Cytokeratin and CD40.
Which cytokeratin?
Pan-cytokeratin.
Okay. So based on that, how did you reach the diagnosis of odontogenic carcinoma?
The CD14 is specific for odontogenic epithelium, and this we found that it's
CD14.
Yes, sir.
Okay.
So it's a CD80.
CD?
80.
Specific for odontogenic epithelium?
Yes, sir.
No, it's not. Did you use, you can go back, check the earlier slide, which
Sorry,
marker
sir.
did you use?
The CK90.
Do you use CK19? Okay. So it's based on that you reached the diagnosis that's an odontogenic carcinoma. So before that, did you know it was a malignancy? Was a question earlier. You have an answer. Have we lost Tara ma'am? Is she still online?
Yes, yes, I'm here. I'm here.
Oh, okay, okay. I thought you were not here. That's why I was asking the question.
No. He was not answering actually, so I thought I'll just leave.
You want to continue, ma'am?
No. Ah, yeah.
Yeah, thank you, judges. So as we are ending the session, like, may I know the confirmed presence of PG paper 16? Okay, thank you, judges.
16 is not there, right?
No.
Okay, thank you. So shall I leave? Can I leave? No. What
A
is it?
certificate as a token of appreciation.
Oh, yeah.
Yeah, thank you. Thank you very much.
Thank you, sir. Now, can you all say one of the you're writing up the question?
Thank you. Thank you.
Yeah, thank you. Manjeji. Manjeji.
Good evening all. I confirm the presence of the participants. PG paper 41. If you can raise your hands, please do. PG paper 41. PG paper 42. Is PG paper 42 present? PG paper 43.
Yes, I'm present.
PG paper 44. PG paper 45. PG paper 46. PG paper 47.
Yes, ma'am, I am present. Yes, ma'am.
PG paper 48.
Yes, ma'am, I'm here.
Yeah.
PG paper 49.
Yeah.
PG paper 50.
Present.
PG paper 51. PG paper 52. Good evening all. Let's begin the session. Pushperi College of General Sciences is delighted to host the Kerala State 5th Annual Triple Conclave. Let's start the scientific presentation under the Department of Oral and Maxillofacial Pathology.
Starting with the postgraduate paper presentation. Now going on to session 5, hall 2, we invite the judges for the session. My privilege to invite Dr. Deepu George, And Dr. Deepak Pandya.
Dr. Deepak George, who is a professor and head of Department of Oral and Maxillofacial Pathology, Annu Dental College, Ernakulam, and Dr. Deepak Pandya, who is an assistant professor at Department of Oral and Maxillofacial Pathology, Savasa Dental College and Hospital of Chennai. We welcome new judges.
Now, let's proceed for the instructions. For paper presentation, you have 5 minutes. You will be given 30 seconds for screen sharing before the presentation. If your time exceeds more than 30 seconds, next candidate will be called on and you will be given a chance at the end. You will also be given a warning at the fourth minute, preceded by a final warning. I hope the instructions are all clear.
Now let's start the session. I would like to call PG paper 42. You will be given 30 seconds for screen sharing. PG paper 42 will be given 30 seconds for screen sharing. I would like to confirm the presence of PG paper 42.
Hello?
Hello?
Am I audible?
Yes, you're audible. Is it PG paper 42?
42.
Okay, you will be given 30 seconds for screen sharing.
Hello? Hello?
Yes.
My slides visible?
Yes, your slide is visible.
Okay. Can I start?
Yes, you
I
can
think you
start now.
can put in the presentation mode. Please put in the presentation mode.
Yeah, sure.
Your time starts now.
Okay. So good evening to one and all. So today I am here to present my case report on fibrous dysplasia involving right maxilla and mandible. So my patient named Shahir, 27 years old, reported with the chief complaint of swelling on upper back tooth region since 10 years. So he also has an RT of 8 years back, and also he was reported from a private dental clinic of the swelling, and the swelling was present since 10 years. On extraoral examination, we have found that swelling of size 4 to 4 centimeter noted on the right side of the face, which causes a deviation of the nose towards the left side, and it causes an overall.
Excuse me, doctor. The slides are not moving.
Hello.
The slides have not changed. It's just the first slide. It is not in the presentation mode, doctor.
Okay, wait.
Can you put it in the presentation mode? Is it possible?
Yeah, sure.
Yeah, just click on it. Yeah.
Okay.
It's not come. Okay, fine. You just have to make sure that slides are changing. Okay, fine.
Okay, I'll go on with this.
Yeah, you can continue.
Okay. So we can swelling of size 4 to 4 centimeter noted on the right side of face with deviation of the nose towards the left side, which overall causes an facial asymmetry. On intraoral examination, we have noted grossly decayed 1/6 and missing 1/1, which he lost during his accident. And we have also noted a swelling of size a swelling of size 2.5 into 1 centimeter in relation to 1.5, 1.6, and 1.4 region. on the OPG of the patient was taken, and here we can see a radiopic lesion on the right side of maxilla extending from 1.4 to 1.6 region near the maxillary tuberosity, and also it is anteriorly it is extending from 1.4 to posteriorly up to the maxillary tuberosity. Superiorly it is extending up to the floor of the orbital wall, and also a mixed radiolucent area extending from 4.4 to 4.7 tooth region also noted. So based on the radiographic and clinical examination, we came to the provisional diagnosis of fibrous dysplasia. We also consider ossifying fibroma, Paget's, and condensing osteitis as the differential diagnosis. But in the case of condensing osteitis, it occurs during an infection. But here, no infection and no pain or tenderness is present. So the patient had undergone surgery, and we received 2 bottles of formal fixed hard tissue specimen. The bottle 1 maxilla and bottle 2 mandible. And hello. Hello. Hello.
It's okay.
Yeah, others please mute. Other participants, can you please mute?
Okay. The largest bit was measuring 1 into 1 into 1.1 centimeter, and smallest bit measuring 0.4 to 0.4 to 3 centimeter in size. So under 10x, we can here see a slender bony trabeculae arranged in uniform pattern, and also the intervening connective tissue appears cellular and shows numerous fibroblasts.
PG51, PG51. That person, can you please mute?
Because you will be presenting, na.
PG51, can you please mute?
You can't write your own name, na. You have to join meeting by some name.
Organizers, can you ask those people to please mute?
This as a name. You can't join it as a name.
Organizers, can you please ask those people to mute? Like, you know,
Yes, sir. Yes, sir. We are working.
At 42 is presenting.
PG paper 51, please mute.
I think 42 is presenting. But the background actually, background is okay.
Can I continue?
You have to fill in the background. Yes,
yeah,
hello?
please continue. Please continue.
Yeah, here we can see a irregular slender bony trabeculae arranged in uniform pattern, which shows a typical Chinese letter appearance. And here also we can see intervening connective tissue appears cellular and shows numerous fibroblasts. Under 40x, we can see connective tissue and plump fibroblast, and we can see oven bone and with the cells without an osteoid. So we come to diagnosis of fibrous dysplasia. Discussion. Fibrous dysplasia is actually a hematoma. So hematomas are actually benign growth made up of abnormal mixture of cells and tissues normally found in area of the body where the growth occurs.
You have 1 more minute.
Hello. Okay. Fibrous dysplasia is an uncommon non-hereditary skeletal development anomaly where the normal bone is replaced by an excessive proliferation of cell and fibrous tissue. And also it is caused due to the mutation of GNAS gene. And also we have 2 types of fibrous dysplasia, the monostotic and the polystotic form. And we also have the craniofacial fibrous dysplasia. The common bones involved are maxilla, mandible, and the less common bones involve ethmoid, sphenoid, frontal, and temporal bones. So the thickened bone shows expansion, thickening, and sclerosis. And the radiograph, a typical ground glass pattern is seen. Historically, fibrous dysplasia replaces normal bone with cellular fibrous tissue containing irregular shaped bony trabeculae. The trabeculae consists of immature non-laminar oven bone without osteoid rims or osteoblastic tissues. The trabecular arrangement has been compared to the appearance of Chinese fractures. Fibrous dysplasia jaw may exhibit varying amount of spherical and amorphous calcification. And these are my reference. Thank you for your patient listening.
Now it's time for the discussion. Over to you, Dr. Deepu George.
I think it was a nice presentation. Can you hear me? Yeah. It's a nice presentation. So you had both the lesion in the maxilla and the mandible, am I right?
Yeah.
So both showed the same kind of features, am I right? Like same
The patient
histology.
actually reported with the swelling in maxilla, but the radiographic examination, we found that the mandible also has a similar lesion.
So you had taken biopsy from the mandible also?
Both.
Okay, fine. So why didn't you consider, since there was a decayed teeth in the maxilla and the swelling was near to it, why didn't you consider the possibility of sclerosing osteomyelitis as your differential diagnosis?
Since there was no pain or tenderness, so we was actually report from another clinic.
Okay.
So, and no pain or tenderness associated is there.
So you have given the diagnosis as fibrous dysplasia. So what subtype of fibrous dysplasia would you consider this as to complete your diagnosis?
Polystotic fibrous dysplasia.
So did the patient had any lesions in any other part of the bone?
No.
So why
only maxilla and mandible.
So why don't you consider it as craniofacial fibrous dysplasia?
Okay, sir.
I think that will be more appropriate.
Okay, sir.
Okay. Anyway, it was a nice presentation.
Thank you, sir.
Yeah.
Thank you, sir. Now over to you, Dr. Deepak Pandya.
What is the main difference? Would you like to tell that? What is the main difference between fibrous dysplasia and ossifying fibroma histologically?
Yes, both appears to be similar, but here it is not the fibrous dysplasia has no inherent changes.
Sorry?
And also the location of the
location means main histological difference, which will you see in radiographs also, clinically also, and histologically also. All three, you can see the same thing. What is the main difference between ossifying fibroma and fibrous dysplasia? I think you mentioned somewhere in the discussion also, I think.
Actually, I think I mixed out that.
Yeah. So that difference, and why not this? The mandibular lesion was in the periapical region of the molars, right?
Yeah, premolars and molars.
Yeah. Why didn't you consider cementoceous dysplasia? Those molars and premolars, they were vital, right?
Since there's no associated mobility of the teeth.
Mobility is not required to call it a cementoceous dysplasia, right? And the initial phase of cementoceous dysplasia will be radiolucent, like in the case which you showed. Why not cementoceous dysplasia for mandibular thing? Teeth were vital, right? Mandibular?
Yeah, not vital.
Non-vital, vital.
Non-vital. No pain.
No pain means non-vital. Okay, thank you.
Thank you, sir.
Thank you, judges.
Now, I would like to call upon piece of paper 43. Where confirm the question. Piece of paper 43.
Hello.
Yeah, you will be given 30 seconds for screen share. Are you PG paper 43?
Yes, I'm 43.
Yeah.
Can you see the presentation?
Yes, sir. Okay. Yeah, it's not moving.
That's still the old presentation that is there, am I right?
Ask 42 to stop sharing, then only 43 can share.
PG paper 42, can you please stop sharing your screen? PG paper 42. Sorry for the inconvenience.
Paper 43. Can you please start sharing the screen?
Can you see this?
Yes, sir.
Okay.
I'll get 30 seconds to arrange.
Can I start?
Yes, sir. Your time starts now.
Okay, thank you. Good afternoon, everyone. So my topic is forensic photography. So if we just look at the first thing, what is a photography? It is just like a language like English and French. It is a reliable means of communication, and it is also an unflinching eyewitness with total memory recall. It is the only way to document what the mind and the eye forget. Photography is useful to assess an object position and location and its relation with subject with respects to other objects, which is difficult or impossible to explain in its entirety. Now, forensic photography is an essential technique used in the field of forensic odontology that plays an important role in crime investigation as well as in the medico-legal issues, which is also known as crime scene photography. Okay, so the word photography is taken from Greek word photos, which meaning slide, and the graphos, which means write. This forensic photography was introduced in 1851 in Belgium the first time, and its advanced technology will come in 1870s onward. Photography is also useful in assess an object position and location and its relation with respects to other object, which is difficult in other case. Next is the principle and the procedures of forensic photography. The first one is securing the scene. After crime has been established, the scene should be secured as it is. Any relocation in the scene photographed will act as a wrong evidence. Now, evaluating conditions. Conditions such as light and weather should be evaluated, and the camera setting should be adjusted accordingly. Right? Third is the shooting the scene. The photographer should capture the entire scene using wide angle shots followed by the close-up shots to visualize the full scene to show relationship of the evidence to the overall scene. Now, photographing the victim. While photographing the victim, location, its injuries and condition of victim should be highlighted properly. Now, photographing the evidence which is present there. Photograph should be taken directly at the right angle, eliminating probable distance distortion for clear visualization, and each part of evidence should be photographed with the scale of signify size and without the scale to show relationship with the overall scene. Now, the placing evidence markers. First shot of entire crime scene is very essential to confirm that no one has altered the crime scene, and photographer should capture the scene with and without the evidence marker. Use of a spatial imaging techniques like green lights and colored filters should be used to detect fingerprints, bite marks, and the footprints. Now, these are the, while capturing, we have to keep few factors in the mind like shutter, aperture, and ISO standard, flash or external light sources, depth of field and exposure. We just see a little bit about these topics. Now, shutter, what does shutter means? Shutter determines the amount of a light time the light is allowed to fall on the digital sensor. As far as aperture is concerned, it is the size of lens opening that controls the brightness of light necessary to capture an image. We denote the aperture with the digit F, figure F. Now, camera ISO, it is an international standard with that indicates the sensitivity of the sensor, denoted by the numerical value. The depth of field, it is the amount of area. Hello.
PG51, please mute.
Now,
So you have one more here left.
okay. The depth of a field is the amount of area in the front and the behind the background area that comes in under this, right? Now, when we have done the photographic, then the documentation is a very important point. So what the point we have to keep in our mind is the photograph to be taken in daylight or the background of the light. Date and the scale of reference should be mentioned there. Identification of person which is photographed are important points. Establishing the authenticity. Two elements necessary to establish authenticity are: first is to record every process done from capturing the image to presentation in the court. And the second is to protect the captured image with brand to prove its authenticity. Then the next point is the chain of evidence. In chain of evidence procedure, origin, usage, storage, and processing of evidence with its integrity is clearly documented. Each step should be clearly mentioned in that. And storage of image should be in a cupboard with limited access, protecting photographic evidence. Photographs reserved in the computer should be protected with password and limited access.
Thank you, sir. Your time is up.
Thank you, sir.
Now it's time for a discussion. Over to you, Dr. Deepu.
44 हमारा ये है.
Hello.
Okay, doctor, it was a nice presentation. I think it was just a bird's eye view of like how photography can be used for forensic. But I think it was more of a generalized concept of how the photography should be done. And I think you could have gone a little bit more deeper into how specifically we can use it from the forensic scene examination. Anyway, it was a nice attempt. Good.
Thank you, sir. Over to you, Dr. Deepu.
No queries. It was nice.
Okay, thank you.
Thank you, judges.
Now, I would like to call upon PG paper 44.
Yes.
You will be given 30 seconds for your screen sharing.
Yes, yes.
Good evening, everybody. Should I start? Should I start?
So 1 minute, sir. I'm just sharing.
Your time starts now.
Oh, ma'am, please, can I get a minute? Okay.
Yeah, sure.
Okay. Is my screen visible?
Yes, your screen is visible.
Okay. Good afternoon to one and all. My participation number is PGP 44 and my topic is It's Not a Child Play and Institutional Review. So as we know, that pediatric pathologies is a complete different category of patients because they need a different handling right from diagnosis till the treatment plan. Hence, it is very necessary to be aware of the Sorry?
Ma'am, PG 44 was mine.
PG 44.
Yeah.
Okay, just a minute. I'll cross check.
So sorry, PG 44 is Dr. Chandani.
Yes, that's me.
No,
Yes,
ma'am. PG 44 was Dr. Abdullah Nasir. Dr. Chandani is PG 45.
Sorry, Dr. Abdullah Nasir is PG paper 42.
You have changed the order list, or I've got the list which I have got. It was mentioned that my ID number was PGP 44.
Sir, we'll take a minute for clarification.
You can cross check the list. There it is mentioned as PGP 44 is Dr. Abdullah Nasir.
Okay, can you just give us 1 minute for clarification?
Yeah. I've already shared my screen.
Can we move on to PG paper 45?
We'll give time at the end of the session.
We'll give time for PG paper 42 and 44 at the end of the session.
Okay, okay.
Okay.
Thank you.
Yes.
May I know the presence of PG paper 45?
45 on a minute.
PG paper 45, Dr. Vidya. PG paper 46?
Please confirm your presence.
PG paper 47?
Yes, ma'am, I'm present.
You will be given 30 seconds for your screen sharing.
Okay.
What about 44, ma'am?
Your turn will be in the end.
Is my slide visible?
Yes, your slide is visible.
Shall I start, ma'am?
Yes, ma'am, your time starts now.
Good evening, everyone present. And today's topic of presentation will be See the Unseen through the Mirror of Oral Cancer. In this mirror, we'll be highlighting the microRNA. So oral cancer, we know this causes the death. It positions 15th cause for leading to the death in worldwide, and it's also a 16th malignancy among the worldwide population. This oral cancer, it is a higher incidence seen in male than in the females, and there are various etiological factors which are involving in the development of oral cancer. The main key pattern will be the epigenetic modifications, which involves the hypermethylation of the promoter gene, and also post-translation and the transcriptional changes, and also histone modifications. Here, microRNA, it is a single-stranded small non-coding RNA which plays an important role, and it is of 18 to 25 nucleotides. It plays an important role in its cancer development, and in this topic, we'll be seeing the microRNA and their relation with the major risk factors which are causing the oral cancer. So the major risk factors, it can be divided into two: epigenetic alteration and also the environmental factors. The factors which are altering the epigenetic will be the betel quid chewing or tobacco chewing, alcohol consumption, diet and nutrition, mouthwashes, and also environmental factors includes the viral, fungal, and the bacterial infections, the occupational at the risk, and poor oral health. So there is a main connection between this miRNAs and their expression in these risk factors. So we can simply divide our carcinogenesis process into three, that is induction, proliferation, and metastasis. So in induction, especially in human papilloma virus, the lethal 7E, it is expressed in a lower amount, and in areca nut and in pan masala chewing, we can see the high expression of the microRNA 23A and 21 respectively. And in alcohol, the microRNA 375 will be expressed in higher amounts. And in proliferation, in smoking, we can see the microRNAs 31-5P and 944 are expressed in higher amounts. And in alcohol, the microRNA 30A and 934 expressed in higher amounts. And in human papilloma virus, there are innumerous number of microRNAs are involved in the proliferation, which helps the tumor cells to proliferate and also to migrate and also to invade, and they finally result in the metastasis. Especially in Epstein-Barr virus, we can see the higher expression of the BART1, and in human papilloma virus, we can see the expression of 550A and 35P. So these microRNAs, what's their role in this major risk factors will be, these microRNAs will be either acting as oncogenes, or they'll be suppressing the tumor suppressor genes, so that they'll be modulating, either upregulating or downregulating the mechanisms, the signaling pathways which are involved in the cell proliferation, apoptosis, cell differentiation, development, and etc. And these microRNAs are usually they are expressed in our saliva, the plasma, and serum. So we can use it as a earlier diagnostic marks. So to conclude, microRNAs, their altered expression in these major risk factors, helping us to use it as an early diagnosis and also use as a biomarker. And in especially in anti-cancerous treatment, we can target these microRNAs, and we can give a give the patient a better targeted therapy. And this is my reference. Thank you.
Okay, now let's move on to the discussion. Over to you, Dr. Deepu.
MicroRNA is something that is, I think, a lot of research is happening recently. Now, my question is like, how do you think like this microRNA really regulates the gene expression? What is the mechanism of gene expression regulation by the microRNA? How does it regulate the gene expression?
Sir, they play an important role in a term like gene silencing, sir. They'll be either they'll be inhibiting the transcription process of the ribosomes, or they'll be either breaking down the chains of the mRNA so that the protein it cannot be translated and the process it cannot be expressed.
So do you think like the like alcohol and HPV are a major risk factor for oral cancers?
Yes, sir. There are major risk factors in immunocompromised patients, and it will be more leading to the process of they will be affecting the process like apoptosis, cell proliferations, and they'll be leading to DNA damages and result in the oral cancers.
So actually, HPV actually affects the oropharyngeal cancers. That is really the tonsillar cancers, not the oral cancers. And alcohol is not a main factor. It is just a cofactor along with other tobacco usage and all. So definitely these, how do you expect to target these microRNAs, and like, how are you planning to do that? Like, what is a methodology, what you're planning to do for that? You said you're going to target these microRNAs, am I right?
Yes, sir. Yes.
Yeah. So how do you propose to do that?
Sir, actually, it's a review article, sir.
Okay.
I'll read about it, sir.
Yeah,
how to target those DNA.
Anyway, I think it's something that an area that that need more exploration, and I think it's an area where a lot of research is being conducted. I think it's a good attempt. Okay, good.
Okay, sir. Thank you, sir.
Thank you, sir. Now over to Dr. Deepu.
Can you tell me, is there any role of HPV in oral epithelial dysplasias? We were concentrating more on HPV. It was there in initiation, metastasis.
Yes, sir.
So is there any role of HPV in oral epithelial dysplasias? Because that is the stage before cancer, right?
Yes, sir.
So is there anything like role in dysplasia, HPV?
They'll be suppressing the activity of P53, P21, and also DNA repair genes mechanism, sir. And
so you think that this molecular thing, you are going to like first is like I'm asking what you see in the your lab. You go for genetics first, or you go for HNE and all first?
HNE screening, sir.
Yeah. So can you like I'll tell. In latest WHO, like 2020 to 2023, they have included some term which is known as HPV-related oral epithelial dysplasia.
Okay.
So read about it. That is the latest thing which is going on. From oropharyngeal, they have moved to oral epithelial dysplasia, and that is the latest inclusion in OPMDs in latest WHO. Okay. So
okay, sir.
From 2017 to 2022, that update has been added.
Okay, sir. I'll see, sir.
Okay.
Thank you, sir.
Thank you, judges.
Now we'll call upon PG paper 48. PG paper 48 ready?
Hello, ma'am.
You'll be given 30 seconds for screen share.
Yeah, sure. Is that visible? Hello? Hello, ma'am.
Sir, you have screen. Yeah, yes, sir. Your presentation time starts now.
Okay, ma'am. Good evening, everyone.
In this topic, I'm going to discuss the poster entitled Stretch and Unstretch, which basically explains the link between yoga, stress, and oral cancer. The first one is yoga, which is derived from the Sanskrit word which means to unite or union, which has history of dawn from the civilizations of 5,000 years ago in India. And yoga has been completely used as an alternative medicine for many diseases and disorders. One have proven for its efficacy, and it's because it's mainly passionate through its physiology and function. Therefore, yoga is considered as a holistic approach to health by the Western world. Moving on to the oral cancer, as we all know, it is the sixth most common cancer in the world. And according to WHO, 40% of the oral cancers or in the population belong to the Southeast Asian countries, mainly like India, Pakistan, Bangladesh, and Sri Lanka, with more male predominance. Moving on to the third factor, which is stress. The state of stress is nothing but the affair which involves the demand of both mental as well as physical demand, which harms by the overwhelming of neural as well as adrenal glands. So when the stress is associated with the cancer, there is always a negative effect on the health due to the release of stress hormones, mainly cortisol, and this is associated with the progression of cancer. And this progression of cancer ultimately results in the negative influence of the oral health in general. Corticoid and glucocorticoid receptors, and this stimulates the synthesis of new proteins and cell growth. And recently, they have discovered the new culprit called the neurotrophic growth factor or NOG growth factor, which plays a role in the progression of oral cancer at the molecular level. These neurogrowth factor, what happens is there changes in the cellular environment causes the activation of inflammation mediators like TN factor, human necrosis factor alpha and interleukin 6, which stimulates the action of STAT3 and NF-kappa beta pathway, which is responsible for the controlling gene that controls the cell proliferation apoptosis. So there is a positive correlation with the increase in the tumor size. So it is associated with the oral cancer. Coming back to the yoga, there are 8 components of yoga quoted by Patanjali, but 3 main components are asana, which are postures, pranayama, which is the breathing exercise, and meditation, which is known as dhyan. When these breathing exercises are carried out by individuals, this creates a wave, a kind of wave in the brain, which is called the theta wave, and this theta wave have negative influence on the this neurotrophic growth factor. So it results in the decreases of carcinogenesis, which is in the formation of malignancy and its progression. So apart from its role in controlling the oral suggestion, there is also a preventive and palliative care. Its role in preventive and palliative care, like there is a reversal of epigenetic alterations, and when the patient suffers from cancer, they will be feeling low, they can't sleep well, they will be stressed again. So it can alleviate symptoms, reduce stress, and increases the physical, spiritual, and emotional wellness of the patient. So to conclude, this yoga, this breathing exercise, asanas, and meditation together will help the patient to hello.
One more minute.
To conclude, this asana, pranayama, and meditation, which ultimately results in the reduction of cancer progression and ultimately which helps improve the quality of life of the patient. And I have quoted my references at the bottom. Thank you.
Thank you, sir. And it's time for the discussion. Over to you, Dr. Deshi.
What is this theta wave like that you have mentioned here?
Yes, sir. Whenever there is an activity in the brain, the neurons conduct electricity. There will be this electricity is conducted as calculated as wave in form of waves, and there are different types of waves named like alpha, beta, gamma, delta, and theta, and each wave of particular frequency. And this theta wave is particularly reached when the patient is at the state of calm, there is meditation, dreamless sleep. Under these conditions, these states are produced. So these waves are called theta waves.
Okay, fine. Okay, definitely. I think yoga may have a role in reducing the stress, but have they done any clinical trials like to show that this can actually, like yoga can actually prevent cancer?
Yeah, sir. There's been mouse trials in mouse and in mouse model, and there is a study also conducted in patients to reduce the stress level by using yoga. But actually, I'm not aware of the path, but I've read the article. I'm not aware of the path.
Maybe I think it will have a lot of role in the palliative medicine because, like, people who have been
in palliative medicine, there was extensive role too.
Okay. Anyway, good.
Thank you, sir. And over to you, Dr. Deepak.
Yeah, I had only one query that sir already asked. Thank you. Theta wave I wanted to ask. Yeah, thank you.
Thank you.
Thank you, sir. Thank you.
I would like to call upon PGP 49.
Yes.
You will be given 30 seconds for your preparation.
Yeah, I'm ready.
You can start now.
Yeah, I'm presenting my short study on tooth decalcification with different decalcifying agents. Like here, I've in this graphical abstract, I've shown we have taken weight change and used different solutions for decalcification and try to establish weight loss percentage and the endpoint completion of decalcification. The demineralization is a rapidly growing and challenging aspect of various scientific disciplines, especially for forensic odontology and also for histopathological evaluation of the cellular structures of the teeth. For histological observations of the pulp, enamel, dentine, and cementum requires the removal of mineral components from the dentine and cementum. This technique involved in decalcification must preserve the hard tissue structures and dental soft tissue structures as close as to the living state. Dental pulp evaluation is often a part of research to study the effect of restorative materials on dental pulp and its biological response to new restorative materials. Examination of demineralized sections of other dental tissues and bone is required to study various pathological changes and developmental processes and stages. Also, various other soft tissue may get calcified and need decalcification following changes due to dystrophic and metastatic processes. In all these cases, the histopathologist is required to provide hard tissue biopsy reports after the process of decalcification. The aim of our study was to establish the endpoint of decalcification by observing weight changes in a tooth and this with the methodology we followed. We took freshly extracted, non-carious, non-iterated 64 human permanent teeth, including 16 of incisors, canines, premolars, and molars. And 4 chemical agents we used were 10% HNO3, 10% EDTA, weak acid, that is 5% tricarboxylic acid, and Von Ebner's solution. Demineralization of teeth was carried out at room temperature, and teeth were completely submerged in 200 ml of solution. The solution for a strong acid and 5% tricarboxylic acid was replaced every 24 hours, and for the EDTA every 5 days. The status of decalcification was evaluated with weight change, followed by chemical and radiographic confirmations methods. Periodic weight loss was weighed and weight loss percentage was calculated, and tooth was sectioned, stained, and examined under microscope for evaluation in each set interval of weight loss. In our study, 4 sets of teeth were evaluated for given percentage change in weight. We observed and recorded weight change at 40 to 50%, 50 to 60%, 60 to 70%, and 70 to 80%. Endpoint was also assessed radiographically with an RVG for confirmation. We also did chemical tests to confirm the completion of decalcification. Here in a radiograph, this is how an incomplete decalcification looks like. The surface has been decalcified, but the inner core of the tooth is still incomplete. These are the other radiographs in which we show the single rooted teeth where the completion of decalcification is evident on the radiograph. And these are the molars showing incomplete decalcification. So this is how we confirmed with the radiographs. The stain sections were observed under microscope and were graded from 1 to 4, and on the criteria of ease of sectioning, cytoplasmic staining, and nuclear staining. These are the histopathological images which we took for the H&E stained sections with EDTA. And results, it was observed as teeth were subjected to histopathological examination under microscope on selected criteria and different percentages of weight loss. Best results were obtained histologically at 70 to 80% of weight change of a
1 minute left.
Yeah, and statistical difference observed among different solutions for soft tissue integrity, leading to EDTA as best decalcifying agent. With this graph, we are trying to establish, and the conclusion of our study was that EDTA, if the time permits, is the best solution for decalcifying teeth, and it gives the best result histopathologically. These are my references. Thank you.
Thank you, sir. Now it's time for the discussion. Over to you, Dr. Deepu George.
I think this is a big challenge that we have in a histopathology lab. That is, after decalcification, the sections will not get stained properly, especially the nuclear stains, the hematoxylin stains will not get proper. And I think that is a big problem when it comes. Decalcification is not a problem because things will get decalcified. But after that, like getting a good like staining characteristics and examining the tissue becomes a big challenge. So I think the problem is not about examining the hard tissues. I think it will be more relevant if we can show the pictures of the pulp tissue, because that's the soft tissue part. That is where the maximum damage is going to be there when you do the decalcification. So I think the nitric acid, like even though 10% I feel like is a bit too much for nitric acid. Nitric acid, a very strong acid. What we usually use is a 5% nitric acid. And EDTA definitely is the best agent that's already been established. The only problem with the EDTA is it takes a long time, and the clinician expects the report by around, even if it's for decalcification, in 2 weeks time, he expects some kind of a report. So I think one factor that you need to consider here is about the time. You have not mentioned anything about the time that has taken for these specimens to get decalcified. I don't know
yes, sir, because I have to prepare it took around 5 days for HNO3, around 14 days for tricarboxylic acid, and for 3 months in EDTA.
Yeah, that's
but also, next to EDTA, if we tricarboxylic acid also gave good results.
Okay. So I think, did you show that any graph or anything regarding the time here? You show in the presentation about the time?
No, I haven't written that. Just to cut short the.
But I think that's an important factor, because nobody will wait for 3 months to get a report. No, they need
but we can consider tricarboxylic acid is also gives enough good results, and it completes in 14 days, sir.
Okay, fine. So the time is an important factor, and the soft tissue staining characteristics. How much the pulp is being affected? Like when the hard tissue part is okay. Did you get any pulp in the end, like after doing the decalcification?
With HNO3, it was decimated, but with the EDTA and tricarboxylic acid, staining was good enough.
I think like out of the whole thing, when you do all the comparisons, I think like one thing that we can do is actually the tricarboxylic acid, because that's not going to be as detrimental as HNO3, and it may not take as much time as EDTA. But again, I feel like HNO3 concentration that you use is a pretty high, and that may actually char the tissues, like especially the soft tissues. But anyway, it is a relevant study. I think it's very important when you do the standardization in your lab for your decalcification solutions. Anyway, good.
Thank you, sir. Thank you, sir.
Actually, sir told that the time in decalcification is very important, the time taken, because in now oral path we usually get now radical specimens. With that, they will submit the maxilla and the mandible, and the turnaround time which they give for excisional biopsy is 10 days. Okay, so in 10 days we can't wait for like 3 months thing. EDTA is out of the scene. Nitric acid does well, yes. But nitric acid you can use with formalin. So what I suggest is try once 8% nitric acid in 10% buffered formalin. You'll get excellent result. It will fix the tissue. It will not spoil the soft tissue, and you'll get fast results. 8% nitric acid in 10% buffered formalin. If that is not there, you can use 10% formic acid in distilled water, formic acid. These two are giving very good results because we have to give the report to the cancer patients. So we can't research, okay, you can take as much time as you want, but for the patient, we can't afford this much of time. So nitric acid, yes, 8% in formalin and formic acid, they give good results.
Yes, sir. Thank you, sir.
Yeah. Thank you.
Thank you, sir.
I would like to call upon PG paper 50 for the presentation. You'll be given 30 seconds for the presentation.
My screen can you please ask the participants to mute their mics? I think because of disturbance.
Can the other participants please mute?
Am I audible?
Yes, ma'am, you're audible.
Is my screen visible?
Yes, ma'am.
Okay, I'm ready. Shall I start the presentation?
You can start the presentation.
Good afternoon, everyone. I'm presenting a systematic review and meta-analysis on tumor-associated macrophages in prognosis of oral squamous cell carcinoma. Oral squamous cell carcinoma accounts over 90% of the malignant neoplasm in the oral cavity, and the prognosis of the oral squamous cell carcinoma patient is poor with 5-year survival rate. And the tumor-associated macrophages are the major cellular component in the tumor microenvironment of oral squamous cell carcinoma, with a bipolar role in disease progression depending upon their activation state of M1 and M2. And the classically activated M1 macrophages exhibit an anti-tumor activity, while an alternately activated macrophages exhibit a pro-tumor activity. The tumor-associated macrophages mostly resembles the phenotype of M2 macrophages and is expressed by CD68, CD163, and CD206. The aim and objective, the aim is to synthesize the available evidence of the literature about the prognostic potential of tumor-associated macrophages in the oral squamous cell carcinoma, and the objective is to evaluate the phenotype of tumor-associated macrophages in CD68, CD163, and CD206 expression in the oral squamous cell carcinoma. Prisma's statement and the Cochrane principles of systematic review were followed in the preparation of this meta-analysis. And only articles that evaluated the prognosis of oral squamous cell carcinoma using CD68, CD163, and 206 ISC studies, available data on at least one of these followings were included in the study, and the patient in treatment in vitro studies, animal model studies, articles with case reports, literature review, and language other than English were excluded from the study. A literature search was performed in PubMed, Google Scholar, and Embase database for articles published between 2010 to 2022. And these are the following search terms we have used for this meta-analysis. And we have designed a Prisma flowchart 2020, and the initial database search resulted in 1,638 articles, and out of this 1,262 articles were removed to the initial title analysis phase, and after the 2 phases of screening, it only remained 23 studies for the systematic review, and the 7 studies were included for the quantitative synthesis for meta-analysis. Moving on to the results. This is the overview of studies selected for the systematic review and meta-analysis. Geographically, 18 of the included studies were performed in Asian countries, followed by Europe and South America, and Japan and China shows the highest number of studies. In demographic data, the sample size ranged from 17 to 240, and the mean age of the patient was from 51 to 69 years. And the male shows higher incidence rate compared to female in most of the studies. And in clinical pathological data, the tongue was the most common site, followed by the buccal mucosa and floor of the mouth in most of the studies. And regarding the tumor characteristics, most of the samples were well differentiated, except in one study by Wang et al. Due to its high sample size. And regarding the tumor grading, most of the studies were in T1 to T2 with no regional lymph node and distant metastasis. In prognosis data, the 4 studies with higher expression of CD68 and CD163 in the tumor nest, and 3 studies with higher expression of CD68, CD163 and 206 in the tumor stroma, and 4 studies with a higher expression of CD163 in the invasive front of the tumor shows worse prognosis, and the 2 studies shows no association between the CD68 and the tumor outcome. And the 8 studies the 8 studies with the lymph node involvement shows poor outcome and reduced patient survival time. To increase the accuracy of the result, we have done a meta-analysis, and the meta-analysis are performed at a fixed effect model because of the low rate of heterogeneity. And among 23 studies, only 7 were included for this quantitative analysis because of these parameters were correlatable and they have a high effective sample size. And this forest plot here it shows each line represent one study, and the size of the red box indicate the weightage of the study. And a diamond at the bottom gives the overall effect of the estimate of the meta-analysis. And most of the studies, the diamond is on the right side, which favors the pooled result that the higher expression of CD163 tumor-associated macrophages correlate with the worse survival in the oral squamous cell carcinoma. In this meta-analysis, we demonstrated that the higher expression of CD163 tumor-associated macrophages, currently considered as an M2 preferable marker, is associated with poorly differentiated oral squamous cell carcinoma, positive lymph node, worse prognosis, and overall survival time. To be concluded, tumor-associated macrophages could be a reliable marker for assessing tumor aggressiveness, improved prognostication of oral squamous cell carcinoma, and a potential target for therapy. And these are all my references. Thank you.
Thank you, ma'am. It's time for the discussion. Over to you, Dr. Deepu.
Good afternoon, sir.
Yeah, I think it was a well-executed study. I'm very happy to see that. A very good meta-analysis. It's not an easy thing to do a meta-analysis. I hope you have done the work, am I right?
Yes, sir.
Okay, that's good. Can you, so definitely I think definitely tumor-associated macrophages should have a role in the prognosis. What can be the role of the real pathogenesis, and what can be the role played by this tumor-associated macrophage in the prognosis of oral cancer? What do you think the pathogenesis is?
So actually, the tumor-associated macrophages, they elicit they are stimulated by this chemotoxic factors by the stromal cells or the tumor cells, and they also release some factors like this vascular endothelial growth factors. They promote the angiogenesis and the chemokines and the colony stimulating factors. These all promote the tumor proliferation invasion.
Anyway, I think it's a good study. The only problem is we have to use immunohistochemistry to really assess the tumor-associated macrophages. It looks very similar to that of endothelial cells. So routinely, when we are trying to do it, it may not be very much feasible to do that, because usually what we see is this pattern of invasion, and the depth of invasion. All those kind of factors are the things that we can assess through H&E is something that is practically can be done in our routine setup. But I think definitely this has got a role, and maybe in future, the future therapy and all those kind of things may be useful. Anyway, it's a good study. Good.
Thank you.
Thank you, Dr. Deepu. Now over to you, Dr. Deepu.
Ma'am, I just liked the systematic review. It was so extensive and very nicely done. Few suggestions. One is instead of mean age, you had written one range. Make it mean age with standard deviation. When you are sending for publication, they will ask for standard deviation. Range you can put in the brackets. Another most important thing, you have not published it, right? So
no,
far?
sir, I'm on the work.
So before sending, you do one thing, register it in Prospero.
Yes, sir, we have.
Yeah, okay, so that is very important. Otherwise, not a good journal, they will not accept.
Yes,
otherwise, it's very nicely done. I liked it.
Thank you.
Thank you, judges. PG paper, do you want? PG, do you want PG paper 50? Please not share. You'll be given 30 seconds for your speech sharing.
Can I start the presentation?
Sorry? Yes, ma'am, your presentation is.
Yeah, you
Okay.
can start your presentation.
Yeah, my paper presentation topic is
Can you
glandular
just put it
odontogenic
in the
cyst, area
presentation mode?
ovarian.
Excuse me. Can you just put it in the presentation mode?
Yeah, it's in presentation mode, sir. Actually, it's slideshow.
Yeah.
My topic is glandular odontogenic cyst, area ovarian. So I'm going to the paper. Introduction. Glandular odontogenic cyst is a rare lesion that constitutes less than 1% of the odontogenic cyst. It was first mentioned by Tadayashi and Van Wyck. GOC presents at an average age of about 50 years with a peak in the 6th decade. GOC is found most frequently in the mandible and the lesions in the anterior mandible.
Change your slide.
Madam, the slides are not changing. Still in the first slide.
And it's not in slideshow mode also.
No, it's in slideshow. Still it's in slideshow.
Yeah.
In the beginning,
Please change the slide. Yeah.
So is it coming now? Introduction part. Is it coming?
Yes, yes.
Yeah. GOC presents at an average age of about 50 years with a peak in the 6th decade. GOC is found most frequently in the mandible and the lesions in the anterior mandible often close the midline in a characteristic symmetrical pattern. Most cases are symptomless and are discovered by chance on radiographs or present as a slowly expanding painless swelling. Radiographically, a well-defined radiolucency with cortical margins can be observed, and the recurrence rate is about 22%, which is comparable to OKC and Botryad odontogenic cyst. Due to the aggressive potential of glandular odontogenic cyst, precise diagnosis and prompt treatment are crucial for the favorable prognosis. Now, coming to the two cases which are reported in our Department of Oral Pathology. Case number 1, female patient of 72 years old, complaints of mild pain and swelling on the right lower front tooth region, and also discharged from the site about 1
Madam, slides are not moving. Slides have not changed.
It's not coming. I really changed the slide. Is it coming? Case history?
It's still an introduction.
Introduction, but I changed the slides actually.
Can you put it in slideshow?
Yeah, slideshare. It is in slideshare only. Slideshow. Is it coming now? Is it coming now?
Yeah, case history has come now.
Okay. So, history of presenting illness. The swelling was noted accidentally when she went for an upper tooth extraction. No relevant medical history, habit history, family history, or tax history. But for case 2, the patient is a male and he is 55-year-old, and the chief complaint was missing teeth in the upper teeth region. On history of presenting illness, the lesion was found accidentally while taking the OPG, and the lesion was found in the anterior mandible. He has a habit history of smoking for 30 years and no relevant medical history, family history, or drug history available. So these are the clinical examination photos. On the case one, we can see the female patient with the symmetry of the asymmetry is seen in the face, which there is a swelling that is extending from the body of the mandible to the anterior region, crossing the.
Madam,
slide is
slide
still
has
not
not changed.
changing.
Slide has not changed.
Okay. Why? I don't know what's the problem with this, but is it coming? Is
Yeah,
it
now
coming
it's come. Now it's come.
Clinical examination. There is a swelling that is extended from the right body of the mandible, crossing the midline, and intraorally we can see a bony hard swelling that is extending from the right body of the mandible to the parasymphysis region. There is a prominent buccal cortical plate expansion. We can see the areas edentulous also. And in the second case, we can see there is a swelling in the anterior mandible region, but the lesion is extending from the canine to canine region. And the patient has periodontal problems like generalized tensile recession, grade 1, grade 2 mobility of the teeth is observed, and there is only slight buccal cortical plate expansion. Is the next slide visible, sir? Is it visible? Intraoral examination slide?
Yes, yes, yes.
Yes, yes.
So these are the things that I explained. So on radiographic examination, we can see, is the slide coming? Radiograph? Did the slide came? Radiograph? I don't know.
No.
Okay, let me check. Okay, is it come now?
Yes, yes.
Okay. The first case, we can see the lesion is extending from the right body of the mandible, crossing. It's a well defined,
defines a unilocular radiolucency that is extending from the right body of the mandible, crossing the midline, and is extending up to the edentulous alveolar crest region and inferiorly 5 millimeters superior to the inferior bot of the mandible. And we can see in the next radiograph, that is the case number 2, the lesion is extending from the mesial aspect of 4-3 to 4-2, 4-1, 3-2, 3-1 areas with the displacement of the 3-2. And it is also unilocular radiolucency crossing the midline. And I'm going to next slide. So this is a radiograph. Next slide came. A CT image came.
No.
No.
Okay. Okay. What is it came now?
We have 1 minute left.
CT image. CT image came.
Yeah.
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 Okay. This is the case of the case 1, that we can see a well-defined lytic expansile cystic lesion in the right mandible, and we can see a prominent cortical expansion also. And clinical diagnosis. The next slide came. Is it came clinical diagnosis?
No.
Okay. So the clinical diagnosis were given for case 1, unicystic ameloblastoma, residual cyst with the differential diagnosis of metastasis and the occult primary. For the case number 2, lateral pudendal system, periapical cyst are given. Is the slide visible? Sir, is the slide visible?
Yes.
Okay. Okay. May I go to next slide? Is it visible? Growth specimen slide. Is it visible, sir?
No.
Okay.
The time is up.
Is it visible, sir?
Yeah.
Okay. So this is the growth specimen of the 2 cases. This is the fine needle
Time is
aspiration.
up. Thank you, ma'am. Now it's time for the discussion. Over to you, Dr. Deepu George.
Why did you consider occult metastasis as one of the differential diagnoses? And like your provisional diagnosis was radicular cyst or residual cyst or something for that, and then suddenly your differential diagnosis is for a metastatic lesion. So I think entirely different type of entirely different provisional diagnosis and a differential diagnosis. So
Yeah,
do you think that's a bit odd?
Yeah, actually the differential diagnosis was given from the oral surgery. They gave it as a metastasis from the occult primary. Maybe they are suspecting a lesion in the anterior mandible.
But anyway, when you are doing it, like you should put your differential diagnosis over there, because like you need to explain and you need to justify why you gave that as your differential diagnosis, no?
Yeah, actually that was not our differential diagnosis. It was from the Department of Surgery only. So I put it as the differential diagnosis.
But next time when you're doing, you should put yours on differential diagnosis, because if somebody asks you, you should be able to defend that differential diagnosis. No.
Okay. Okay.
Okay. Fine.
So,
another thing, another small thing, when you're putting that CT images and all, like if you just put all the sections together, like nobody will be able to appreciate the changes of the CTs.
Okay.
You put
Okay,
so
sir,
many
I understood.
together. Okay, film, put the whole film together.
Yeah.
Okay.
Okay, sir, I was not able to complete my presentation. Histopathology and everything is remaining. What should I
That's
do? I
okay,
should
that's
present it to another laptop or
it's fine. I think the time is over. I think. Okay.
Okay.
Thank you, sir. Now over to you, Dr. Deepak Pandya.
Ma'am, can you show me the histo pictures?
Yes, sir. Yes, sir. Definitely. There was a problem in my slideshow in my lab. That is why I'm not able to show, sir. I was not aware of that.
Okay.
These are the histopathology diagrams. There are so many histopathological diagrams. May I show you all those?
Next, slide 13. Can you show?
Is it visible now?
Yeah.
Yeah, I have to switch off from the slideshow mode to this other mode to show it again. That is the problem with this lab now.
Okay.
This is another picture, and this is the periodic acid shift stain sections that I did for this.
Okay.
Okay.
So what are the latest criteria for diagnosis of GOC? Latest.
Yes, sir.
Yes, sir.
2022-23, I'm asking.
Yeah, 2022, there is no such specifications. There are so many features that is peculiar to glandular odontogenesis as well as other odontogenesis like lateral periodontosis, glandular odontogenesis, and everything. There are so many features that is clubbing. So in that case, there is no peculiar features or nothing like that that is pathognomonic to this glandular odontogenesis. But more specific feature that is considered is hobnail cells.
Yeah. That is something they consider now, and the thickness of the epithelium,
Yeah.
the variable thickness and hobnailing. That is the latest WHO
Latest
follows. Otherwise, in 2017, how many criteria were there?
Kaplan et al. Suggested a criteria with 5 major features and 4 minor features, and
No,
Fowler et al. Also
I'm
suggested.
asking WHO.
WHO actually.
17, like I am the WHO person. Those all criteria are gone now. So everything which is actually being updated is WHO. So
Okay.
they asked 2017 how many? 10 are there. Okay, so they removed.
10 are there. Okay.
Yeah,
10.
that's what I was asking.
10 specific features are there.
Yeah.
Out of which 6, if more than 6 is there, then we can give a more towards glandular autonomy diagnosis.
Okay, thank you.
Thank you.
Thank you, judges.
Now, I would like to call upon paper 52 for the presentation. Paper 52, are you present? Okay, can we move on to paper 53 then? Is paper 53 there?
May I confirm the presence of PG paper 53? So we'll move on to PG paper 41.
Is PG paper 41%? Is PG paper 42 ready to present? Sorry, 43.
PG paper 53. May I know your presence?
Hello.
Is it PG
Hello?
paper 53?
Yeah, it's a 53.
Okay. You will be given 30 seconds for your screen sharing.
Okay. Is it visible? Hello? Is it
Yes, it's
visible?
visible. Yes, yes.
Okay. Can I start?
Yeah, you can start.
Okay. Good evening, everybody. Today, my topic is impacted at transmigrated mandibular canine, a case report. Altered tooth eruption is a failure of tooth eruption to emerge in an appropriate position. This may lead to the impaction, translocation, and transmigration. Impaction is defined as a failed eruption of a permanent tooth with a completely developed root, while the migration of the impacted tooth across the midline by more than half of its length is defined as the transmigration. An impacted tooth is occasionally migrates away from the site, but mainly it is within the same side of the arch. Left mandibular canine is more affected as compared to the right. Females are more commonly affected as compared to males, and unilateral cases are more seen as compared to the bilateral cases. Transmigrating teeth can cause root resorption, tipping, sensitivity, and discomfort to the patient. Case report. 17-year-old female reported to our institution with a swelling over the mandibular symphysis area with an occasional pain. On examination, palpation showed a firm consistency over the symphysis region of lower border of mandible. On further examination, we found that it is a retained A3 and the absence of right mandibular canine. Here's the picture of the patient showing the swelling on the left symphysis region. Now we can see the radiograph here. We can see the impacted right mandibular canine. It is located in the inferior border of the mandible. It is located below the root apex of the left mandibular canine, that is on the contralateral side. Here we can see a radiolucency that surrounds the crown and it is attached to the CJ of the crown. It mimics the dentigener cyst. Various treatment options were considered, but finally we decided to extract it considering its close proximity to the lower border of mandible. The extract tooth with the cystic capsule was sent for the histopathological examination. On histopathological examination, the features suggested dentigener cyst. Discussion. The impaction of canine is more commonly seen on the maxilla, but when it comes to transmigration, it is mostly seen in the mandible. In fact, the mandibular canine is the only tooth in which migration and transmigration has been documented. It is a very rare event and its incidence is 0.31%. This is the classification of the mandibular canine that transmigrate. It is given by the Mu Parafu M. And we are basically dealing with the type 2 in the further side. See, you can see the position of the type 2. Here, this type 2 we are dealing. It is a case of a type 2 transmigration. Etiology can be tumor, cyst, odontomas that's in the path of eruption. Other etiologies can be retained deciduous teeth, as in our case, crowding, spacing, supernumerary teeth, etc. Howard shows like the angle between the long axis of unerupted canine and mid-sagittal plane, if it is 25 to 30, then it will not cross the midline. But if this angle exceeds more than 50-degree angle, then the crossing the midline becomes the rule. Javed explained that the cause of transmigration is some abnormally strong eruption force that drives the canine through the dense symphysis. Elvedi suggested that transmigrated canines are usually associated with the cystic lesion, or maybe the cyst that is associated with the impacted canine that causing the transmigration. But we cannot completely say that this pathology is causing the transmigration. There are several treatment options like surgical removal, transplantation, orthodontic treatment, and plain observation. In our case, we went for the extraction because of its close proximity to the mandible, pathology associated with, and the patient was symptomatic. To conclude, transmigration of canine is a rare event with multiple etiologies. Presence of an over-retained mandibular deciduous canine or missing permanent mandibular canine should be clinically and radiographically investigated. It is a take-home message. Further documentation of this anomaly can lead to an improvement in the classification and better understanding of this condition. These are the references. Thank you.
Thank you, ma'am. Now it's time for the discussion. Over to you, Dr. Deepu.
So it was a nice presentation. So how do you differentiate between an enlarged follicular tissue and a dentigerous cyst?
So we can identify because according to the size, if the follicular, enlarged follicular, it is greater than the size of 3 to 5 mm, then it is a follicle, but it is greater, then it becomes the dentigerous cyst.
Will the histology be the same or different?
Histology will be different.
Different. How will it be different between enlarged follicular tissue and a dentigerous cyst? Will the lining epithelium change?
So the lining epithelium will be like ribbon-like lining epithelium with 2 to 3 squamous epithelium cells.
Will there be any difference between a follicular tissue that you see the reduced enamel epithelium and in a dentigerous cyst? Will there be any difference in the histology?
I don't know if it gets secondarily infected, then might be the difference.
Anyway, it was a nice presentation. Good.
No queries. It was nice.
Thank you.
is ready for discussion. PG paper 53 is ready for discussion.
Can you repeat, please?
PG paper 53.
Ma'am, can PG 44 present?
Yes, you can present.
Okay, I'm starting.
Having 30 seconds for discussion.
Okay, I'm
If
sharing.
you having, yeah.
Good evening, everybody. My topic is forensic photography, an essential aid in trial and judgment. Once a famous photographer, Smith, American photographer Smith in 1970 said, photographer is expected to produce something which will convey to the eye of the viewer an accurate reproduction of the scene as it would appear if the viewer actually saw the scene. So significance of photography, economical and provides evidence at faster rate. And crime scene photography became cutting edge in 1870s, and new technologies have expanded its use ever since. We can see forensic photography can serve as an excellent pre-episodic evidence. Supreme Court favors the use of digital camera for crime scene photography, and it has also asked the center to look into the suggestion that policemen using GPS-enabled digital cameras having a time stamp system should be bearing for taking photographs of crime scenes. The best method to collect and preserve evidence in forensic cases, especially dental identification, human abuse, and bite mark cases. A very important use of photography as evidence, and probably the most common one, is the use of the use as explanatory or illustrative evidence, and their purpose is to enable the jury to better understand the testimony of the witnesses. In criminal cases, also, photograph of the wound have been uniformly held to be admissible upon proper identification. Basic principles in photography: more than one victim subject should not be photographed in one roll of film. Each film roll should start with a facial view of the individual, and brightly lit backgrounds should be avoided. The profession has long replaced the fact that it is not an easy matter for even a well-trained mind to get a clear conception of a place or of a physical thing from a description given in words. So before photographs can be introduced in evidence, they must be properly identified and their accuracy must be shown. In cases where pictures are admitted in evidence to show the locality of an accident or to show the place where the homicide has been committed, then it should be shown that there was no material change in the place during the interval which elapsed between the time and the time the accident occurred or the homicide was committed and the time the place was photographed. Now coming to the exposure triangle, it is of a very important value in taking forensic photographs. The exposure values, which is the combination of aperture and shutter, and ISO rating is a measure of the digital sensor sensitivity to the light. These all three should be in the correct balance to take a proper forensic photographs. In all the photographs must be taken parallel to the plane and the lens must be perpendicular to the evidence. If the evidence is on the curved surface, palette, nose, etc., multiple shots should be taken and at least 3 photos of every finding should be taken. This is the life-size photo of a bite mark, which has to be taken along with the measuring scale. And next, coming to the types of forensic photograph, here we have got 3 photographs which has to be taken: overview, mid-range, and close-up. Overview covers the overall view of the crime scene, helps in understanding the relative position of the subject in the field. And mid-range is the...
you have 1 more minute left.
Okay, picture of the view, a picture where the piece of evidence is in reference to the other items. A close-up view is taken to show all the details which is concerned with the photograph. Coming to the drawbacks, these are the misrepresentation of the facts, in which we can see the Abraham Lincoln photo was morphed with the South Carolina politician John Calhoun's body. And here it is also in a morphed photograph which was taken in North Korea, showing the North Koreans in flood. Challenges in forensic photography: we have to obtain the consent, and poor quality of photographs should not be admitted. Overexposed or underexposed images, narrow window of time for recovering evidence, because we have to take the photographs very early, because then changes can occur. And then this has to be in cyber jurisprudence in India, and the authenticity of the digital evidence has to be considered.
Thanks, sir.
Okay, these are my references which I have taken.
Thank you, sir. Now it's time for the discussion. Over to you, Dr. Devi.
I think it was a good presentation, and I think you have gone into that forensic and the relevance of and the important points that has to be taken care when you're doing the forensic photography. It was a good presentation. Thank you.
Thank you, sir.
Thank you, sir. Now over to you, Dr. Devi.
It was nice.
Thank you, sir.
Can PG 45 present? PGP 45?
Yes, ma'am, you can proceed.
Okay, just a minute, I'll share my screen. Is my screen visible?
Yes.
Okay.
And your time starts now.
Okay. Good evening, everyone. My paper number is PGP 45, and my topic is "It's Not a Child's Play: An Institutional Review." In introduction, we know that pediatric pathologies is a complete different set of population that has to be dealt with, starting from diagnosis till the treatment plan. Hence, it is very important to be aware of the clinico-pathological trends, the incidence and the prevalences of the pediatric pathologies in our day-to-day life. This presentation might give an insight to us and also to the clinicians about the world of pathology among the kids and aid in diagnosis and treatment. So aim of my study is to have a look at the clinico-pathological trends of pediatric cases reported at our Institute and Department of Pathology in past 10 years, that is from 2013 to 2023. Method was retrieving the data from the archives of the department from 2013 to 23, then analyzing and then presenting the data. So the results that I have collected is, firstly, I came across around total 109 cases in past 10 years from the data available. Coming to the results, among them, there was a slight male predilection. There was not much difference, but just a slight male predilection. Then the location, so 37% cases were located in mandible, 32% in maxilla, and the rest were in the extraskeletal sites like the palate, lower lip, floor of the mouth, buccal mucosa, tongue, etc. Coming to the laterality, the highest laterality was seen in left and also in the midlines, and also there are some cases which we did not have the information. So, but then the right and the left were almost similar. There was not much significant difference. Coming to the age groups, so from 0 to 5 years, we had 2% of cases. From 6 to 10 years, we have 21% of cases, and 11 to 16 years occupied the most of the data, that is from 77% of all the counts. Coming to the histopathological diagnosis, firstly, I encountered a lots of variety while documenting this data, but the major part was occupied by cysts. Then that was followed by periapical granulomas, chronic infections, mucoceles were also on a higher part. And then I would just like to mention the variety that I came across. So it was cyst, dental follicle, hyperplastic dental follicle, fibrous epulis, fibrous dysplasias, juvenile ossifying fibromas, ameloblastomas, GOC mimickers, compound odontomes was also a common finding. Then AOT we also found, and giant cell tumor was also one of the cases. Peripheral giant cell tumor was also a case, and mucodense was also one of the common finding. Among the cysts, if we see, so there were a variety of cysts that we found. So from that, the highest was the inflammatory cyst, which was in hand with the periapical cyst, and that was followed by the radicular cyst, and also a few cases of traumatic bone cyst and aneurysmal bone cysts. Coming to the conclusion. So from whatever we just saw, there was a slight male predilection. The skeletal and extraskeletal distribution was almost similar, and the highest.
1 minute left.
Okay, and the highest age group that was involved was from 11 to 16 years. And the most common pathology we can say that that was encountered was also the cysts, and of course the variety of cysts. So just coming to my last slide, that is the take home message. So firstly, treating pediatric patients requires a very fast diagnosis and treatment plan as they are in a developing stage. So if we don't decide anything fast, it might affect the ongoing development or and create a lifelong impression of that thing. And for the same reason, and there has to be a database created for the pediatric patients, wherein all the cases that we come across, along with their radiographs and the clinical pictures and everything, should be maintained for easy referral and identification. Starting from diagnosis till the treatment plan, it will make the entire process easier, and it might also help contribute in demographics. Yes, thank you. Okay, thank you for your time.
Now it's time for the discussion. Over to you, Dr. Deepu George.
What was the age group that you included in your study?
So from 0 to 16, but the minimum age that I encountered was 1.6 years.
Okay, can you just show me that distribution of the diseases, like that particular?
Yes.
Yeah, in which I see something like ameloblastoma. Yeah, fine. Can you just show me the previous PPT, like previous this one? Okay, fine. I think I saw something. Anyway, I think it is a good cross-section study, and I think it gives us an idea about like what kind of different what do you call pathologies happen in this age group. Anyway, I think it's a good attempt. Good.
Okay, thank you, sir.
Thank you. Over to you, Dr. Deepak Pandya.
Yeah. Actually, you have just enlisted all the pathologies. I would suggest it to, if you have like segregated is which is reactive, neoplastic, cystic, like that. If you go, it will be, because these percentages, I can't even see which one is the maximum. And what is this GOC mimicker?
Sir, glandular odontogenic cyst mimicker.
What is that? I have never heard of it. Can you please tell me? GOC mimicker.
Sir, there is a variety of cyst that we call as glandular odontogenic cyst, and there are other number of cysts that can resemble it in the histopathological features. So that we call as GOC mimicker, like they mimic that cyst, but there are some features, the criteria that the other cysts have to fulfill to be called as GOC. But if they don't fulfill all the criteria, but few of them, so we name it as GOC mimicker.
But we don't need now all the criteria to call it as GOC, right? We need just two criteria. One is thickness, one is hobnailing. And any references for this? I've never actually came across to this term, GOC mimicker. And what is the last thing? Last thing is overlapping. After chronic infection, I can see one osteosarcoma. What is that? Before that, I can't see. After chronic,
Mesiodens.
no, after chronic infection.
Sir, chondroplastic osteosarcoma.
Okay, only one entity is there.
Yes, sir.
Okay, okay.
Doctor, 1 minute. I just wanted to ask you, what is this diffuse lopomatosis? There was one diagnosis over there. I was just confused. What was that? I never heard of it.
Lipomatosis, she means, I think, lipomatosis, sir.
Yeah, that's what I thought. Like,
Yes,
like,
sir. It is a spelling mistake.
Many were there, so I ignored. Epulis spelling,
Sir, yes, lots of mistakes. It was
dental
a
follicle,
little rush.
many things I actually ignored. So
I was actually searching whether there was any diagnosis like that.
Sir, I think she means lipomatosis only.
Yes, sir. Actually, there are lots of spelling mistakes. I made it a little rushed. Fault on my part. I'm so sorry.
Yeah, you should be careful when you're coming for a presentation. You should make sure all these kind of things are not there. And this overlapping, be careful next time, okay?
Yes. Okay, thank you, sir.
Thank you, judges.
This was 45, right?
Yes.
Oh, okay.
So coming to end, can I confirm presence of PG paper 46? PG paper 52. PG paper 41. Final PG paper 43 there.
Excuse
Thank
me.
you, judges.
Yeah. So there was no 41, 46, and 52, right?
There is no 41, 43.
43 is present.
43
Yes,
is there.
43 was there.
46.
41, 46, and 52.
52, right. Okay, thank you.
Yeah. Thank you, judges. Dr. Deepu George, we kindly receive the certificate as a token of appreciation.
Thank you. Thank you.
Thank you. Now, Dr. Deepak Pandya, kindly receive the certificate as our token of appreciation.
Yeah, thank you so much.
Thank you, sir. Thank you for all your valuable time. We are winding up the session.
Okay, thank you so much.
Hello? Hello?
Good evening, all. We'll begin session. Pushpiri College of Dental Science is delighted to host the Kerala State 5th Annual O Conclave. Let's start the scientific presentation under Department of Oral and Maxillofacial Pathology.
Starting with the faculty paper presentation, going on to session 8 and 2, we invite our judges for session. It's my privilege to invite Dr. Vindhya Savitri and Dr. Mahija.
Dr. Vindhya Savitri, who is a professor of Department of Oral and Maxillofacial Pathology, Amrita School of Dentistry, Edapalli, and Dr. Mahija Janardhanan, who is a professor Department of Oral and Maxillofacial Pathology, Amrita School of Dentistry, Edapalli. We welcome you, judges.
Now, let's proceed to the instructions. For paper presentation, you have 5 minutes. You'll be given 30 seconds for screen sharing before presentation. If time exceeds more than 30 seconds, next candidate will be called on and you will be given a chance at the end of the session. You will also be given a warning at the 4th minute, preceded by a final warning at the 5th minute. I hope the instructions are clear.
Now, let's start the session. I would like to call faculty paper 11. I repeat, faculty paper 11. You'll be given 30 seconds for your screen sharing.
Yes. Is my screen visible?
Sorry?
Yes.
Is my screen visible, ma'am?
Can you be a bit more louder?
Is my screen visible, ma'am?
Yes, sir, it is visible.
Yeah. Can I start?
Yes, sir,
Can I start? Yes.
Yes, sir.
Yes. A very good evening, respected chairpersons, organizers, and dear colleagues. So I'll be presenting faculty paper code 11, and my title is Application of State-of-the-Art In Silico Computational Biology Strategies to Demonstrate Mechanism of Oral Cancer Cell Death by Natural Peptide. So this is the overview of my presentation. I'll be speaking about a brief literature review. What was the work executed until now? What was the main aim objectives? And I'll focus and emphasize on the results and the original contributions with the research outcomes. So the specific problem in combating cancer is the continued proliferation of cells. We have seen that even after surgery, chemotherapy, and radiotherapy, the residual tumor cells begin to proliferate. And this is the main cause of recurrence. So alternate treatment therapies have been researched by many people. And we also know that conventional chemotherapy is a double-edged sword. In spite of killing some of the cancer cells, it also kills the normal cells of the body. It is very encouraging to know that 50% of the anti-cancer drugs that are available commercially are from naturally available sources. So this makes us look at more naturally available sources that can be commercially converted into drugs. It is a very long journey. So I came across something called as the earthworm coelomic fluid, which is the intestinal secretion of the earthworm. So I thought I could identify some biomolecules which have anti-cancer properties. Also, I wanted to make use of advanced computational biology techniques because always we've been stuck in an in vitro world and we have never explored what is in silico techniques, which many of the pharmacological companies do. So this will be the first step in establishing the inhibitory potential on oral cancer cells. So adjunctive therapies for oral cancer have been inadequately researched, and recent studies have shown that the earthworm coelomic fluid protein does have anti-cancer property on liver cancer cells and gastrointestinal and breast cancer cells. So I took up this project pertaining to oral cancer cells. So recent literature review shows the advent of artificial intelligence and machine learning, and there is in silico analysis where homology modeling, molecular docking, molecular dynamics, and energy assays have been made use of. So I wanted to amalgamate in silico simulation and in vitro studies to develop an anti-cancer therapy. So the work carried out so far is I did an initial assay using an MTT assay, and I tested 3 species of earthworms, and I found that the species Eudralis eugeniae showed good anti-cancer property on the oral cancer cell lines, that is SCC9. And even in a clonogenic assay, the Eudralis eugeniae coelomic fluid protein showed very good results. I also did a comet assay where the 3rd species, that is Perionyx excavatus, showed good anti-cancer properties. And the lactate dehydrogenase assay again showed Udrylis eugeniae to be superior. So we saw that about 70.77% and 85.13% of cell cycle arrest was found with Udrylis eugeniae, and a very good apoptosis induction effect. So I wanted to validate these in vitro techniques, and I used this artificial intelligence technique of computational biology. So with this, the aim was to identify and demonstrate the anti-cancer potential through in vitro and in silico techniques. I basically wanted to purify the protein, determine its anti-proliferative effect, to perform proteomic analysis, and to construct a homology model, and to validate this by further with wet lab techniques. So we isolated the protein using SDS gel, and protease activity was determined. We further purified it by zymography, and we cut out the 18 kilodalton band, which you can see here in lane 2. So we wanted to first prove that it doesn't have effect on the normal cells, for which we use the mouse fibroblast cell line, and the killing effect was not significant on normal cells. However, on the cancer cells, it showed a very good IC50 of 2.234.
Just 1 minute.
Okay, ma'am. And then we did a proteomic analysis through MALDI-TOF. MALDI-TOF was not sufficient, so we went ahead and did a complete amino acid sequencing, and we found this 18 kilodalton anti-cancer protein is made up of 158 amino acids. So we determined the whole amino acid sequence, and for the first time, we built a homology model using BLAST-P analysis. And we also did a molecular dynamic simulation because we wanted to see how the protein behaves in its in silico environment, not only static, but dynamically how it behaves. And then we downloaded the caspase-3 and caspase-8 receptor through the protein data bank, and we saw that our molecule binds very well with the caspase-3 and caspase-8 receptor, and it gives a lock and key configuration. So in other words, the anti-cancer protein model developed is binding with the caspase-3 and 8 receptor, which we assume will cause cell death. And these are the results.
So your time is up. Thank you, sir.
And we also validated through wet lab techniques.
Now it's time for the discussion.
Yes, ma'am.
Over to you, Dr. Mahija.
Yes, Dr. Dominic, it was a very good presentation. But I would say so much of information passed in a very short time. So we could we couldn't go from one step to another so fast. So there are certain areas which I'm not very clear with. So can you tell me how this ECF causes suppression of proliferation?
Yes, ma'am. So this ECF is upregulating caspase-3 and caspase-8. That is what we came across, ma'am. So this is, and it causes apoptosis through activation of caspase-3.
Can you please explain us the role of caspase-3 and caspase-8 in apoptosis?
Yes, ma'am. So these pathways are mainly the intrinsic and extrinsic pathways. Intrinsic through mitochondrial damage to the cell, and extrinsic through the trigger factors. So once these pathways are apoptoted, are activated, there is a cascade that happens through translation, and the nuclear factors are activated, and there is a causation of nuclear pores. That is the final step through which the cell undergoes apoptosis. So this we, yes, ma'am. So this was estimated through the cell cycle analysis.
Okay. Did you try it with the normal cell?
Yes, ma'am. We used the mouse fibroblast cell line, the normal, that is the 3T3L cells. And we found there was not significant cytotoxic effect, ma'am. Even at 80 microgram per ml, only 36% cytotoxicity was seen. Whereas with the SCC9, the ATCC cell line of tongue cancer that we purchased, we saw about 86% cytotoxicity, ma'am.
Okay, fine, good. Similar studies had been done previously?
Not on oral cancer, ma'am. This is the first study on oral cancer. And the similar studies already knew what was the protein existing. We were very blind. We isolated and we created the model and then did the in silico and then validated by wet lab analysis.
Okay, very good. I mean, it's a very innovative study, right?
Thank you, ma'am.
So you think you'll be able to translate it to clinical application, clinical level?
I have applied for funding for in vivo, ma'am, to be done on mice. So that is the intermediary step.
Oh, fine.
Yes,
animal studies.
Yes,
so this is funded project?
No, ma'am. This was the fourth and fifth objective of my PhD. This wasn't funded.
Fine.
So
okay, fine. Very good. Very
Thank
good.
you so much, ma'am. Thank you, ma'am.
Yes, Dr.
Vindhya.
Over to
Good
you,
evening, ma'am.
Dr. Vindhya.
Good evening. very impressive, and as ma'am said, very exhaustive. So it is rather difficult to keep up with you. Yeah, but I was thinking, how is that extraction of ECF done?
Yes, ma'am. We used alternate hot and cold method, ma'am. The earthworms are taken in a Petri dish, and when we showed them over a flame with a maximum temperature of only 40 degrees, and then alternately for the next 1 minute we have to transfer them over ice cubes. So this hot and cold alternating methods will make the use of the coelomic fluid. This can also be followed by mechanical agitation. So using both these techniques, there is also a ethyl alcohol method, but through the ethical clearance, we didn't want to harm the organism because ethyl alcohol would kill them. So even after mechanical agitation, also we collected the fluid and then we released the organisms back into its ecological.
So the whole study is over, right? The whole
study is over. This 4th and 5th objective is not yet published now.
Anyway, congratulations on your work. Rather exhaustive. Well done.
Thank you so much. Thank you.
All the best.
Thank you.
Thank you, judges.
Now I call upon the next faculty paper 12. Faculty paper 12. So you will be given 30 seconds for this screen share.
Is my screen visible?
Yes, ma'am.
Good evening, respected chairperson and colleagues. I am presenting faculty paper number 12, and the title for presentation is The Thematic Landscape of Lymphovascular Invasion in Oral Squamous Cell Carcinoma, which is considered to be a component of a bibliometric analysis. So to move ahead, we are all aware of the fact that oral squamous cell carcinoma is amongst the 10 most common malignancies, and it accounts for nearly 3 lakh new cases diagnosed annually worldwide. There can be a multitude of clinical presentations as has been depicted in these pictures. So the next question is, what is a thematic analysis? So thematic analysis is a qualitative data analysis, which process that involves delving through the data set, identifying patterns, systematically coding them, deriving the themes, and then creating a narrative. But here I want to emphasize that it is only a qualitative analysis depicted in statistical language. So this analysis is basically based upon the process of text mining, which involves a multitude of steps like text pre-processing, text transformations, feature selections, coding them, mining the data, evaluating, and then creating a narrative. So for this purpose, we identified the database through Medline through the advanced search using lymphovascular invasion in oral squamous cell carcinoma using the Boolean query and, so that all the keywords, so articles had these 2 keywords, and the keywords have been listed here on the right-hand side. We emphasize the co-occurrence analysis of the keywords in our study using the WAS-Viewer tool version 1.6.19, which examined the co-occurrence of keywords in our analysis. So a bibliometric thematic landscape or a map was created using the program's full text approach with all the keywords as the unit of analysis. And the map which was created identified 7 main clusters, which were later converted to themes for the identification of OSCC research, and the network visualization was grouped into clusters. So this is how the cluster was represented on a WAS viewer examination, where the colors of these circles representing as codes were identified using the default setting, and they were given respected colors based upon the items or the labels which were grouped into different categories. The categories are listed on the left-hand side of the panel. So the results of this thematic analysis indicates that we identified 7 main clusters, which were based upon a varying number of items ranging from 26 items to 2 items based in different clusters. And the clusters were identified based upon the different colors which have been listed here. So these clusters grouped different labels into the statements which have been mentioned at the bottom. That is, cluster 1 identified the causes and symptoms of OSCC. Cluster 2 identified treatment options and survival analysis. Cluster 3 identified the risk assessment models. Cluster 4 identified the statistical measures and the tumor burden of OSCC. Cluster 5 identified the prognostic impact and the lymph node metastasis using the lymphovascular invasion. Cluster 6 identified the ideal lymphovascular invasion features, and the clinical parameters were listed in cluster 7. So these clusters in total were 7 in number, which were grouped upon 104 items. The items here represent the keywords. So this graph illustrates the comparison of the weight, that is the links between these circular nodes, and the occurrences which are represented by the nodes or the circles in the picture. The graph emphasizes how labels which are measured by the links and occurrences are independent of each other, because they are not moving in the coherent manner. They are not going synchronous to each other, and this characteristically depicts the fact that they do not have a causal relationship. The occurrence of the keyword and their association with the another keyword is not associated directly. So to discuss the findings of this thematic analysis, there were 7 clusters observed in our analysis, which had a multi-dimensional approach. Okay, ma'am. And they depict several etiologic factors governing the prognosis of OSCC. And the tumor microenvironment cluster was identified using lymphovascular invasion as an important parameter, which is crucial to both local and distant metastasis in OSCC. And it can be even used as a parameter to determine the aggressiveness and to choose aggressive treatment approaches for OSCC. However, the majority of the clusters did not associate a direct correlation, suggesting that there was non-uniformity in OSCC research global focus. So the following slide represents the highlights of the present study. That is, it had a few limitations, that our research was only associated with the PubMed database, although we could have searched for other databases also, which we are planning in near future. And we only included English language literature in our analysis. However, the grouping of the studies based on topics suggested us that we need to stress upon tumor microenvironment and lymphovascular invasion, specifically in OSCC research. Thank you. These are my references. Thank you.
Now it's time for the discussion. Over to you, Dr. Vidya.
Yeah, good presentation. What is the topic of your presentation?
Ma'am, it was thematic analysis. I created a thematic landscape using the keywords lymphovascular invasion in oral squamous cell carcinoma.
Okay, and your conclusion was?
My conclusion states that we had done the thematic analysis, which is a qualitative research model for analyzing the research multidimensionality of OSCC research and how impactful is lymphovascular invasion research in OSCC. Because it is the prima facie, the tumor biology of OSCC is prima facie linked to the newer lymphangiogenesis, that is generation of new lymphatic vessels intratumorally and peritumorally. But here I came to the conclusion that not much of the research focus is in OSCC research is still directed to this main arena, and we are actually focusing in and around the main topic. We are not focusing directly on lymphovascular invasion presently. So I want to emphasize the fact that until and unless we work in this regard, this is one of the most important tumor microenvironment parameter which needs to be emphasized a lot.
Okay. Dr. Mahija?
Yeah, this is a systematic review, right?
It's not a systematic review, ma'am. The thematic analysis is a component of a bibliometric analysis, wherein meta-analysis is different from bibliometry because in meta-analysis, we are weighing the components statistically, how relevant they are. But
no. Like there's a lot of difference between systematic review and meta-analysis. In meta-analysis, you have the statistic component, you really measure. But coming to systematic review, this is what it is, I believe.
Right, ma'am. But in thematic analysis is not a component of systematic review, ma'am. It is a component of bibliometric analysis, where we are...
Can you just tell me, because we are not very clear with the results. Because you just told us what you have done, but what is the outcome?
The outcome states that, ma'am, here the map which is created suggests that we have emphasized, we have got the findings in the form of these 7 clusters, where you can clearly evaluate the fact that only 2 items listed in the analysis were actually related to lymphovascular invasion, whereas we are actually the research of the ongoing research or the pivot of research around OSCC focus is revolving around a multitude of other clinico-pathologic parameters. We are focusing on survival analysis. We are undergoing treatment analysis. We are focusing on treatment options available. We are going about the on and off about the symptoms of OSCC research, but actually we are not working on tumor microenvironment as much as we should.
No, so this is just an outline. Like you just you are pulling all those studies and telling which all areas they are focused, isn't
yes.
it?
And then I'm also correlating the strength of association between the studies, which is being represented by the graph here now. Here the circles represent the nodes, and these lines in between these nodes is representing the strength of association between them. So globally, worldwide, they are all focusing their research in and around the clinico-pathologic parameters, but not truly on the tumor microenvironment, in which lymphovascular invasion is of utmost importance in OSCC research, because currently—
So you are trying to say that the number of studies in tumor microenvironment is very minimal.
Yes, ma'am, truly.
Okay, you are just looked at squamous cell carcinoma, and you are just getting a bird's eye view on what are the areas of focus in oral squamous cell carcinoma, isn't it?
Truly, ma'am. And I want to state, and I want to emphasize one more point here, that, ma'am, the kind of thematic analysis which is usually employed, which is a component of bibliometric analysis, is not representative of it should not be made. It represents only a short-term projection of the research field, which is in the current scenario, ma'am. Because as and when more researchers are going to add, the map is going to change. So in near future, as in a month or two, more researchers are going to add. So this is not laying down a very long-term proposal, but then we can focus, if more and more studies are added into it, this map will change. So it provides a very short-term narrative of the current situation, qualitative keywords.
Is this a part of your PhD work or something?
Yes, ma'am, it is.
Yeah, I think it's a beginning of your review.
It is, yes, ma'am, it's a second step. One step, the systematic analysis, review and meta-analysis have already done. This is my second step.
Okay, fine. Yes. Good. All the very best for your PhD.
Thank you so much, ma'am. Thank you. Thank you, ma'am.
Now, I would like to call upon faculty paper 13. Can you speak? Faculty paper 13. May I confirm the presence of faculty paper 13? Okay, let's move on to faculty paper 14. Faculty paper 14.
Yeah, one second.
You'll be given
I'm having
30
a
seconds.
problem in sharing the screen.
Yeah, you'll be given 30 seconds for sharing your screen.
1 second. 1 second. I'm having some problem.
Is it paper 13 or 14?
It's 14.
14.
Faculty paper 14. Are you ready?
You'll be given 30 seconds for screen share.
Is it visible? Okay.
Yes. It's
okay. Good evening, chairpersons and my dear colleagues. Warm welcome to all of you present here. My code is faculty paper 14. I'm going to present my research topic on the title Prognostic Value of Preoperative Neutrophil Lymphocytic Ratio and Platelet Lymphocytic Ratio as Hematological Predictive Markers in Lymph Node Metastasis of Patients with Oral Squamous Cell Carcinoma. Coming to introduction, according to Globe 2025, most common tumors in India is breast cancer, followed by the cancer of the lip and the oral cavity, which stands second in the position. 90% of cases among oral cancer are oral squamous cell carcinoma. lymph node metastasis is one of the most significant prognostic factors of head and neck cancers. Preoperative platelet neutrophil lymphocytic scores serve as a non-invasive, inexpensive, and effective prognostic indicators for patients with oral squamous cell carcinoma. Coming to objective, my objective was to determine the prognostic value of preoperative neutrophil lymphocytic ratio and platelet lymphocytic ratio as hematological predictive markers in lymph node metastasis of patients with oral squamous cell carcinoma. Coming to methodology, it was a retrospective cohort study. The study duration was taken from 2016 to 2021. Around 146 oral squamous cell carcinoma were included, and the databases were derived from the electronic medical records backbone. Coming to methodology, neutrophil and lymphocytes were assessed from the complete blood count reports retrospectively from electronic medical records. Neutrophil lymphocytic ratio and platelet lymphocytic ratio was calculated by dividing neutrophil by lymphocytes and platelet by lymphocytes. Then the cutoff value for the NLR was 2.16 and 134.5 based on the ROC curve analysis. And then the ROC curve for oral survival was also constructed for neutrophil lymphocyte and platelet lymphocytic ratio. Coming to the results, this is a table showing the clinico-pathological characteristics. They were statistically using the chi-square. They were associated with in terms of NLR. And based on the chi-square analysis, we did not find any statistical significant relation for the neutrophil lymphocytic ratio with these clinico-pathological parameters. Again, when the preoperatively platelet lymphocytic ratio were statistically associated with the clinico-pathological factors, we found a good statistical association where the p-value was less than 0.05 in terms of perineural invasion, depth of invasion, lymph node metastasis, nodal classification, as well as TNM staging. Further, these neutrophil lymphocytic ratio and platelet lymphocytic ratio, where the ROC curve, that is receiver operating curve analysis, were conducted. And this is a graph which is showing the ROC curve for the NLR, and the cutoff value was 2.16. And for the PLR, the cutoff value were 142.25. And here also we can see there was a good significant association based on the ROC curve analysis. Further, overall survival were calculated by evaluating the time when the surgery was done and the time the patient died. And the cases where the patient died only due to the oral cancer were evaluated. Out of that, we found 78 patients were alive and 68 patients were dead. Further, the independent sample t-test was used to find out the association, and we got a good statistical significant association for the preoperative PLR. As we can see, the p-value is less than 0.05. And further, the ROC curve of were constructed for this overall survival for both the preoperative PLR and NLR. And we can see that we got a good results in terms of, and this is a reference line, and we can see the ROC curve for both NLR and PLR is going above the reference line. Coming to discussion, similar findings we got in accordance with the study conducted by Acharya et al. And Feng et al., which stated that preoperative PLR is directly associated with the nodal involvement status. Even Feng et al. Also stated preoperative PLR was superior to the preoperative NLR, and it can be used as a predictive factor for predicting lymph node metastasis. I conclude by saying preoperative PLR is directly associated with nodal involvement status, and preoperative PLR is more efficient in predicting the lymph node metastasis than NLR in oral squamous cell carcinoma. These are my references. Thank you.
Thank you, ma'am. Now it's time for the discussion. Over to you, Dr. Vidya.
Yeah, Doctor, a good study.
Thank you so much, ma'am.
So you have done a retrospective analysis of the blood counts of the patient, right?
Yes, ma'am. Yes. Complete blood count reports. From there, we use the preoperative neutrophil lymphocytic ratio and platelet lymphocytic ratio just before the surgery, ma'am. We took the preoperative, the lymph node, the complete blood counts.
So if it's, since it's a peripheral blood, can we say that, like, have you evaluated whether the patient has any other disease?
Yes, ma'am, exactly. The exclusion criteria for this study was the patients who are on corticosteroids, then the patient who had the inflammatory diseases, all those were excluded, ma'am. And even the chemotherapy and radiotherapy patients we have not included because it will interfere with these values, ma'am. blood count values, because these are also inflammatory, systemic inflammatory markers.
Then one more point, okay, one more point. You've said something about the survival, right?
Yes, ma'am. Yes.
Yeah. So, how long was the follow-up for?
Actually, we have since the study duration we have taken from 2016 to 2021. The last follow-up was done in the January, ma'am, January month, the last month. And out of that, we have out of 146 oral squamous cell carcinoma patient. As of now, we have got the alive, the count is 78 and 68 patients are dead.
So it's
So
not
still it is going on, ma'am, because
Yeah,
it's a part of my PhD. This is my first objective. And still it has to be continued, because we are also planning to take this ma'am, disease free survival also. For that, we need to complete the follow-up.
So what long period of follow-up are you planning?
Another 6 months will be the end point of the follow-up period, ma'am.
So for all the patients?
Yes, for all, no, not for all the patients, ma'am. Those who are alive, we are going to again follow up with the patients to know the survival status, ma'am. But till now, out of this 146 patient, we have got a good results for the preoperative platelet lymphocytic ratio, ma'am.
Okay, good.
And we have taken only the lymph node metastasis cases only, the excisional cases. So that somewhere preoperatively there is a lack of this thing, ma'am, gap. There is a gap in the literature.
So
Because
have you compared with the patients who do not have metastasis? Is there any difference with them?
Yes, ma'am. That's what when we did an association chi-square analysis we did, as well as man-Whitney test we did to see where doing with the metastasis positive and the negative, we got a good association for the positive patients, ma'am. The survival because these markers, when they are high, their survival the rate is less, ma'am, and we have got that. Since we are, again, it is an ongoing study, I have not included it, because again we have to see for even the disease free survival also, ma'am, to see the recurrence rates also.
All the best. Over to you.
Thank you so much, ma'am. Thank you so much.
You have taken specifically any site, or it is oral squamous cell carcinoma in general?
Oral squamous cell carcinoma, ma'am, irrespective of the site. We have all the sites, yeah, buccal mucosa, the tongue.
Okay, so was it, the values were based on the peripheral smear?
Yes, no, blood count, ma'am, complete blood count.
Complete blood count.
CBC.
CBC is based on smear, no? When you see neutrophil and lymphocyte, it's peripheral smear. But my problem here, what I felt is that when you compare neutrophil and lymphocyte, we put it in percentage, they are related. If neutrophil count is high, lymphocyte actually drops down, whereas platelet is completely different way of counting. So
yes,
won't
ma'am.
it affect your results?
It has not affected, ma'am. I have taken
taking a particular blood and counting because these two N/L ratio are related, because it's a component of once a neutrophil goes up. So don't you think that there will be some sort of bias in the results?
No, ma'am. This we have taken count at the initial, because neutrophil lymphocyte ratio was very easy to calculate. We had to just divide the neutrophil by lymphocyte. Whereas platelet lymphocytic ratio, we converted into an absolute. First, we converted into an absolute lymphocytic count. And then after we got that, then we divided the platelet by the lymphocyte. And then
I got it. My point is, when you say N/L, N and L are related. So when N goes high, when N becomes high, L has to go down. But whereas a platelet is completely independent of lymphocyte count. So how can you compare it that way? I do not know.
Ma'am, I will take thank you so much for your suggestion, ma'am. I will take this into a consideration, but when I have analyzed
because
the data,
I do not know, because I was thinking that way, because these two are related parameters, because we count in 100 cells.
Yes,
out
ma'am.
Of 100 cells, if 60% is neutrophil, it will be 40% lymphocyte, or 70% if the neutrophil.
Yeah, I agree. This is according of our knowledge. But when I collected the data for this patient, I have seen that when the neutrophil is high, need not be the lymphocytic ratio is down. Usually, according to the theory, it is like that, ma'am. But there are
in
cases
that
I have
case, you are
seen.
not doing the peripheral smear. In that case, you are not doing the peripheral. That's why I specifically asked if it is peripheral smear. In the CBC, we count total number of cells, out of which how many percentage of lymphocyte and how many percentage of neutrophil. So if that is done, that's why I asked you initially, are you using some other parameter for determining the neutrophil count and lymphocyte count? If it
No,
is
ma'am.
CBC, it is not.
I have
It is
taken just the complete blood count reports, ma'am. That too retrospective reports. From there, I have
I'm not very
calculated
clear
the
with
ratio.
that. I am not very clear with that. You need to read up on that, I believe.
Okay, ma'am. Thank you for your suggestions. I will
Yeah. You
look
can
into
just,
this, ma'am. Yeah.
it's a part of your PhD,
Yes,
you
ma'am.
said.
Yeah, yes, ma'am. This is one of the objective of my PhD.
Okay, fine. All the very best for your
Thank you so
PhD.
much, ma'am. Thank you so much.
Thank you, judges. Faculty paper 14, please stop sharing the screen.
This is 13?
No, it's 14. It was 14.
Oh, okay, fine.
Next is telephone, faculty paper 15 for presentation. Paper 15. Okay. Now let's move on to faculty paper 16.
15 is not there? No. Okay.
Faculty paper 16. I confirm your presence. You'll be given 30 seconds for the screen sharing.
Good evening, ma'am.
Other countries, please mute.
Good evening, ma'am. Can you see my screen? Can I start?
Yes, ma'am. Yes.
Okay. So my presentation name is the analysis of the elevated tissue nitric oxide in oral squamous cell carcinoma. So,
excuse me, can you put it in full screen mode?
Yeah.
It's not in full screen actually.
Is it?
No. And there are some
slideshow, please.
Yeah, slideshow. And there is some background noise from your side also. So please just see whether people around you.
Yes. Can you hear me now?
Yeah, your voice.
Yes.
It's not.
I will start
It's
with my
not a
presentation
slideshow now.
It's not in slideshow. As ma'am said, it's not in slideshow. So please.
I have put it on a slideshow, ma'am, but I don't know what's happening with the screen. But can I start with the presentation?
Yeah, you start. Let's see.
Nitric oxide is a diatomic molecule that has been implicated in tumor progression of oral squamous cell carcinoma. So, however, the mechanism of nitric oxide affecting the tumor growth and progression remains unknown. So, the tumor progression has been recently received considerable attention, and there is an increasing evidence of correlation of tumor biology and its behavior with the nitric oxide.
Are you moving your slide?
Yeah.
We are seeing only the first slide. I think you can close down the PowerPoint and do it again. I think you're not opening the same PowerPoint. Close it and do it again.
Ma'am, I'm not able to do this. I don't know what's happening.
Paper 16, do you want a question at the end of the session? So that you get more time.
Faculty paper 16.
Can you move on to faculty paper 17 then?
16 is not there?
Yes, ma'am, I'm here only, but I'm not able to share the screen.
Oh, fine. Okay, fine.
Faculty paper 16 will give you time at the end of the session then. Can we move on to 17 then?
Okay, fine.
Okay, so we are calling upon faculty paper 17 for the presentation. Faculty paper 17, are you ready with the presentation?
Hello.
Yes.
Am I audible?
Yes, ma'am, you're audible. So you'll be given 30 seconds for screen sharing.
Yes, ma'am. Is it fine? My screen is seen.
Yes, ma'am. You may please start.
1 minute, ma'am. Sorry. Is it visible, ma'am?
It is visible.
Okay.
You may start with the presentation.
Good evening. Glandular odontogenic cysts are uncommon jawbone cysts of